ચાલો. અચ્છા. इनकोर्स चार लो. Manish, shall I start? Okay, so I'll be talking about urethral stricture. So, as once you get MS surgery, uh, how important is urethral stricture for a surgeon? How much knowledge you think you should know? What are you expecting in this presentation? Do you have any thoughts about it? You listen something, I made it very, very general. So, but do you have something in your mind that you want to know the thing about urethral stricture, which is relevant or you think it's important? I don't think you get a long case or a short case of urethral stricture, okay? So, what is in your mind? So, what is in your mind? What do you want to listen from me? Okay, so this presentation is an overview of urethral stricture. Broad idea about urethral stricture. This, what I feel is relevant for you. But in case you want any additional information, I'm happy to give that. Okay, so I have included, although the title for my talk is stricture, can be anything, the etiology, management. So what I have done here is I'll talk a little bit about, because you are the people who are, managing trauma. I'm happy to give that. Okay. So urethral trauma. I have included, although few slides, the title for my talk today is overview of urethral stricture, etiology, it's more of a general. So what I have done here is I'll talk a little bit about, because you are the people who are managing trauma also. Okay, so just to revise the anatomy, okay. So although it's few slides about here, and then overview of urethral stricture. It's more of a general guideline. Okay, any backward is fine. This is so just to revise the anatomy, although it's this is written pendulous urethra or the penile urethra. Does it have a point? This is what? Quick. This part of the urethra is known as backward bulbar urethra. Okay. So if you see the length of pendulous urethra or the penile urethra is almost the same quick as this part of the urethra is known as. Then you have bulbar here. You can. Okay. This is the. So if you see the length of pendulous urethra or the penile urethra is almost the same. This is as the bulbar urethra. Then you can call this urethra as posterior urethra, and this urethra is the prostate, anterior urethra. So this is what is the prostatic urethra between the two? This is the bladder neck. Between anterior urethra and the posterior urethra. You can call this urethra as posterior urethra. This is what is this structure? This anterior urethra. So what is the difference between the two structure? This one between anterior urethra and the posterior urethra. Corpus spongiosum. So the anterior urethra is surrounded by corpus spongiosum. The posterior urethra is not surrounded. Okay. So technically urethral stricture. So the anterior urethra is surrounded by corpus because the stricture is nothing but spongiofibrosis. Not surrounded. See, okay, stricture is narrowing of the urethral stricture. Narrowing कैसे is only in the anterior urethra. जो उसका surrounding चीज है fibrosis होगी. Fibrosis. ठीक है. So your stricture is narrowing of the lumen. Spongiofibrosis. कैसे होगी? जब इस structure जो उसका surrounding चीज है उसमें अगर यहाँ पे इन्फ्लेमेशन हो जाए, तो स्ट्रक्चर इज नथिंग बट स्पॉन्जियोफाइब्रोसिस डाला, उससे ट्रॉमा हो गया. हाइड्रोजेनिक अगर यहाँ पे है स्ट्रक्चर की, अगर यहाँ पे स्ट्रक्चर में इन्फ्लेमेशन हो जाए, ट्रॉमा की वजह से, इन्फेक्शन की वजह से नैरो हो जाएगा. कैथेटर डाला, उससे ट्रॉमा हो गया. हाइड्रोजेनिक ओके अगर यहाँ पे है, पोस्टीरियर यूरेथ्रा दिस पोर्शन इज नॉट क्या होगा अगर फाइब्रोसिस होगी तो यूरेथ्रल ल्यूमेन नैरो हो जाएगा. यहाँ पे कैसे स्ट्रक्चर होते हैं? पोस्टीरियर यूरेथ्रल स्ट्रक्चर्स होते हैं कि नहीं? But posterior urethra, this portion is not surrounded by. I have only 15 minutes and I don't want to exceed my time. यहाँ पे कैसे स्ट्रक्चर होते हैं? Posterior urethral strictures होते हैं कि नहीं होते? होते हैं कैसे होते हैं
जल्दी
फ्रैक्चर आई हैव ओनली 15 मिनट्स एंड आई डोंट वांट टू एक्सीड माय पेल्विक फ्रैक्चर यूरेथ्रल डिस्ट्रैक्शन इंजरी हो जाती है होते हैं कि नहीं होते हैं कैसे होते हैं यहाँ पे पेल्विक फ्रैक्चर बहुत बिग सिम्फिसिस है ना प्यूबिक सिम्फिसिस के फ्रैक्चर्स यूरेथ्रल डिस्ट्रैक्शन इंजरी हो जाती है इससे प्रोस्टेट अटैच्ड जाता है अगर कंप्रेशन एंटेरोपोस्टीरियर होगा तो ये हिस्सा प्यूबिक चला जाएगा ये यहीं पे रहेगा ना पेल्विक फ्रैक्चर में ओके इससे प्रोस्टेट जाता है यूरेथ्रा अगर कंप्रेशन एंटेरोपोस्टीरियर होगा तो ये हिस्सा पीछे चला जाएगा ये यहीं पे रहेगा सो पोस्टीरियर यूरेथ्रा में क्या होता है सो टूट जाता है यूरेथ्रा स्ट्रक्चर होता है बट देखते होंगे आप लोग एसपीसी डाल देते होंगे ठीक है और क्या सिनेरियो है पोस्टीरियर यूरेथ्रा में क्या होता है स्ट्रक्चर होता है बट इट इज मोस्टली तो ट्रॉमा हो गया ठीक है और क्या सिनेरियो है जिसमें नैरोइंग हो सकती है यहाँ पे नैरोइंग हो सकती है जल्दी बताओ एक तो ट्रॉमा हो गया पेल्विक फ्रैक्चर एक अलग बीमारी है दूसरा कैसे यहाँ पे नैरोइंग हो सकती है पोस्ट यूआरपी ब्लैडर नेक कंट्रैक्चर बन सकता है पोस्ट रैडिकल एक अलग बीमारी है स्ट्रक्चर की बात हो रही है प्रोस्टेटेक्टमी जिसमें रैडिकल ब्लैडर नेक कर दिया ब्लैडर को पोस्ट रैडिकल अगर वहां पे स्ट्रक्चर बना तो जिसमें रैडिकल नैरोइंग हो गई कर दिया ब्लैडर को अगेन इट इज नैरोइंग मेम्ब्रेनस यूरेथ्रा ब्लैडर नेक के लेवल अगर वहां पे स्ट्रक्चर रैडिकल प्रोस्टेटेक्टमी कर दिया या रेडियोथेरेपी लगा प्रोस्टेट अगेन इट इज फिर वहां पे नैरोइंग हो गई ठीक है ब्लैडर नेक के लेवल पे या रैडिकल प्रोस्टेटेक्टमी कर दिया या रेडियोथेरेपी लगा प्रोस्टेट को फिर वहां पे नैरोइंग हो गई अगेन यू कैन से इट इज अ स्ट्रक्चर ओके गॉट इट okay okay so a few slides on trauma so how does the patient present okay so a few slides on trauma happens so how do the any injury how does the patient present तो क्या होगा अगर यूरेथ्रा में इंजरी होगी तो ब्लड कहां से निकलेगा यू हैव ब्लीडिंग से निकलेगा तो क्या होगा अगर यूरेथ्रा में इंजरी होगी तो ब्लड कहां से निकलेगा एंड मीएटस naturally if blood the patient is unable to urinate you can have a palpable bladder retention naturally if the patient is unable to urinate क्या करोगे जल्दी बताओ palpable bladder retention मिलेगा अगर ये सिनेरियो है पेशेंट बोल रहा है चोट लग गई पेरिनियम में फटाफट चलो एक मिनट अगर ये सिनेरियो है पेशेंट एक सिनेरियो तो बताया कि पेल्विक फ्रैक्चर हुआ यहाँ पे ट्रॉमा इंजरी सिनेरियो तो बताया कि पेल्विक फ्रैक्चर हुआ यहाँ पे ट्रॉमा इंजरी कुछ हो सकती है which type of injury will give rise to stricture in the anterior urethra which type of injury will give rise to stricture in the anterior urethra I can't I can't lip read lips आपके नहीं रीड कर पाऊंगा I can't lip read lips आपके नहीं रीड कर पाऊंगा है ना स्ट्रैडल इंजरी कहाँ होती है यहाँ पे होती है वो किसी ने धक्का दिया या गिर गया और उसके इंजरी स्क्रोटम और रेक्टम के बीच में हो एनस के बीच में ठीक है यहाँ पे कंप्रेस हो गया ठीक है किसी चीज पे गिरा साइकिल का जो बीच का डंडा होता है उस पे गिर गया साइकिल का जो बीच का डंडा होता है उस पे तो ट्रॉमा हो सकता है एंटीरियर यूरेथ्रा को तो ट्रॉमा हो सकता है एंटीरियर यूरेथ्रा को स्ट्रैडल इंजरी में क्या होगा यहाँ पे जब इंजरी होगी तो इसमें क्या होगा यहाँ पे जब इंजरी होगी बोन ऊपर है और प्यूबिक बोन ऊपर है और यहाँ से चोट लगी तो बोन अबव नीचे से इंजरी हुआ तो बोन अबव नीचे से इंजरी हुआ तो यूरेथ्रा दब गया बिटवीन दीस टू स्ट्रक्चर्स ओके सो व्हाट टू डू नहीं अगर ये है बस एसपीसीसी दे नहीं अगर ये है बस एसपीसीसी दे कर सकते हो नो वन विल से कि गलत किया एसपीसी कर लेकिन अगर you are working in a very good hospital you have all the facilities with you what will you do RGA perfect so you will do a RGU so scenarios so you can have injury scenarios partial injury so what you see here you see contrast entering you can see contrast there's extravasation also there's extravasation injury हुआ तो क्या होगा injury हुआ तो क्या होगा contrast वहां से leak करेगा extravasation okay but at the same time contrast is also entering into the urinary इस scenario में आप guide wire डाल के confirm करके ठीक है but if you have this type of injury the contrast doesn't enter into the bladder okay this is complete injury there's no point trying to place a catheter here ठीक है do a straight away okay So these are the three things that can be done. Catheterization if there is partial injury, catheterization if there is partial injury, SPC if there is partial or complete injury. And very rarely the literature is very rare, but you can do realignment. Controversial, but you can do realignment. You pass a flexible cystoscope from below and try to align the from below and try to align the urethras. Okay. So as I said, stricture is. So as I said, we use this word urethral stricture. Typically we use this word urethral stricture for anterior urethra only. And urethral stricture by definition is nothing but spongiofibrosis. ये बात समझ में आ गई? And these are the various etiologies. Trauma is very common. Iatrogenic, as I said, catheterization, cystoscopy, all these are risk factors for urethral stricture because you are manipulating the urethra. Then you can have lichenoclerosis. Then you can have lichenoclerosis. देखते होंगे पेनिस पे कभी-कभी सफेद टाइप का सफेद है. देखते होंगे पेनिस पे कभी-कभी सफेद. The patient doesn't tell you anything. And idiopathic. Many times कोई infection नहीं हुआ, कोई चोट नहीं लगी, कोई catheter नहीं डाला, तब भी stricture. And this is a very infection नहीं हुआ, कोई चोट नहीं लगी, कोई catheter नहीं डाला, okay? तब भी stricture. And this is so when you a patient comes to you with thinning of a stream. When you are suspecting stricture in a particular patient, what do you do? How do you evaluate? So what do you do? How do you evaluate? We have these things in our mind. Is there the height and length? The urethra, male urethra is about 20 to 22 centimeters in length. You saw the first image, pendulous urethra, bulbous urethra. So it's fairly long. तो कितना लंबा है? कहाँ पे है? Bulb में है? Penile urethra में है? What is the length of the stricture? You do not know. चाहे 1 सेंटीमीटर का हो, चाहे 10 सेंटीमीटर का हो, symptoms will remain the same. है ना? So you do not know. So you stricture for this history is very. Bladder dysfunction तो नहीं है, hydroureteronephrosis तो नहीं develop हो रही है, ठीक है? ये सब चीजें, creatinine तो नहीं बढ़ गया, renal failure में तो नहीं चला गया, all these things, okay? So what do? You do a urea creatinine, you do a uroflow, and then radiology. Sonography for the upper tracts and cystoscopy, all these things can be done. Uroflowmetry, I am sure you have seen these graphs. This is a normal pattern, bell-shaped. This happens in BPH. The flow rate reduces, the bell becomes a bit flattened, but this is a stricture. This is the plateau type of pattern that you get. This is uroflowmetry. Because RGU is an invasive test, it's an uncomfortable test. You are pushing contrast through the meatus. Okay, so it's not a test that, at least, you know, supposing I have a poor stream and someone tells you to do, you get a uroflowmetry first. If the pattern is something like this, the patient is 50 years old or borderline BPH also, you are thinking in terms of BPH also. You are thinking in terms of a stricture also. A 70-year-old man comes with poor flow, you diagnose as BPH first. If a youngish man, 20, 30 years old, comes to you with poor flow, you diagnose a stricture first. Okay? So uroflowmetry gives you a very, very good idea. The pattern changes. Okay? The pattern changes. Here it is. Because there is fibrosis, so you have a fixed stream. Okay? I hope you are understanding. Okay? In case you are not, please interrupt and I'll clarify things. Okay? So this is how you do a RG. Okay? This is the MCU. You fill the contrast, supposing the patient has an SPC, especially if the patient is on SPC, suprapubic catheter, always give you, okay? If the patient is not on SPC, then it's a slightly difficult thing to get a MCU. What is the difference between MCU and a RGU? For what images RGU is better, for what structures MCU is better? जल्दी जल्दी बताओ. See, अगर आपको ऊपर से अगर ना हियर द पेशेंट इज वॉइडिंग, तो यू सी द पोस्टीरियर यूरेथ्रा बेटर, ठीक है. और इन केस when you are putting contrast here, you see posterior urethra is not seen well, you see the anterior urethra. अगर आप यहाँ डालोगे तो naturally ये portion ज़्यादा अच्छा दिखेगा. अगर आप have information the proximal extent of the stricture, do a MCU. Retrograde study will give you better idea about the anterior urethra. Okay. They have already, the bell is ringing. So this is the bony landmark is, this is the external, ये pubic जो ramus है इसके जो lower border पे, this is the external sphincter, ठीक है. Here is the stricture. So I'll just skip it. You can do ultrasound also. I'll just tell you the philosophy of management. These are the various options. I'm sure you know, you have heard about it. You can dilate, you can do optical internal urethrotomy, the endoscopic treatment. Then you have option of anastomotic urethroplasty, substitution urethroplasty. That can be, you can place a graft. So for, I think this is the most important slide. In bulbar stricture, you have both the options, excision and primary anastomosis, and you can do substitution urethroplasty. Penile stricture, can you do excision primary anastomosis? ये ऑप्शन इसमें नहीं दे रखा है, क्यों? अगर मान लो छोटा सा स्ट्रक्चर है, आप लोग बावल को तो खूब एनास्टोमोस करते हो, ठीक है ना, काटा, जो हिस्सा खराब है उसको काटा. सर्जन्स को तो यही है, कुछ खराब है काटो, हटाओ, और जो नॉर्मल हेल्दी चीज है उसको जोड़ दो, ठीक है. बल्बर यूरेथ्रा में लिखा हुआ है, पेनाइल में नहीं लिखा है. क्या प्रॉब्लम है, क्यों नहीं लिखा है? जल्दी जल्दी बताओ, बहुत सिंपल चीजें पूछ रहा हूं आपसे. चल नहीं रहा शायद, बंद कर दिया. तो पेनाइल यूरेथ्रा में अगर आपने यूरेथ्रा को काट दिया, अगर 1 सेंटीमीटर भी काट दिया, उस समय तो कोई कष्ट नहीं है, कर दोगे. लेकिन प्रॉब्लम होगी व्हेन द पेशेंट विल हैव इरेक्शन, देयर विल बी वेंट्रल कॉर्डी, छोटा हो जाएगा यूरेथ्रा नीचे से, ठीक है, वेंट्रल कॉर्डी. सो एक्सिजन एंड एनास्टोमोसिस नेवर डू इन पेनाइल यूरेथ्रा, इवन फॉर शॉर्ट स्ट्रक्चर्स. 5.5 मिलीमीटर का भी अगर स्ट्रक्चर है, अगर आपने काट के पैचुलेट करके एनास्टोमोस किया, कॉर्डी हो जाएगी, ठीक है. सो एनास्टोमोटिक यूरेथ्रोप्लास्टी इज ओनली फॉर बल्बस यूरेथ्रल स्ट्रक्चर. ओके. एक चीज होती है जिसमें दोनों ठीक है. तो एक्सिजन, छोटा सा स्ट्रक्चर अगर है तो एक्सिजन एनास्टोमोसिस कर सकते हैं. रीजन इज because the bulbar urethra is, it's a curved structure. If you remember the first slide, bulbar urethra जो था थोड़ा सा curved होता है, इसको straighten किया जा सकता है, 1-2 सेंटीमीटर काट सकते हैं और उसको join कर सकते हैं, ठीक है. This is how it is done. The problem is because you are excising, still there's little bit of penile shortening and there's a risk of erectile dysfunction, ठीक है. जब आप urethra काट देते हो, वैस्कुलैरिटी थोड़ी कॉम्प्रोमाइज होती है, इरेक्टाइल डिसफंक्शन का रिस्क रहता है, ठीक है. तो इसीलिए बहुत सारे मॉडिफिकेशंस डिस्क्राइब्ड हैं. आई विल नॉट टेल यू ऑल दीज थिंग्स. Then you can, if the stricture is long, you cannot anastomose more than 2 centimeters in length in the bulbar urethra, or you can take from the cheek, put it ventrally, dorsally, or wherever you want. This is the ventral graft, dorsal and all that. I think I'll stop here. In case you have anything to ask, you can ask me. So suspect stricture in younger patients. Get a uroflowmetry. It tells you whether the patient is having bladder outlet obstruction because of BPH or primary bladder neck obstruction in younger patients. If the get a SPC in situ, get a MCU, and depending on the length, the site of a stricture, pendulous में है तो substitution urethroplasty, बड़े में है तो anastomotic कर सकते हैं छोटे के लिए, अगर लंबा है तो वहाँ पे भी substitution urethroplasty, बक्कल ग्राफ ना होगा आपने. Thank you.
Thank you, sir, for your commenting on the ureteral picture. I would like to invite Professor Abbas, sir, for clarification of the sir.
The site and length, the urethra, male urethra is about 20 to 22 centimeters in length. You saw the first image, pendulous urethra, bulbous urethra, so it's fairly long. तो कितना लंबा है, कहाँ पे है, bulb में है, penile urethra में है, what is the length of his...
He is a professor in Department of General Surgery and he is a urologist and he is a very excellent teacher and a surgeon. So over to you, Abbas, sir, for your informative lecture. So again, I would like to invite Abbas, sir.
Okay.
He is a professor in Department of General Surgery and he is a
urology day today. So
and he is a very excellent teacher and a surgeon.
Enlightening talk, and you can say the very vast subject, stricture urethra, by Professor Apul Goel. So now I'm trying to cover another common clinical scenario. So I'm taking here like approach to case of lower urinary tract symptoms after LUTS. A very enlightening talk, and you can say the very vast subject is the emergency in general OPD. So the maximum number of cases you are going to encounter these clinical scenario. Common clinical scenario are going to encounter. So I'm taking here like approach to case of lower urinary tract symptoms, LUTS. So this is group of clinical attending as a in the emergency deviation general normal voiding. So the maximum number of cases you are going to encounter these. This is a common clinical scenario you are going to encounter. Normal bladder function. So means normally contractile bladder. That should contract just before and outlet should be relaxed, that in sphincter, and urethra, normal urethra. So if there is any abnormality in urethra, like a stricture urethra as we discussed, someone told BPH, and if there is abnormality in bladder function also, that may be because of neurogenic bladder, because of cystitis. So in all those cases, patient will present to you with lower urinary tract symptoms. So it is a very comprehensive, you can say, thing. So I am here taking in like in the just 15 minutes I am supposed to cover, will take reference of BPH only. Okay. Important causes, otherwise you know urinary tract infection is very common cause. Then stricture urethra, neurogenic bladder, bladder tumor, bladder stone, carcinoma prostate. So these are common scenarios which you, and in children definitely posturethral wall and metal stenosis in any age group. So we encounter all these clinical scenarios and you should be ready to. Apart from these important clinical diagnosis, you can say that ailments, there may be simple comorbid conditions which may be responsible for solely lower urinary tract symptoms, or they can aggravate lower urinary tract symptoms. Like otherwise, somehow a person had a compensated bladder function, but in these scenarios, they will present with lower urinary, like general health debility, like patient is otherwise sick, non-ambulatory, patient can start, like patient is not able to move, patient can start having lower urinary tract symptoms also. Dietary and fluid intake, sometimes it happens quite often, patient is exactly having polyuria, that will also present as LUTS. Like to take lot of fluids, lot of water, they start drinking 4-5 liters of water, and then they land up in urology or in physician's OPD. So with excess intake only. Diabetes, quite often we diagnose, like they straightforward come to us with LUTs, we evaluate and we diagnose first time as a case of diabetes. So these are comorbid conditions which can present as LUTs. Certain medications like patients on antihypertensive statin diuretics or some cough mixtures, antipsychotic medications, they start and they usually start with LUTs. Cardiovascular status, poor sleep itself can cause sometime nocturnal frequency, exactly patient is not having that. So all those things we should keep in mind. So you can say it is a very vast clinical scenario and you should be aware about these things. It is a clinical syndrome, so we are concerned about, we should be concerned about clinical BPH. Like it's simply if it is a benign prostatic enlargement, quite often it can happen like a incidentally detected ultrasound says there is 70 grams gland, 80, even sometimes 100 grams gland, any size, but patient is otherwise asymptomatic. Ultrasound done because of any other reason, so that is simply benign prostatic enlargement, but that prostatic enlargement is not causing any obstruction and that is why not causing any symptoms. So what is important? Important for us is, so prostatic enlargement is like graying of hairs, it is not always pathological. So there should be enlargement, there should be bladder outlet obstruction and that can cause lower urinary tract symptoms, only then it is cause of concern. So coming to the quickly to the work into initial evaluation, detailed history, as usually quite often I am overemphasizing history taking in each and every case, but here it is more important. Anyone will like to tell my few more old students which who already attended my long clinic, why history is more important in this? Yes, from this side. Eh? Why history is more important? History is important in each and every case. I keep on emphasizing this. In spite of all high-tech investigations, it is so one you all know, history is important because बोलो बोलो भाई तो यूजी वाला है yes, why history is important? Otherwise चलो इसमें छोड़ दो, because patient is coming with that complaint, patient is concerned about those complaints, he is not interested in diagnosis. Once you will come to know, only allay those problems, so you should know the problems. But here why it is important in history, because our decision making is important. Decision making is quite often, as I already mentioned this, like if there is enlargement, if patient is not symptomatic, patient is not having any symptoms, so that patient may not need any treatment. So decision making is solely based on if patient is having bothersome symptoms. So that's why symptoms are very important. Then follow up, rest of things I will discuss. Then examination still remains most important, abdominal and external genitalia exposure is important. Quite often it happens like physicians start treatment of BPH and once they come to us with a bunch of investigations, reports of ultrasounds, and once we expose that patient, patient is having simple metal stenosis. So that you can't diagnose without exposing properly patient and without examination. Ultrasound will not detect that. So history and examination is important, that we should keep. Quite often it happens. महीने में एक या दो patient ऐसे जरूर आते हैं जो being treated, not responding, and on examination you will find simple patient is having, sometimes patient himself tells. Then coming to the digital rectal examination is still important part of clinical evaluation of a case of BPH. That is mandatory part is still in spite of ultrasound, TRUS and so many investigations. Then coming to the diagnostic test, we can divide into initial diagnostic test, then additional diagnostic test and test in men who require surgery, before surgery. So in that way we can. So initial diagnostic challenge, this is important slide, why I am trying to highlight this, emphasize this, again already I have highlighted those points. So if we are able to diagnose enlargement of prostate, we are not able to, we won't be able to diagnose clinical BPH. Okay. So it is important if this because of BPH, ये important है कि ये symptom BPH की वजह से है या नहीं है, क्योंकि सिंपल इनलार्जमेंट से तो हम कंफर्म कर नहीं सकते, क्योंकि कई बार 100 ग्राम की ग्लैंड पे प्रॉब्लम नहीं कर रही, एंड समटाइम 20 ग्राम्स ग्लैंड इज कॉजिंग सीवियर सिम्टम्स एंड रिटेंशन एंड इवन समटाइम रीनल फेलियर. So it is a challenge कि how to diagnose, we'll discuss in next few slides. So initial evaluation, history taking, simple way, ये मैंने simplify करने की कोशिश की है so that you can remember it like ABCD of trauma. So here I just simply tried to make a mnemonic. A you can recall from AUA score, okay. So A for specific urinary symptom, AUA score, that is a scoring system considering all these specific symptoms. So those symptoms are important. By those you can quantify those symptoms, that is second. In the follow up you can assess progress of that patient, ki how patient is responding or not. So these symptoms you must, at least if you are not recording, ideally patient, if patient is well educated, one can record AUA score, otherwise you can go for at least you should record what complaints, what symptoms patient is having if you are not recording AUA. B for bad effects or complications, C for history of comorbid conditions, and D for history to rule out differential diagnosis. So ABCD you can remember so that you will not miss. This is important integral part of any, especially if you are dealing with the case of LUTS, and in reference to BPH is rather more important. So you should record all those symptoms. Specific urinary symptoms, as you all know, voiding and storage, we categorize these symptoms: frequency, nocturnal frequency, and urgency, urge incontinence, dysuria, and all those things you can, and this is AU symptom score, you can go ahead. So complications are hematuria, if patient is having recurrent hematuria, recurrent UTI, and renal failure, and history of recurrent retention for the BPH. Why these symptoms are important? Why these complications are important? Yes, anyone? This is also important subset of complications if patient is having. So if BPH patient presenting with these complications, how it is important? How this information? नहीं? Yes? ये हमारे fresh JR2, JR3. So these, if patient is presenting with this clinical scenario, so it means that patient will qualify. These are definite indication for surgery, okay. We will not offer medical therapy to those cases, okay. If patient is having recurrent hematuria because of BP, so these are definite indications for surgical intervention, and surgical intervention, as you all know, TURP. And comorbid conditions, as already discussed, they sometimes they can cause aggravate these symptoms, or they are important for this. Then coming to this slide is important, differential diagnosis. So before making diagnosis of BPH, this is always mandatory to rule out all these things. If someone patient is having, suppose stricture urethra, if there is some component of neurogenic bladder, then we will not diagnose this case as a BPH, okay. So sometime it is said कि BPH is diagnosis of exclusion. I can modify that statement. At least if you are going to make a diagnosis of BPH, you should always exclude all these things. Only then you can make a diagnosis, because you can't make diagnosis with ultrasound or imaging, okay. So these things we should always, if patient is having a stricture, you will first treat a stricture, because stricture is a stricture, it is going to cause problem. Prostatic enlargement may or may not cause symptoms, okay. So first of all you should treat these things, only then you will go ahead with this. Physical examination remains important. External examination, like abdominal examination, external genitalia systematic examination of and look for metal stenosis, look for any findings suggestive of stricture urethra or any phlegma and fistula, and distal rectal examination is still important. Distal rectal examination is not meant for size, we are not bothered about those. We should look for tenderness, look for any asymmetrical enlargement, induration or nodularity to rule out any possibility of carcinoma prostate, okay. Then coming to the investigation, initial investigations, serum creatinine, urine analysis and serum PSA are as initial investigations if you are going to start treatment. Then additional diagnostic tests are uroflowmetry, ultrasound. Ultrasound should include pre-fluid urine volume, and these diagnostic tests are not indicated for diagnosis of BPH like cystoscopy, urodynamic. So cystoscopy is indicated once we are planning for surgery. Just before surgery we can go for cystoscopy. Urodynamic study is only indicated in cases where we are having some storage symptoms more like frequency, urgency, high residual urine, or you are suspecting some neurogenic bladder. So in those cases, and upper tract imaging is also if you are having renal function is compromised or suspecting urinary stone disease. So in select cases you will go for these tests. This is workup, you can say if patient is presenting with this relevant medical history, assessment of LUTs, severity and bothersome, like with AO score you can do it, urine analysis, PSA, frequency value. So lower urinary tract symptom important, sometimes simple bothersome LUTs, predominantly significant nocturia, frequency volume chart, polyuria. Quite often it happens once you will go for urinary diary, patient is having polyuria, like he started taking little extra fluid, and so if it is more than 3 liter in 24 hours, it is considered polyuria. Lifestyle and fluid intake is to be reduced. If nocturnal polyuria, sometimes patient is having more urine in the, if it is more than 30% of total volume, then it is called nocturnal polyuria. So we should simply modify dietary habits and all those things, and patient will in that way feel better. Okay, and if there are other things, we can go for evaluation, further evaluation. नहीं हो रही आगे? Yes. So coming quickly to when to treat BPH now. कुछ तो हमने आंसर दे दिया है. Yes. है? Bothersome symptoms, that is one, और या complication हो जाए. Complication हमने जो बताया 3-4. So only like sometime it happens quite often, patient of a neurogenic bladder admitted here, patient goes for ultrasound because of any other reason, then they are referred, it's a prostatic enlargement, and then what should, so patient is, although patient is otherwise not having any bothersome symptoms, or patient is not having any complication, but on ultrasound a patient is having reported with 60, 70, 80 grams gland. So quite often simply after evaluation you can advise that patient will not qualify for any intervention or surgical intervention. Okay. So indications remains very clear, bothersome symptoms due to BPH, or if patient is already presenting with complications. Complications we already discussed, like recurrent hematuria, recurrent UTI because of BPH, and features of renal failure because of BPH, because of chronic bladder outlet obstruction, or like patient is having bladder stone or those things. In those cases we will go for decision making. So how you will treat, what are options you are aware? Quickly I am going to finish with this. What options do you think for the management of BPH? Yes. Medical management. Any other? Surgical management. So what options do you remember in cases of medical management? Silodosin. Okay. Or 5-alpha reductase inhibitors. Good. Or so two set of medicines you are able to tell. That's what. Any other group of what surgery? TURP. Okay. Any other modality you are aware about? TURP, and what options we have? Okay. So watchful waiting we discussed first, that was the first option we discussed. Quite often patient is coming with apprehension, and exactly after evaluation don't find any symptom, bothersome symptoms. So sometimes patient comes with that, so watchful waiting may be a valid option in good number of patients. Medical treatment is one. Second option is minimal invasive surgical techniques, MIST, and surgery. Surgery open is now all obsolete, now TURP, and there are so many techniques which are being used in laser we are using there also. So there are 4 subsets which you can use in management of BPH. Okay. So watchful waiting is also important. Simple precautions of style changes, drink normal amount of water. Sometimes people are taking excess fluid, it's not. Okay. So normal amount, like urine output should be 1200 to 1500 ml of in 24. Take less liquid diet before sleep. Use medications for hypertension, asthma, cough, psychiatric disorders only after proper consultation. There are so many medications which interact with this. BPH patients, comorbid conditions should be treated. Diabetes, CHF, all those things should be addressed. And then patient, quite often they will not need additional medical therapy in these cases. Then constipation, alcohol intake, all those things are important to address. This is also, you can say, the important part of urinary stone disease, and BPH is also a part of metabolic syndrome. So as you all know, the management of metabolic syndrome, all those things are kept here. Quite often patient is obese, metabolic syndrome, they will develop early these LUTs and BPH symptoms, and quite often they will medications. So that is important part you should keep in mind. Coming to the medical management quickly, moderate to severe symptoms, unfit for surgery. So it's not, one thing is important, quite often you say like patient comes with bothersome symptom, you will always going to offer a medical therapy. That's not true. So you should discuss, sometime patient can opt for surgery, or you can offer both the, and it is a mutually, and for that patient the best option you should offer. So one can start medical therapy, or one can go for surgical intervention, barring those 4 definite indication for surgery. Okay. So medical therapy, these are 4 subgroup of medical medications we are using: alpha-adrenergic blockers, as you mentioned, silodosin, alpha-adrenergic tamsulosin, mechanical obstruction, alpha reductase inhibitors, finasteride, dutasteride. Okay, I am just finishing. And overactive bladder, antimuscarinics, you can add these medications also. Then hypocontractile bladder, there are few reports which can support that we can use bethnicol, and if patient is having these younger patient associated with erectile dysfunction, we can use tadalafil. So these are certain medications which we can use. And then in surgical, in minimal invasive surgical options, there are certain, you can say, minimal invasive surgical techniques: prosthetic urethral lift, and water vapor thermal therapy, robotic water jet. These are recently introduced newer techniques which are being tested and used in the with advantage of you can say the less invasive than surgery, and you can response, and considered like people don't want to continue with medications, are not responding to medical therapy. But we don't have long term experience with these prosthetic urethral lift. These are newer and FDA approved options which are, and keep on changing. This is a very long list of these newer techniques which are being practiced by at different centers: transurethral vaporization, tuna. Okay, so just I am making you familiar with these terms. Prosthetic stents also introduced and not very popular. Then laser therapies, where Nd:YAG laser initially came, then holmium laser, then KTP laser, thulium laser. Okay. So regarding these new techniques, one should keep a point of caution, like many new options have been introduced to the market, although with claim of maximum results with more acceptable safety profiles, but each technology led us to previously unconsidered complications and new paradigm to consider. So वही उसके complication हमें बाद में पता लगते हैं after some time we, then they come out कि no, this laser is latest and best. So keep on changing things. So overstate result, attempt to mislead, like we need to be very careful to embrace new techniques, like this proper evaluation has been done or not. Then coming to the last important, the surgery. Surgery still remains, you can say, the TURP, and earlier we used to do monopolar, but now we are using bipolar, and that still remains a gold standard option for the management of BPH if it is indicated. Okay. These are complex scenario where you will go for surgery only, you will offer surgery. Why surgery? Why you are going to offer surgery? In these cases, you will not offer medical therapy, because this surgery is still most effective treatment modality. So, in majority patient can opt for medical therapy and they can respond, but if patient is presenting with these clinical scenarios, you don't offer, you should not offer medical therapy. So, I think with that I should conclude. Thank you.
Thank you, Baba sir, for elaborating talk on BPH and LUTS. So I would like to invite Professor Apul Goel sir for felicitating Baba sir. Thank you, sir. Now I would like to invite Professor Manoj Yadav sir from Department of Neurology, KGMU. He has number of publications in various international and national journals, and his main area of interest is lab urology, endourology, and reconstructive urology. So he will be delivering a lecture on the PUJ obstruction.
Good morning, everyone, and it's a pleasure to come here because I have started my surgical career from this department only. So I passed from here. So I am alumni of this department also. Now, from where sir has left, that is the surgery. So I am dealing with a condition where surgery is the option, but when and how it has to be done. So most of us has heard the word hydronephrosis and hydroureteronephrosis. Two are different terms, and be careful, both have different treatment. Ureteric junction obstruction. As the name suggests, there is something in where ureter and pelvis joins. So what is the definition? Definition is functionally significant impairment of urinary transport from the renal pelvis to the ureter. And if it is left untreated, it can reach to non-functioning of that side of the kidney. We have seen bilateral PUJ also. So this is important to deal this condition because it can lead to non-functioning of the kidney, and we have to do nephrectomy. Most causes are congenital, where surgery is required, and other causes are acquired, means stone disease. If it is an impacted stone at the PUJ and it has not been tackled, then it can lead to inflammation and fibrosis. So these are the secondary cases. Most of the inflammatory or sometimes urothelial neoplasm at the junction of at the level of PUJ can lead to hydronephrosis of the kidney. There is cause of aberrant vessels, so they can also lead to extrinsic compression over the PUJ if they are crossing. I will show you in the next slide. And this BUR, when its severity is so much that there are kinking in the ureter, it can lead to a secondary PUJ. So BUR can be the cause of secondary PUJ obstruction. As I said, it's a intrinsic disease. There is a peristaltic segment at the pelvic-ureteric junction which lead to non-passage of urine from pelvis to the ureter, which can lead to hydronephrosis of this condition. Sometimes during development there are valves or kinks in the ureter. They can also lead to this PUJ obstruction. the significant crossing vessels have been noted in 63% of the patients with PUJ obstruction. But it is not the sole cause of PUJ obstruction. There is something intrinsically in the PUJ, because in up to 20% of the normal cases where we deal with stone disease or anything, PUJ. So up to 63% there is the cause of PUJ, that is the crossing vessel, but normally it can also present. With the development of this antenatal, this ultrasonography, we can find in utero that there is hydronephrosis, and it's not always they have to be treated, they can be followed up, and there are certain grading systems where we do follow up and how we decide to operate or to just follow up. So there are two parameters, the anterior posterior renal pelvic diameter, and there is a grading system, Society for Fetal Urology grading system. So there are certain criteria. If this AP diameter of pelvis is growing more than 15 mm, then we have to look this kidney, and we should watch this fetus or infant for further deterioration of the renal function. And there is another grade happening in future to the kidney. First was the normal anatomy, there is nothing. It's a little hydronephrosis, that is the grade 1. In 2, there is pelvis is full and major calyces are dilated. Be careful. Major calyces along the is stirred, because this dilatation can lead to pressure over the parenchyma and destruction or thinning of the parenchyma started. And grade 4 is dilatation of the renal pelvis, major calyces, as well as thinning of the renal parenchyma. वो देखो सो रहा है वो उसको. So from here we will decide what to do next. Cases. Clinical presentation. Most common causes. Patient is coming with the abdominal lump. Children or adults, sometimes adults can also come. Or associated symptoms, nausea, vomiting. In children, failure to thrive. And these are the most common symptoms. Due to secondary infection, they can have secondary infection, infected hydronephrosis fever, infected hydronephrosis fever, or else. This is a hematuria. There is a trivial trauma. There is a trivial trauma. Just fallen from the child has just fallen from the in the urine. Then the parents they panicky how it has child. So here it is the caution. You have to go for investigation. Sometimes the trivial trauma can cause hematuria in these patients, recurrent UTI, because there is the urine, then can lead to the urinary tract infection. Fetal crisis. This is the common word you will ask in your exams. When we give fluid, this fluid is not passing through the pelvis to the urethra. There is development of lump, pain. Suddenly with the gus of urine when disappears. So it disappears. This is details crisis. Sometimes undiagnosed vascular hypertension. It can be the cause due to the UPJ of renal vascular hypertension. It can be the cause due to the non-invasive test. It can diagnose about the status of the kidney, hydronephrosis or hydronephrosis. For the children, there is a if there is hydronephrosis, dilatation of the renal pelvis, and you are not able to visualize the ureter, confirm there is a PUJ obstruction. But this radiologist is dedicated to the urological symptoms. So urologist, if he is saying uroradiology, there is non-visualization of the ureter, but there is hydronephrosis. percentage PUJ of success. And next investigation required for in such cases can rule out the function and of success. Rule out the function and their radiation exposure has been their radiation exposure. All the patients they require IVU or CCT. All the patients the radiologist require IVU or CCT dilatation of the pelvis. The radiologist is saying that there is another disease dilatation of the pelvis kidney. It is also diagnosed on the basis of compound. Because in PUJ there is dilatation of the renal pelvis along with the calyxes. But in multicystic dysplastic kidney there is dilatation of the kidney. But there are multiple ultrasonography say there is cystic means there are walls. In PUJ there is uniform dilatation, but there are focal area. So how the ultrasound can differentiate between multicystic dysplastic kidney and PUJ. CT or MR pyelogram. When we do surgery, we are not able to diagnose the patient. As I said, ultrasound. If it is not done by a reliable radiologist, then they can base a medullary stone. So, if they are saying there is dilatation of the kidney without visualization of the ureter, then diagnosis is straightforward. That is a PUJ obstruction or hydronephrosis of the kidney. This is a typical picture. You can see the pelvis. Large area is pelvis. Now CT contrast resonance will show the function as well as the drainage of the kidney. So these are the typical pictures. You can see in the left side black area that is dilatation of the renal pelvis and lighter black is the parenchyma of the kidney. And here you can see development of a renal stone in the pelvic area. How we can diagnose on the basis of CT? There is dilatation of the pelvis. This is the extreme situation where pelvis is hugely dilated. There is no parenchyma. The kidney has gone for non-functioning. This is the diagnostic test. Whenever you operate, be careful. Diagnostic test. There is a whenever you operate or not, and it will also dictate what is the function of the kidney. Suppose it was 10% function and you operated, and again parents go for kidney to kharab ho gayi. So then this will dictate you ki what was the function. So you have to take a DTPA scan before. So these are the curves. Upper one, that is the blue line which is going above. It means there is stasis of this this MAG3 or this contrast which we have given for DTPA. It is staying in the kidney. It means there is obstruction in the left side of the kidney. And second graph, it is also red is right kidney or blue is the left kidney. Now it is passage of the contrast. So first one is the PUJ obstruction. Second one is of operated case of PUJ obstruction. Retrograde pyelogram, it will dictate us what is the length of the narrowing in the PUJ, what are the procedures we can require during surgery. Now it's a surgical management is the mainstay of treatment, where we do most common procedure is Anderson-Hines dismembered pyeloplasty. I will show you in the next picture, and other options are there. Now what are the indications? Number one, PUJ obstruction diagnosed on the basis of difference of 10% function between both the kidneys. Then we have to tackle PUJ obstruction. Now it's the time to hold surgery. Or there is development of any stone, secondary stones, because of stasis of the urine. It is also indication for surgery. And patient is having a solitary kidney. We have to be careful for this kidney because he or she is having a single kidney. Asymptomatic patient, difference of function is less than 10%, then we can also follow up such patients. Other procedures I will show you. This is the typical Anderson-Hines dismembered pyeloplasty, a retroperitoneal approach for the adults. In children, anterior retroperitoneum, we excise the portion of the this aperistaltic segment of the ureter, and we again anastomose with the pelvis. So this is the most commonly done procedure in PUJ. Sometimes there is dilatation of the pelvis, so we have to reduce it also, so that stasis of the kidney is decreased and secondary chances of stone formation or other things can be high. Other procedures like crossing vessel, we have to transpose the vessel from posterior to the, so here it is the crossing vessel which is leading to the PUJ obstruction. So again Anderson-Hines procedure is polyBYplasty if there is a high riding of pelviuretic junction. So this is a minimal non-dismemberment. If we have a long segment of stricture, then we can use these spiral flaps of the pelvis, because pelvis is redundant and length of is more. So to deal with this, we use different type of flaps. This is the Scardino-Prince vertical flap. Another is intubated Davis ureterotomy. This is the last situation where intrarenal pelvis is difficult to dissect, and we are not able to give the good results by doing a Anderson-Hines. So we can go for this ureterochelicostomy. Second thing, because in PUJ kidney is uniformly dilated, so if we cut the lower pole and anastomose ureter. And minimally invasive is endopylotomy, less than 2 centimeter, and it's a failed open pyeloplasty. We can use this minimally invasive endopylotomy. Indications of nephrectomy: function is less than 10%, parenchyma is thinned, there is infected pyonephrosis is there, then we have to remove the kidney. Follow up 1 month as usual, and up to 2 years we have to follow up with the ultrasound. I will show you minimally invasive. Can I? This is the typical transabdominal laparoscopic pyeloplasty of the left side. We are just colon is reflected so that we can reach pelviuretic junction. In children or in females, this is all visible through the mesocolon also. So a transmesocolic approach can also be done. Here, this is the pelvis, and this is the PUJ obstruction, where the surgeon has pulled it at the PUJ, because it has to be cut. So no touch technique is also set for the during this surgery. Both left and right hand should be coordinated during laparoscopic or minimally surgery. So you can cut by a left hand also. So this is cutting at the PUJ. Now there is spatulation of the ureter. This is the segment which we have to sacrifice. So we are cutting and just using for holding the ureter. Now this is the spatulation of the ureter. It has to be done on the lateral side of the ureter, because all the vascularity is coming from the medial side. And how we will decide how much has to be cut? It's around 1.5 to 2 centimeters. And this laparoscopic seizure, one blade is enough to measure how much you have cut. Now we are started suturing. This anastomosis should be funnel shaped and dependent and butter tight. This is the classical term used for this pyeloplasty. First, either we can take a posterior layer or the anterior layer, it depends on the surgeon. So this is the posterior layer which we are taking. This is the ureteral posterior layer and the pelvic posterior layer. Typically, Vicryl 40 or 30, in children 50 is used. Because this is minimally invasive, only 3 holes are there, no incision, nothing else, because to remove anything, a small amount of this aperistaltic segment which can be taken out by either this 5 mm port or 10 mm port. This is the placement of the ureter. Laparoscopically you can place the DJ stent, and DJ stent always has to be placed after the surgery, with the surgery, because sometimes there is edema or there is tension over this anastomosis. So this will lead to a securement of the anastomosis. So that's how we did it. Thank you so much. Any questions? One thing is diagnosis of hydroureteral nephrosis and should be clear in your mind, because they have a different etiology. And how to do a DTPA scan in cases of hydroureteral nephrosis is just drain the bladder with the placement of catheter and write to the person that we are suspecting hydroureteral or hydronephrosis. So thank you so much.
Thank you, Manoj sir, for your lecture on the PUG obstruction. Now I would like to invite Professor Power sir for felicitating. Thank you, sir. Now I would like to invite Anil Raj, sir. He'll be delivering a talk on ultrasound, which is important for general surgeons. So, sir is faculty in Department of Radiology.
So good morning everyone. Today I am going to discuss about ultrasound physics, pneumology and image education. So first of all, coming to the history of ultrasound, piezoelectricity is discovered by Pierre and Jacques Curie in 1880 using natural cords, and sonar was the used in 1940s wartime, and its diagnostic medical application is used in since late 1950. So what is the ultrasound? These are the acoustic vibrations of frequency higher than 20 kilohertz, non-audible by human ear. According to type of interaction with cells, these are the active and passive type. Active are the high intensity ultrasound waves. These are mainly used in physical therapy and surgery. And the passive ultrasounds are the low intensity sound waves. These are used in medical diagnostic. These are of our importance. So what are the advantages of ultrasound? These are it is a widely used and versatile modality. Tomographic and real-time imaging, inexpensive and portable, and it has known risk to the patients. Used to guide many types of interventional procedure as well. High intensity focus or HIFU is a finding growing use as a therapeutic modality. Effect is used to make quantitative measurements of absolute blood velocity and to map blood flow over a large field of view in a semi-quantitative manner. So what are the diagnostic frequency we used in our diagnostic areas? 2 to 6 megahertz probes are generally used for abdominal ultrasound, obstetrical and gynecological examination, echocardiography and transcranial Doppler. 7.5 to 14 megahertz probes are used for small parts, vascular Doppler examination or MSK ultrasound or superficial examinations. 10 to 20 megahertz are used for ophthalmology or a special vascular examination. And 20 to 50 megahertz probes are used for endoluminal examinations such as TVS or ultrasound biomicroscopy used in ophthalmics and dermatology. Now coming to velocity of sound, these are the sound waves have a velocity of 1540 meter per second. These are the average for body tissue, and these propagation is depends on compressibility and density of the medium. So the decreasing compressibility results into increasing speed of sound. So the compressibility is indirectly proportional to propagation velocity, and density is directly proportional to propagation velocity. Means more denser the media, more propagation velocity. So this is the schematic diagram. We can see there as we move down, there is more denser media is there like bone, which have more propagation velocity, about 1800 meter per second. This is the wavelength and frequency. The distance between corresponding point on pressure time curve is called as a wavelength, and the number of complete cycle in a unit time is called frequency, as we all know. The human hearing is limited to range of 20 to 20,000 hertz. Used for diagnostic application range from 2 to 15 megahertz. So what is the impedance? Impedance is a resistance offered to the sound waves by the tissue in which they are traveling. The junction of tissue with different physical properties produce an acoustic interface which are responsible for the variable reflection of the incident waves. The amount of reflection or back scatter is determined by the difference in the acoustic impedance of the material forming the interface. So the impedance is equal to density into propagation velocity. Means impedance is directly proportional to density as well as propagation velocity. So these are the, in the first image we can see this is a fluid where which is less denser than the solid media. We can see the incoming signal is shown by this black arrow, and the reversed back signal is shown by small arrow. Means the attenuation factor is more. What is the reflection? The change in direction of a wave at a boundary between two different media, so that the waves move back into the medium it came from. Sound reflects off a surface at an angle equal to the incidence angle. So larger smooth area reflect back most of the incident waves when the angle of insolation is near 90 degrees and are called specular reflectors. Examples are diaphragm, vessel wall, endometrium, and urine filled bladder. Solid organs have interface much smaller than the wavelength of the incident sound. The echoes from these interfaces are scattered in all directions. These are called diffuse reflectors. Now coming to the attenuation, it is the loss of energy of transmitted and reflected sound waves owing to scattered reflection, refraction, and thermal absorption, and the attenuation of frequency of sound as well as the nature of the medium. So now coming to the basic component of the ultrasound scanner, these are shown in the pyramidal fashion: a transmitter, transducer, receiver and processor and display, and the storage function. Now coming to the transmitter part of ultrasound machine, transmitter or a pulsar to energize the transducer. Most clinical applications there is a brief burst of acoustic energy and transmitted into the body. The transmitter controls the rate of pulse emitted by the transducer or the pulse repetition frequency. PRF is important in determining the depth of the frequency. Wavelength. The ultrasound pulse
dictate what is the
must
function
be
of the
spaced
kidney.
with enough time
Suppose
between the pulses to permit the sound to travel to the
was
depth of
10%
interest and
function
return before
and
the
you
next
operated.
pulse is sent.
And again,
Now coming to the transducer, a
parents go
transducer is
for
an
kidney
that converts one form of energy to another. Ultrasonic transducers converts an electric signal into ultrasonic energy that can be transmitted into tissue and convert ultrasonic energy reflected back from the tissue into an electric signal. It works on the principle of piezoelectricity. This is a schematic diagram of an ultrasound probe in which we can see there is a coaxial cable and a piezoelectric crystal is this, and it is covered by plastic housing, and there is a backing block to prevent back scattering of the sound waves. Now coming to the resonant frequency, every crystal has particular value of resonant frequency, and so is designed that is thickness equal to the half the wavelength of sound to the produce. So the thicker transducer means larger wavelength produced and lower frequency. The thickness of the crystal determines the frequency of the scan head, so the low frequency probe deeper structures. So what is the matching layer? It is located at the front surface of transducer and it is made of aluminum powder and epoxy resin. The thickness of matching layer is generally 1/4 of the wavelength of the ultrasound produced. It is called a quarter wave matching. The purpose of matching layer is to minimize reflection between piezoelectric crystals and patient skin, or to minimize transmission of ultrasound from piezoelectric crystal to the patient. So what is the receiver? When the returning echoes strikes the transducer phase, minute voltage are produced across the piezoelectric crystals. The receiver detects and amplifies those weak signals, and it provides a means for compensating for difference in echo strength. So it is compensated by time depth compensation, or a TGC control. In ultrasound machine, we have the control of TGC. As the sound waves penetrates from superficial to deeper structure, it attenuates more. To overcome these attenuation, we increase intensity of those sound waves. We can see these controls are more towards the left side and more towards the right side, means we are increasing the power of the sound waves as we move deeper to the structures. So ultrasound, what are the different modes of ultrasound? A mode, it is basically used in measuring, used in ophthalmology, echoencephalography, echocardiography, and adjunct to B mode displays when accurate depth measurements. And B mode is usually we used, and M mode is used for echocardiography and cardiac non-stress test and echocardiography. So B mode is usually we used in general examinations. So what is the real time? Real time means we capture multiple frames per seconds. When they frames move together, they create a scene, real time imaging. So what are the different type of transducer arrays? These are the linear sequence arrays, phased array, and a curved transducers. So what are the different special imaging modes? These are the tissue harmonic modes. Tissue harmonic imaging, what it does, is results into contrast resolution, increase and reduce noise and clutter, improved lateral resolution, reduced artifact, and improved signal to noise ratio. So this is an article published in a journal which shows the clear enhancement of deeper structures with the use of tissue harmonic imaging. So a special compound used for speckle reduction, and extended FOV imaging is used for larger areas such as vessel imaging, when we create a panoramic image of the vessel. Three-dimensional ultrasound, in which we can capture multiple planes and create a 3D image by multiple planes. It is mostly used in obstetrical examination. So what are the imaging artifact? These are the reverberation artifact, which we can see in the multiple areas such as diaphragm, when the lung and air artifact are called reverberation artifact. Mirror image artifact they lie behind it, just as something viewed through a mirror, it appears to lie behind it. Example, diaphragm. Now coming to the acoustic shadowing, marked reduction in the intensity of ultrasound deep to the strong reflector or attenuator. Shadowing causes partial or complete loss of information due to attenuation of the sound by superficial structures. So it is useful in cases of calculi. We can clearly see the multiple echogenic structure with definite acoustic shadowing in the gallbladder lumen, suggestive of cholelithiasis. So what is acoustic enhancement? It is the opposite of acoustic shadowing. In below the lesion occurs when sound travels through a medium with attenuation rate lower than the surrounding cyst or urinary bladder. Now coming to the knobology, it describes the pertinent knowledge and use of ultrasound equipment to achieve the best setting and applications for patient care. Apart from good knowledge of anatomical structure and examination technique, knowledge of how to achieve the correct machine adjustment for the best image quality and to maximize the potential of ultrasound equipment function is essential. So these are the different type of probe. This is the curvilinear probe used for general abdominal and ops examination. This is a high frequency probe used in superficial structures such as ophthalmological examinations and MSK examination. This is the endoluminal or TVS probe. This is the phased array or a cardiac probe. So these are the different frequency of the above mentioned probes. These are the controls generally in machine, some of near field gain. And so now coming to the ultrasound for surgical aspect of ultrasound. Ultrasound has become an essential tool in surgical practice, offering real-time diagnosis, procedural guidance, and post-operative monitoring. Its portability, safety, as it has no radiation exposure, and ease of use make it invaluable in various surgical specialties. So the common surgical applications, as we see in trauma settings, we are doing FAST and eFAST scan. FAST include different quadrant visualization of fluid in pericardial effusion, free fluid in Morrison pouch, free fluid in the splenorenal recess, and in free fluid in pelvic fluid. eFAST is extension of that FAST examination, and it also include lung ultrasound for pneumothorax detection. In abdominal surgery, we can do evaluation of acute abdomen causes such as cholecystitis, appendicitis, bowel obstruction, and in hernia assessment, differentiate reducible from strangulated hernias. For the vascular access and procedures such as central line placement and for the breast, thyroid, and soft tissue lesions, it differentiates solid versus cystic masses, and it also guides FNAC and biopsies from these lesions. And perioperative use used for regional anesthesia, USG guided nerve block, and monitoring post-op collections for in cases of abscess, hematomas, and seromas. So what is the practical tips for surgeon? First is to choose the right probe according to your examination. Curvilinear probe, that is low frequency probe 2 to 5 megahertz, used for deeper structure, and linear probe high frequency 7 to 15 megahertz, used for superficial structures, vascular and soft tissue. Phased array used for cardiac and trauma scan. Applies generously to prevent air in and optimize depth and gain for better visualization. Understand normal anatomy first before identifying pathology. So that finally conclude the final conclusion. The use of ultrasonography in medical practice has evolved dramatically over the last few decades and will continue to improve as a technological advances are incorporated into daily medical practice. Although ultrasound machine size and equipment have evolved, the basic principles and fundamental functions have remained essentially the same. And it is a powerful extension of clinical examination and surgical decision making. With proper training and practice, it can significantly enhance diagnostic accuracy, procedural safety, and patient outcome. As its use continues to expand, ultrasound proficiency is becoming an essential skill for every surgeon. Thank you, everyone. Any questions?
Okay, so I would sir for felicitating Anil Rawat sir. Okay, so I would sir for felicitating Anil Rawat sir. So I would again invite sir for his lecture on anal fissure and hemorrhoid. So he'll be discussing about it in detail. I would again invite sir for his lecture on anal fissure and hemorrhoid. So he'll be discussing about it in detail, and it's a very common problem. So over to you, sir.
इसमें पॉइंटर जाता है क्या बेटा? इसमें पॉइंटर इस पे जाता है क्या? पॉइंटर इस पे जाता है क्या? अच्छा तो यहाँ रखेंगे तो वहाँ भी जाएगा. अच्छा तो यहाँ रखेंगे तो वहाँ भी जाएगा. ओके. कौन सा पॉइंटर? कौन सा पॉइंटर? गुड मॉर्निंग. Good morning. Good morning, respected teachers. Good morning, respected teachers. Dear students. So without wasting my time, I am going to deliver a talk on approach to a case of anal fissure. So to introduce, I will cover the following headings: introduction, etiology, pathology, clinical feature, diagnosis, and management of hemorrhoids, fissure. So. Fissure in ano or anal fissure is a very common anorectal condition, and it is defined as a longitudinal tear in the distal anoderm or distal anal canal. Usually it is situated on the posterior aspect of the anal canal, but other sides may also be, it may be found, है ना. In most of the cases posterior side common होता है, otherwise एंटीरियर और लेटरल फिशर्स भी मिल सकते हैं. सो etiology, what is the etiology or common factor which leads to generation of this anal fissure is one is the anatomical structure of the anal canal. Posteriorly क्या होता है कि मिडलाइन में जब लॉन्गिट्यूडनल मसल के फाइबर्स एक्सटेंशन जा करके जुड़ते हैं तो एट दैट साइड वेस्कुलरिटी कम रहती है. दूसरा स्ट्रेचेबिलिटी एंड इलास्टिसिटी एंड दैट साइड इज ऑल्सो लो. तो व्हेन एवर देयर इज हार्ड स्टूल, कॉन्स्टिपेशन या सच काइंड ऑफ सिचुएशन जिसमें आपका स्टूल पेशेंट का हार्ड होता है, स्ट्रेनिंग होती है, तो एट दैट एरिया फाइबर्स स्ट्रेच नहीं होते हैं एंड देयर इज माइनर ट्रॉमा ओवर देयर. विशियस साइकिल चलती है, वेस्कुलरिटी सराउंडिंग टिश्यू की बढ़ जाती है, बट एट दैट एरिया वेस्कुलर सप्लाई अच्छी नहीं होती है तो टीयर बढ़ता जाता है एंड अल्टीमेटली इट लीड्स टू डेवलपमेंट ऑफ क्रॉनिक फिशर. कॉमन एटियोलॉजिकल फैक्टर डिवाइड करते हैं हम, प्राइमरी एज वेल एज सेकेंडरी फिशर होते हैं. प्राइमरी फिशर जो स्पॉन्टेनियसली वाया डायरिया, कॉन्स्टिपेशन, हार्ड स्टूल की वजह से होता है, और सेकेंडरी फिशर वो होते हैं जिसमें कि आपका प्री एग्जिस्टिंग कोई सिस्टमिक डिजीज़ और एनोरेक्टल डिसऑर्डर होता है, लाइक एसटीडीज़, एचआईवी, एनल कैंसर, आईबीडीज़, इसमें सेकेंडरी फिशर होते हैं. एंड द साइट ऑफ फिशर इन सेकेंडरी एटियोलॉजी, सेकेंडरी फिशर्स इज यूजुअली नॉट एंटीरियर और पोस्टीरियर, इट इज़ यूजुअली ऑन लेटरल साइड्स और मल्टीपल फिशर्स माइट बी देयर. For the anal canal in the posterior aspect, and due to less elasticity there is development of or generation of acute anal fissure that leads to pain and spasm over internal sphincter muscle fibers. As a result there is high resting anal pressure and reduced blood flow or blood supply or anal perfusion at that particular area. इसकी वजह से at that site there is local ischemia and poor healing on that site of fissure. अगेन फिर से हार्ड स्टूल होता है, कॉन्स्टिपेशन होता है, तो देयर इज माइक्रोट्रॉमा एंड ए विशियस साइकिल चलती रहती है. एंड एक्यूट फिशर अगर प्रॉपरली ट्रीट नहीं हुआ तो दैट में लैंड अप इनटू ए डेवलपमेंट ऑफ क्रॉनिक फिशर. क्लिनिकल फीचर्स की बात करें तो पेन ड्यूरिंग डेफिकेशन इज द फर्स्ट एंड फोरमोस्ट सिम्टम ऑफ एक्यूट और क्रॉनिक एनल फिशर. पेशेंट क्लासिकली कहता है देयर इज समथिंग, जैसे कि नाइफ और ग्लास से कोई चीज़ कट हो रही है, पासिंग स्टूल, एंड minimal amount of blood can be also seen while defecation on the posterior aspect where the fissure actually lies. Perianal leaching हो सकती है, discharge हो सकता है. These are the common symptoms which are associated with acute or chronic anal fissure. डिफाइन करते हैं acute anal fissure और chronic anal fissure को depending on the duration. If development of fissure हो रहा है and duration is 6 weeks, तो इसको हम एक्यूट फिशर की कैटेगरी में रखते हैं. एंड इफ इट इज़ मोर देन 6 वीक ड्यूरेशन देन फिशर इज सेड टू बी ए क्रॉनिक फिशर. क्लिनिकली व्हेन एग्जामिन द पेशेंट हमें क्या दिखेगा? बेसिकली इन एक्यूट फिशर देयर इज ए लिनियर टियर इन द डिस्टल पार्ट ऑफ द एनोडर्म, जो आपका पेन सेंसिटिव एरिया होता है. while we look the patient, examine the patient in chronic fissure, we found hypertrophied anal papilla at the apex of the fissure and sentinel pile or sentinel tag just distal the fissure. और बीच में जो फिशर का साइट होगा दैट इज यूजुअली इंटरनल स्फिक्टर के फाइबर्स एक्सपोज हुआ करते हैं इन chronic fissure. So diagnosis is entirely based on clinical history and examination. And if we suppose कि कोई systemic disorder है और unusual site of fissure है, then we have to investigate the cause of the fissure, जो कि that may be systemic cause or immunocompromised status or Crohn's or something else. Then management. What is the management of fissure? Acute anal fissure है तो we have to try for conservative management first. अगर chronic fissure है then we adopt initially medical management. If conservative management, obviously stool softeners, lifestyle and dietary modification, high fiber diet, laxatives, water intake, ये सब बढ़ाना है. Sitz bath plays a important role in management of conservative management of fissure because adequately taken sitz bath can reduce resting anal tone. Resting anal tone अगर prolonged time के लिए कम रहती है तो there is chances of spontaneous healing of the fissure. उसके अलावा local therapies in the form of glyceryl trinitrate, calcium channel blockers and botulism toxin के फॉर्म में यूज़ करी जाती है. तो टॉपिकल ग्लिसरल ट्राइनाइट्रेट इज ए नाइट्रिक ऑक्साइड डोनर दैट कॉज इंस्पेक्टर रिलैक्सेशन और केमिकल इंस्पेक्ट्रोटमी. Besides that, diltiazem and nifedipine can also be used for chemical inspectotomy. दोनों ड्रग्स जो हैं that can be used as a first chemical inspectotomy or conservative management of this acute or chronic anal fissure, but superior side effect profile is found in calcium channel blockers. जो GTN है उसमें headache and other systemic effects are more as compared to calcium channel blockers. तो हम कैल्शियम चैनल ब्लॉकर्स को प्रीफर. बोटुलिज्म टॉक्सिन इंजेक्शन inside the internal sphincter muscle fibers can reduce the pain or spasm of this particular condition and promote healing of posterior or anterior anal fissures. तो ये भी यूज करा जाता है but there is chances of recurrence with this particularly injection of botulism toxin. तो it can be done but chances of recurrence is much more as compared to GTN and surgical management of fissures. So anal fissure can be treated with topical nitrates. Grade of recommendation इसकी है 1B. मतलब हाई रिकमेंडेशन है, इनिशियली वी कैन यूज. सुपीरियर साइड इफेक्ट प्रोफाइल बिकॉज कैल्शियम चैनल ब्लॉकर्स का है, तो हम उसको प्रीफर करते हैं ओवर ग्लिसरल ट्राइनाइट्रेट के लिए. बोटुलिज्म टॉक्सिन का सेम रिजल्ट्स है एज कंपेयर टू कैल्शियम चैनल ब्लॉकर्स एज वेल एज GTN, बट फील्ड मैनेजमेंट हो जाता है, रिकरेंस होती है एंड इट इज़ टेक्निकली डिमांडिंग कि सही साइड पे लगाना है. तो इट इज़ यूजुअली कैन ऑल्सो बी यूज्ड एज ए फर्स्ट लाइन ऑफ ट्रीटमेंट इफ़ योर GTN एंड कैल्शियम चैनल ब्लॉकर्स लेने की पेशेंट की कंप्लायंस नहीं है और प्रोफाइल नहीं है. देन सर्जिकल मैनेजमेंट में ओनली वन थिंग इज टू डू इज स्फिक्ट्रोटमी, दैट इज लेटरल स्फिक्ट्रोटमी. इनिशियली पहले हिस्टोरिकल है स्फिक्टर स्ट्रेच प्रोसीजर कराया जाता था, बट इट इज ऑब्सोलीट नाउ बिकॉज इट कॉज ए मेजर इंजरी टू द स्फिक्टर मसल फाइबर्स एंड लेटर ऑन फाइब्रोसिस होने के बाद देयर इज पॉसिबिलिटी ऑफ स्टेनोसिस एज वेल एज recurrence in the formation of this particular anal fissures. Sphincterotomy कैसे भी करनी है, that may be either closed, open with use of energy devices or with use of laser. So how to do a closed internal sphincterotomy? We have to palpate the intersphincteric groove, internal sphincter. In this particular groove we put a knife. उसके बाद मेडियली रोटेट करके लोअर 1/3 ऑफ फाइबर्स को वी हैव टू जस्ट क्या करना होता है, कट करना होता है ना. पॉसिबिलिटी क्या रहती है, प्रिसीजन अच्छा नहीं है तो देयर इज चांसेज ऑफ कि आप पूरा इंटरनल स्फिंक्टर के साथ कर देंगे, पूरी म्यूकोसा कट कर देंगे, है ना. तो पॉसिबिलिटी ऑफ फिस्टुला फॉर्मेशन, ब्लीडिंग, कॉम्प्लिकेशन होने का ज़्यादा रहता है. दूसरा है कि आप रॉन्ग प्लेन में चले गए तो पॉसिबिलिटी ऑफ इंजरी टू एक्सटर्नल स्फिंक्टर फाइबर्स और ऑल्सो बी देयर. ओपन इंटरनल स्फिंक्टरोटमी करनी है तो वी हैव टू मेक ए रेडियल इंसिजन ओवर इंटरस्फिंक्टरी ग्रूव. वी हैव टू आइडेंटिफाई द इंटरनल स्फिंक्टर फाइबर्स. कैसे आइडेंटिफाई करते हैं, पर्ली वाइट फाइबर्स है ना, रेड फाइबर्स आर इज ऑफ एक्सटर्नल फाइबर्स. उसको अप टू डेंटेट लाइन और अप टू द टिप ऑफ द फिशर तक हमें क्या करना होता है, कट करना होता है. लेंथ क्या होनी चाहिए, सूचर लगाना है कि नहीं लगाना है, दैट इज ऑन योर चॉइस, है ना. आप क्लोज करना है कि ओपन छोड़ना है, इट्स योर चॉइस. दोनों इज हैविंग सेम इफेक्ट, है ना. बट चांसेज ऑफ एब्सेस फॉर्मेशन इज मोर विथ अगर आप सूचर करते हैं. मल्टीपल ट्रायल्स जिसमें देखा गया है कि व्हाट शुड बी द लेंथ, क्या होनी चाहिए, अप टू डेंटेट लाइन इज द आइडियल, है ना. दैट इज रिकमेंडेड कि अप टू डेंटेट लाइन शुड बी डिवीजन ऑफ इंटरनल स्फिंक्टर फाइबर्स. बट अगर हम जो फिशर का टॉप एंड है उस टॉप एंड के लेवल तक हम अगर डिवाइड करते हैं तो फिशर हीलिंग रेट इज हैविंग सेम रिजल्ट एज वेल एज जितना हम डेंटेट लाइन तक डिवाइड करके अचीव करते हैं ना. इनकॉन्टिनेंस जो पार्शियल होती है, फ्लैटस इनकॉन्टिनेंस फॉर पार्शियल फॉर सम टाइम, तो उस तुम्हारा जो फिशर के एंड तक जिसमें हम स्फिंक्टरोटमी करते हैं आपकी क्या होती है, लेस होती है ना. देयर इज मोर चांसेज ऑफ फीकल और फ्लैटस इनकॉन्टिनेंस इन फर्स्ट ग्रुप जिसमें वी हैव डिवाइडेड द फाइबर्स अप टू डेंटेट लाइन, while if we divide it is up to the tip of the fissure, then it has low chances of flatus incontinence. Complication as other surgeries के complication होते हैं, हेमाटोमा हो सकता है, हेमरेज हो सकता है, रॉन्ग टेक्निक से आपने किया तो इंजरी टू एक्सटर्नल स्फिंक्टर फाइबर्स कर सकते हैं, है ना. ऊपर चले गए तो इनकॉन्टिनेंस बाद में हो सकती है एंड दैट इज यूजुअली टेम्परेरी, है ना. स्पाज्म ज़्यादा नहीं है ना, एंड एनल टोन इज नॉर्मल और बिलो नॉर्मल, देन देयर आर सम प्रोसीजर डिस्क्राइब्ड इन विच वी हैव टू डू फिशरेक्टमी एंड एनल एडवांसमेंट फ्लैप्स. इसमें we have to excise the fissure posteriorly or anteriorly and make a anal advancement flap of the posterior anal skin. उसको जितना part exercise कराया आपने up to that area we have to cover it, है ना, so that fissure got healed. Can anybody tell me why we should not perform sphincterotomy on the posterior side? सेम चीज है, आप लेटरल कर दो और पोस्टीरियर कर दो तो क्या प्रॉब्लम क्या आएगी? की होल डिफॉर्म. व्हाट इज की होल डिफॉर्मिटी? Keyhole or whitehead deformity is formed if we perform sphincterotomy on the posterior aspect, है ना, ठीक. To overcome that, this procedure has came or bring. इसको एनल एडवांसमेंट फ्लैप करके हमको कवर करना होता है. अदरवाइज पेशेंट कंप्लेन ऑफ परसिस्टेंट प्रोराइटस, म्यूकस डिस्चार्ज, है ना, fecal swelling in that particular area. So I have a small video for you. This is chronic fissure actually, palpation of internal sphincter fibers and identification of internal sphincter fiber by its pearly white color. The division of fiber may be either done by your seizures, a cautery, laser, है ना. लेजर जो आप करते हैं that is a type of closed internal sphincterotomy. We need not to open this groove. We enter in the submucosal plane, rotate the conical fiber on the medial side, lateral side, and run the, though it is open LIS, and I did it via use of cautery. Any question regarding anal fissure? Aji, how to identify it is a chronic fissure? How to differentiate between chronic and acute anal fissure? कोई एक आदमी एक साइन बताए. Sentinel pile and hypertrophied papilla as well as exposed fibers of internal sphincter, है ना. So now second talk. आजा भाई जरा इसको लगा दे. मैं ले लेता. हाँ ठीक है. सर का करा दो.
I would like to invite Professor Avnish Kumar sir. He will be delivering a lecture on bariatric surgery procedures.
Good morning to everyone. See, I am not going to teach you in detail bariatric surgery. I will be running through the slides and we will be focusing on the videos, and I have got some so I will try to show if the time permits. Okay. Otherwise, I know this is not your domain, but you should know a bit of it. Actually, it is a specialized branch. It is a technically demanding surgery. Surgery is not so much of demanding, but of course, perioperative management is demanding. Understand? surgery is not technologically based, but only problem is कि you have to do some perioperative workup, perioperative involvement. If something happens bad, then you have to be very much careful. Overall, weight loss associated surgery is known as bariatric surgery. Baria means weight. So, weight loss associated surgery is known as bariatric surgery. If it is done for particularly for management of some metabolic disorders like especially exclusively metabolic like diabetes, hypertension, it may be done exclusively also, not associated with weight loss only, included as a metabolic surgery as well. The bariatric surgery, metabolic surgery is entirely different things, but of course, if you do surgery for weight loss, the weight loss associated morbidities are also dealt with. That is why there is a lot of confusion कि bariatric surgery means metabolic. Bariatric surgery, metabolic surgery is entirely different. Understand? And how it started? It was started in 60s as well. But the era was laparoscopy was not very popular. The morbidity was quite high, mortality was even very high. Understand? Mason is started first, Mason is supposed to be performed first bariatric weight loss surgery, and later it was popularized in 1994 when laparoscopy era came. Morbidity also reduced, mortality also reduced. अदरवाइज देखो क्या होता है, अगर हम लोग किसी की बैरियाटिक सर्जरी को क्यों बोला जाता है कि ये बहुत चैलेंजिंग है, बहुत डिफिकल्ट है, मैंने बोला ना स्कोपिक सर्जरी. सी व्हाट हैपेंस, देयर इज ऑलवेज अ ऑप्शन फॉर ओपन सर्जरी इन एनी केस व्हेन यू टेक कंसेंट कि भैया ओपन होना है, लैप होना है, अगर नहीं कर पाएंगे तो देयर इज ऑलवेज अ चांस ऑफ कन्वर्जन. यू गॉट द पॉइंट. बट इन बैरियाटिक सर्जरी you have to have a skill, everything has to be dealt in minimally invasive form. Once you are going to convert the patient, I told you it was started in 1964, so what happened there? Morbidity was high because of surgical site infection. So that is why when you convert the patient, for some reason you are going to lose the patient most of the time. That is why whatever has to be done, it has to be done by lap only. If you are not able to do it by lap, then you should not start bariatric surgery. Bariatric surgery has to be started once you have acquired enough skill to be dealt, everything to be dealt by the lap only. This is the basic difference. That is why it is taken as a separate branch, it is taken as advanced surgery. Otherwise, surgery per se is not technically so demanding. See, these are the definition of obesity. 18.5 to 24.5, it is actually normal BMI. We don't talk in terms of weight actually, we talk in terms of BMI. What you have to consider it is BMI, understand? What you have to consider is it is a BMI, it is not the weight per se which is taken into account. And what is that? Sorry. So under, I am not going for definition, but of course, if someone is having BMI of this one 25 to 29, it is overweight. Above to that, this is obesity, class 1 obesity, class 2 obesity, class 3 obesity. When it is known as morbid obesity, it is more than 45 kg per meter square BMI. Again, it may be BMI is more than 50, it is super morbid obesity. Then if it is a more than 60 BMI, super obese, like that. We know the definition then. And then what is the important indications for surgery? Indications for surgery is BMI more than 45. Anyone BMI more than 45, that makes the indication. BMI more than 35 plus associated comorbidities like diabetes, most common, because of the diabetes associated with the obesity. It is not type 1 diabetes, it is type 2 diabetes. Understand? And hypertension, obstructive sleep apnea, arthritis of the knee, all this good weight related problem. OSAs, if someone is having 35 plus, all this. In Asian population, it is a bit different, it is 32.37, 27 to 32. And then if someone is having BMI of 27 to 32, if not responding to diabetic medications also, may undergo. It's not likely that bariatric surgery is the treatment of choice, but may undergo. It's not like it 27 is very, no, that figure is, if someone is having diabetes and not being controlled by a drug, then of course you can offer the bariatric surgery or metabolic surgery, whatever we want to say. And then of course there are few contraindications. Absolute one is when there is a hormonal problem in your body or congenital disorders like Prader-Willi syndrome, you must have read it, and all others are relative contraindication. It should not be performed in the extremes of age like 18 years से जो पहला bariatric मैंने किया था वो लड़की थी 17 years age की, but that needed gallbladder along with the diabetes, that is why we went for it ना 17-18 years की 12th में पढ़ रही थी, ठीक है, but of course it is relative contraindication because as you grow changes occur in the body, what can happen, whether relapse is there, and afterwards if you are doing more than 65 years age group, what will happen? Will happen and patient may end up into some other problem, you may not be able to recognize that whether it is because of bariatric surgery or something else. Psychologically unstable patient, this is a very important. For workup also we have to send the patient to psychological department, psychiatric department, so that she or he can stick to the protocol which we offer. Understand, अगर psychiatric patient होगा तो क्या होगा, आपको follow ही नहीं करेगा, तो psychiatric patient is ना the bariatric नहीं करी जाती है, ठीक, got my point? तो these two indications, poor family support, drug abuser, of course alcohol abstinence होना चाहिए, smoking abstinence होना चाहिए, और अब अगर ये सब चीजें नहीं कर पाता है तो आपको नहीं करनी है. तो these are 5 things which you should be taken into account. Of course I will be focusing on this one. Types of bariatric surgery, one is the restrictive procedure, other one is malabsorptive. Restrictive means you decrease the capacity of the stomach by any means. Malabsorptive means you have to do something, you directly transposition, you make transposition of the ileum, you directly take ileum and directly with the stomach or some bypass you perform, that is a malabsorptive. But when you combine both restrictive and malabsorptive, that becomes a combination of the procedure, and most commonly that is done. This malabsorptive procedure is most often done, but of course restrictive is also done in cases where someone wants or someone is strict and someone follows very carefully. तो restrictive में बताएंगे कौन सा वाला होता है, किसी की शादी होनी है, सपोज करो लेडी है बहुत मोटी तगड़ी है, उसकी शादी होनी है, उसको चाहता है कि कॉस्मेटिक, बैरियाट्रिक सर्जरी इज per se not a cosmetic indication, you have to understand, it is not a cosmetic indication कि पतला होना है. पतला होना क्यों ज्यादा जरूरी है, पतला होना इसलिए जरूरी है कि उससे ज्यादा रिलेटेड जो प्रॉब्लम है वो ना हो, उसके मन में कहीं ना कहीं ये बिठाना है. इट्स नॉट ए कॉस्मेटिक. कॉस्मेटिक के लिए क्या कर सकते हैं, कॉस्मेटिक के लिए क्या कर सकते हैं, लाइपोसक्शन. इट इज नॉट अ लाइपोसक्शन, इट इज नॉट अ लाइपोसक्शन कर सकते हैं, पतला हो जाएगा, लेकिन फिर अगेन देयर इज अ वेट गेन. In all these procedures also there is a weight gain, problem of weight gain, but of course delayed weight gain. If you stick to the protocol, chances of weight gain is very less. So these are the some of the restricted laparoscopic adjustable gastric banding, laparoscopic slit bypass. These are very common. These ones are, these two laparoscopic adjustable gastric banding, laparoscopic slip gastrectomies, these are two common procedures. Jejunal ileal bypass, ileo-ileal transposition and jejunal-ileal bypass, these were the two procedures originally started for the metabolic surgery, but now they are not in use per se because of more complications associated with this complication, because there is loss of vitamins, loss of minerals, more loss of everything. That is why these are not used. To lesser procedures are used. I will tell you the commonest one of the combination of this Roux and Y gastric bypass, RYG, mini gastric bypass, one anastomosis gastric bypass is another name. Biliopancreatic diversion with or without duodenal switch is the another procedure. This is a more commonly practiced in Western world. Okay, this is a more practiced in. Last one is more practiced where last one. Last one is more practiced in Western world where BMI is more. more than 50, more than 60, like that. Otherwise, if BMI is more than 40 and less than 50, these procedures can be considered. Laparoscopic adjustable gastric bending, this is a more common in again Western world, costlier one. ट्रांजिएंट रिस्पॉन्स इज देयर, बट आपको मैंने बोला ना कि पतला होना है किसी को, तो इस तरह से कर सकते हैं, इसको अप्लाई कर सकते हैं. व्हाट इज दैट? सी दिस इज एनिमेशन. नो, इस पे फिर से जाना पड़ेगा यार. कैसे होता है तुम लोग यार, बार बार इस पे जाओगे. ऊपर ऊपर ऊपर, इसके बाद ये वाला यहाँ. चलो यही चला दो, यहीं से ऐसे चला दो, चलो कोई बात नहीं. इसको पहले क्यों नहीं कर देते हो तुम? चलो ओके. See, this is animation for how laparoscopic adjustable gastric bending is done. These are the port placement. And then visualize the peritoneal cavity. This one is stomach, esophagus, and then what we do, we introduce a band which is wrapped around upper part of the fundus and the cardiac region, and then there is inflatable device which is implanted into the anterior abdominal wall. Depending on what amount of fluid you are going to inject or air, which is here, band takes place, and then that causes the restriction of the stomach. The only problem with this technique is this is a reversible. You can take it also, take it out also. Once the work has been done, weight loss has been achieved, शादी हो गई, बाहर निकाल लो, घर फिर से खाना पीना खाए मोटा कर दो. समझ गए कि नहीं बात को? तो this is altogether, it is a very popular in Western, but it is a costlier one. This one is costlier one. The another procedure is sleeve gastrectomy, laparoscopic sleeve gastrectomy. What happens there? There are few steps. We will be dealing with this in video actually. First we perform gastrolysis. After that we mobilize the fundus we entirely mobilize the greater curvature from all vascular attachments. Then we fire a stapler over the bougie and we make a sleeve, and we perform then leak test, and then later on we come out and put a drain and come out. This is a most commonly, there is a MCQ, what is the most commonly performed surgical procedure worldwide? This is laparoscopic sleeve gastrectomy. This is not Roux-en-Y. Roux-en-Y is the best procedure to some extent, but it is the most commonly performed procedure is sleeve gastrectomy, because this is the easiest one, and of course you can go for it. फिर से तुम्हें वही करना पड़ेगा. तुम बेटा उसका लैपटॉप क्यों लगा देते हैं? तुम ही खड़े रहो. ठीक है, this is animation for the laparoscopic sleeve gastrectomy. What happens once you go? We will be seeing original video of this one, but of course you should understand what is being done here. We perform first gastrolysis on this border, later on we put port here, 5 ports are used usually, and see tension detector or fan detector, whatever you can use. Gastrolysis being performed here with the help of energy source, and after you perform gastrolysis, you put a bougie which is advanced beyond the pylorus, and over this bougie you actually fire the stapler. Okay, this is how it is done. And then of course Roux and gastric Y bypass. What happens here? if a small pouch is created, this jejunum is transected here, and then one limb of Y is connected to the pouch which you have created, another jejunojejunostomy is performed. This is why Ru and Y gastric bypass is a better procedure as compared to the sleeve gastrectomy. The next one. See, this pouch is created, this pouch is of 30 to 60 ml. Jejunum being transected about 60 to 70 centimeter away from the DJ flexor. Then this limb, it is known as elementary limb, which is brought and anastomosed with this one, and then food directly into the elementary limb, and this jejunojejunostomy is performed later on. This is how. This is a Ru and Y arrangement. Another is, this is the most popular nowadays in India, especially in western our parts of northern part of the India. And what happens here? See, directly instead of making a Ru limb, what is done is you directly take a loop quite away from the DJ flexor, about 200 centimeter, and anastomoses directly to the part which you have been restricted. The first part is sleeve is performed, later on this loop is taken directly to that particular area, so that you don't try to make that Ru system. You take 200 centimeter of the ileum, it can go directly. What happens? Food gets absorbed everything, so there is less chance of bile reflux, but of course there is a possibility of bile reflux in this procedure, but of course people have quite good amount of stomach so that they can eat easily. It is also known as one anastomosis gastric bypass. See, this was a sleeve gastric pouch. It is a bigger than the what we create in the Ru and Y, and then this loop is brought there, and then after that it is done like that. The food directly enters into the jejunum. It takes too long pathway so that everything gets absorbed. There is least likely chance of bile reflux. There is a potential risk of bile reflux actually, which is not there in the, bile reflux उसमें नहीं होगा, Ru and Y में. Good. And biliary pancreatic diversion with the duodenal cyst is another procedure. I am not going to show it because it is not practiced in India. It is not practiced in India. It is a practice in Western world only. Okay. This is a video there. I am not going to run it. अच्छा run हो रहा है. चलो ठीक है. ठीक है, okay. चलो आगे ले जाओ. Now there are endoscopic procedures as well. There are endoscopic gastroplasty, endoscopic ballooning. These are the two commonly performed procedures which are done for the weight loss. But the recurrence rate is quite high. And there are some drugs also in the market nowadays, GLP-1 agonist, that is semaglutide, liraglutide, all these drugs are available which can be taken for the weight loss. Weight loss is 15 to 20% of the excess weight loss. What we talk is actually it is a excess weight loss. It is not the actual weight loss. Excess weight loss means कितना weight होना चाहिए मेरा? एक मोटा मोटा ऐसा रहता है कि सेंटीमीटर्स में हाइट को काउंट करते हैं. 50 सेंटीमीटर्स के बाद जितना वेट होता है, हाइट होती है, होना चाहिए. ये कब तक चलता है? 80 तक, 180 तक. जैसे किसी की हाइट मान लो 154 मेरी हाइट है, तो माई आइडियल वेट शुड बी 54 kg. किसी की 162 है तो उसका आइडियल वेट शुड बी 62, like that only. And these are two procedures which are commonly done by the gastroenterologist. And then of course before doing procedures we have to get all this smoking, alcohol, preoperative work loss. And then of course before going for bariatric surgery we have to go for exhaustive evaluation, cardiac evaluation, respiratory evaluation, fat analysis, because fat is the major component of the body which forms a bulk. That is why if somebody is having fat, more fat, then you have to assess it, because there our intention is not to have the protein loss. Understand? If somebody is having weight, the weight because of the body weight is basically given by the bones and protein also, muscle mass. So if somebody is having clear cut weight and no fat, then you need not go for bariatric surgery actually. Of course, there is a risk, principles of management. Actually, I told you there are a lot of procedures here. So what should be the principle? Principle कैसा होना चाहिए मैनेजमेंट का? ढेर सारी प्रोसीजर तो नहीं कर देंगे. तो इट इज वेरिएबल टू पेशेंट. तो इट इज पेशेंट सेंटर्ड प्लान. हमने बताया ना, किसी को मैरिज करनी है, किसी को बीमारी है, किसी को ओबेसिटी से कॉम्प्लिकेशन है, तो सबका पेशेंट सेंटर्ड प्लान होना चाहिए. इट इज नॉट लाइक कि यू हैव टू गो इन एवरी केस कि नहीं आपको वही सर्जरी करनी है. थियरी क्रेटिन एंड एंटी क्रेटिन थ्योरी, हाउ इट इज बैलेंस, कि कैसे क्या गड़बड़ होता है, कैसे वेट लॉस होता है. आई एम नॉट गोइंग इनटू डिटेल. Of course, the treatment is multimodality treatment. It is not a single doctor treatment कि you go to one shop and buy everything. It is not like this. It is a multimodality because psychiatric, physiological, endocrine evaluation, respiratory evaluation, and dietitian, nutritionist, everything is involved. Got my point? It's not only surgeon is only one man in the team. Everyone is there, so that you have to go for. What is the important point here is sleeve gastrectomy से weight loss कितना होता है, रू एंड वाई से वेट लॉस कितना होता है, एक्सेस वेट लॉस, एंड माल ऑब्जर्वेटिव प्रोसीजर से. तो स्लीव गैस्ट्रेक्टमी इज 50% ऑफ, यूजुअली 60%, रू एंड वाई 60%, माल ऑब्जर्वेटिव प्रोसीजर 70%. तो 50 to 70%, 60% is the line average where you can have the excess weight loss after doing these surgeries. I told you LSG is the most commonly performed procedure, and that has to be taken into account. If you are more technically expert, then you can go for, of course, to start with, everyone should start with a sleeve gastrectomy only, because this is the easiest procedure to be performed. The next one, and MGB is the another one. So these are three procedures which has to be started, and malabsorptive procedures which has got the good control over the weight loss along with the morbidity resolution, that is the biliopancreatic diversion, is less commonly performed in nervous setup because it is associated with the mineral vitamins deficiency, all those things. ठीक है, टाइम हो गया कि अभी बाकी है? अच्छा ऐसा है ना, 5 मिनट में वीडियो दिखाते हैं तुम लोगों को. There is a 5-minute video. See, this is a video first when I performed the first surgery. Now, for quite a few years I am performing this surgery. My team is performing, but of course this was the first one. कल क्या बताया, उस दिन डॉक्टर कुलरंजन पढ़ा रहे थे, क्या बताए थे, कौन सा इफेक्ट बता रहे थे, तुम लोग याद हो कुछ हैं? गार्टनर साइकिल बताया था ना. गार्टनर साइकिल में क्या बताया था? पहला प्रोसीजर करते हैं तो बहुत अच्छा होता है, प्रोसीजर करते हैं थोड़े दिन करते हैं थोड़ा और अच्छा होता है, अच्छा हो सकता है. बीच में आते हो लर्निंग के क्या होता है, बहुत ओवर कॉन्फिडेंट हो जाते हो, फिर काफ़ी कॉम्प्लिकेशन करना शुरू कर देते हो, फिर नीचे आता है ग्राफ, फिर धीरे 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 फिर से ऊपर जाता है, देन इट बिकम्स प्लेटू. तो दिस वाज द फर्स्ट रन कर दो. व्हाट दिस इंस्ट्रूमेंट, दिस टेंशन डिटेक्टर स्पेशली डिजाइन नाउ टू is retracted, and see now we have put a bougie and suctioning it so that the stomach is deflated. And then we actually mark a junction, we identify the pylorus here, and then we take 5 centimeter length so that pylorus is not included in the sleeve. Understand? Otherwise there is a more chance for the leak, because pylorus is a spheric system there. So you don't try. And then this cardio esophageal junction, this is the first landmark which we try to, and this is, and then we start the gastrolysis towards the greater curvature, and it has to be juxta stomach actually. When you are juxta stomach मतलब बिल्कुल stomach के पास में, because this when the here, understand? If you are juxta, there is less chance of the bleeding. Then you make continuity dissection to the left crus of the diaphragm, perform full gastrolysis. This is as gastrolase. You deal several cases here. On the right of my pointer is it is spleen. The careful, you should not injure the spleen during the procedure, because that is why I said you, if spleen starts bleeding, it may have to be splenectomy may have to be performed. That is why you have to be very expert, because at times you may have to end up into the splenectomy. That is why you have to take consent also, and then you complete the gastrolysis on the caudal part also. आफ्टर नहीं फायर स्टेटर फायर पता चला कि यहाँ से नहीं पीछे करो पीछे करो पीछे करो पीछे करो पीछे करो this is Boji being advanced. Boji is advanced. This is the stapler. First few green ones, because pylorus area is thicker one, that is why you use green ones. Then either yellow or blue cartridges are fired along with this. This is a powered stapler. This is not mechanical one, this is a powered. Once you fire it, it automatically fires. So what you have to remember most of the time, which firing is done first. It is the firing near the pylorus which is done first with the blue or purple, or sorry, with the green or purple cartridge. Sometimes black, because this has got the highest limb length after closure. Understand? आगे कर दो बेटा. After we have fired it, we actually bed test with the help of sugar to just give a sense of feeling that it will not leak. Otherwise, that may not be necessary in every case if you are confident enough. And see, this is the way their bleeding starts. बस आगे कर दो. ठीक है? Last time when we operated on 26 January, I had a leak. That leak, actually this is the worst complication which ever can happen, and because of this only people are afraid not performing for the bariatric surgery. So that leak happened, and to a VIP person, it was the mother of a medical student. That leaked. Ultimately I was worried a lot what to do, because we have one facility for the endoscopic management or everything. There are facilities the endoscopic place and lavage. We went for lavaging it. On kar do beta. This is the scene inside of the abdominal cavity. Encounter. Leak is actually identified with high index suspicion. If patient is not doing well in a second or third post-operative day, it means patient is having leak. Understand? It's only clinical suspicion where you can expect. Otherwise, patient starts taking, and because you start only on the next day. Understand? See, this is the point. There was no space. There was lot of fluid. So we successfully make out the point of fluid. This 1 minute video. Don't worry. So on 1st January, I started my journey like this. For this, it was being managed with us. For the God's sake, it survived and is doing well, and now she has lost 20 kg of weight after 6 weeks of surgery. After 6 weeks of surgery. So this was leak, and then we performed saline test, and that bubble came, and this is the leak site. Okay, this is the leak site. What are the options for leak management? You have to do thorough identify it, try to, if it is not older one, if it is not too old, you can directly, if it is an old one, you have to convert into bypass. Now after stitching, you have to convert into bypass, so that the restrictive component like pylorus is bypass, so that it heals later on. Or you can, it can be dealt with the endoscopically also. You can put endoscope inside and stent it, and put a lavage, give a good lavage and come out after putting a drain. This is the leak after we repaired the leak site. This was done with the help of interrupted vital switches. This is not V-lock. Don't use V-lock for the repair of these kinds of leak or secondary anosmosis. Understand? They will bite. They will give a bite. Now, because they have got serrations and cutting edge. Understand? This is what happened. And we bypass that leak also with the momentum there, and this is all. So that means complications are always there for any surgery. Leak, bleeding, stenosis, kinking, all these are the complications of the bariatric surgery. So you have to be careful for the complications also, you have to be ready for that. Okay. And we did intra-op endoscopy for if there was any further leak or anything happening inside the stomach. We did intraoperative endoscopy on that day also. Okay.
Thank you, sir, for your informative talk. Now I would like to invite Professor Suresh, sir, for felicitating Abhi, sir.
अच्छा मुझे फेलिसिटेट भी करोगे?
Now I would like to invite Professor Arshad, sir. He was ex-professor in the Department of General Surgery, KGMU, and he's a renowned colorectal surgeon with around 25 years of experience. So over to you, sir.
Good morning. First of all, I must thank my colleagues and seniors in the department for giving me this opportunity to visit the department again. Until last couple of years back here, and I still miss all the activities in the department, and I try to make it possible to come at every opportunity, because teaching and training and learning, because we all are a student in different stages throughout our life in our profession. We remain students, we keep on learning, refining our skills and learning new things, because medical science is a dynamic subject and you keep on learning throughout your life, and the day you stop learning, you stop growing. So at the outset, I thank my department, my colleagues, and all my students and patients who have contributed in whatever I am trying to do today. And anal fistula is it's not coming. Sure. Okay. इसको लगा दीजिए आप, हाँ इसको लगा दीजिए, डायरेक्ट लग जाएगा. इसको अपना इसमें लगा, देखो है कि नहीं, है कि नहीं है. So, we will discuss today about a problem which is quite common and very diverse. Anal fistula is a very diverse disease, extremely diverse disease. I have been doing this so many cases for last several years, and still I find this disease very challenging sometimes. Sometimes it's a very simple disease, requires only 10-20 minutes treatment, all the patients heal well. And sometimes disease is so complicated that patient comes to you already has been operated 4 or 5 times and still the disease is not cured. So it's a very diverse disease. If you look at the etiology, majority of anal fistula are primary in nature and they are of cryptoglandular origin. I'll tell you what is cryptoglandular origin. More than 95%, approximately 97-98% of fistulas, they are of cryptoglandular origin and they are considered to be as primary fistulas. 2 to 5% fistulas may be secondary in nature, where there is IBD, Crohn's disease, could be tubercular, can be malignancy or post-traumatic. And then there is another variety of fistula where there is a multi-system involvement. There can be involvement of vagina, there can be involvement of coccyx, there can be involvement of urethra, which further complicates the situation. Now, this is a cryptoglandular, this is an anal gland here, and this is the gland where infection starts, and these glands are located in the intersphincteric plane. So, the initial event in development of a cryptoglandular or a primary is the infection of anal gland. And once this gland gets infected, it can lead to a formation of abscess, which is initially an intersphincteric abscess between the two sphincters in this space, and then it can spread to suprasphincteric space, extrasphincteric space, perianal space, all around in a horseshoe manner, post-anal space, because there are so many potential spaces around the anal canal. So, the disease process can grow and it can spread in various potential spaces, and the fistula, which is the result of this sepsis, will be accordingly, if the spread is not so much, it will be a simple fistula. If it has spread to many spaces, it can lead to a complex fistula, which may violate various parts of sphincters. Because the disease involves anal sphincters, that is why the treatment is even more challenging. Now, I am showing you few pictures of secondary fistula. This is fistula involving coccyx along with coccygeal osteomyelitis, which may be tubercular in nature. Crohn's disease, the incidence is rising in India. So, any eccentric fistula, unusual fistula, you should always think of Crohn's disease. Tuberculosis is quite common in India, and this disease involves sometimes there is tubercular fistulas, malignancy. Then a primary fistula can be very complex, where the disease has spread to, you can see, up to abdominal wall, up to scrotum, up to flanks, up to thigh. You can see all this disease is primary, but the disease is spread, the extent of disease is so much that it has made the treatment very challenging. Then patients come with previous treatments, which are often by unqualified people sometimes, and they make the situation even more complicated. And a poor management, previous poor management, patients with pre-existing incontinence make the situation even more complex. And sometimes, like this, a gorged piece was found inside the fistula cavity because of previous surgery. Sometimes there is a dilemma in diagnosis. This is a anal diverticula, which is confused as fistula. So, you should always have a high index of suspicion whenever you are finding unusual fistula, eccentric. This could be either a secondary fistula or even a complex primary fistula. So, now what is a simple fistula? Simple fistula is one where the sphincter complex, because anal canal is surrounded by 2 layers, 3 layers of muscles rather, but 2 layers are important. One forms the internal sphincter, which is the circular muscle layer, and there is a new muscle from pelvic floor downwards, which forms the external anal sphincter. So, now these muscles are important for the function of continence, because fistula violates these sphincters. That is why it is important to treat the fistula. It is challenging sometimes, it is if it is violating substantial part of a sphincter, because the lower part of a sphincter, less than 50% or 30% anteriorly, if we divide, it will not lead to incontinence. So, those fistulas which are involving lower part of a sphincter, they are considered to be simple fistulas, but less than 50% of the sphincter complex or less than 30% anteriorly, they are simple fistulas. To be as complex fistulas, because dividing that part of a sphincter will lead to issues with continence. So, low intersphincteric, low transsphincteric, these are simple fistulas. The remaining are complex because they are involving more muscle. Now, what are the factors which lead to complexity of the disease? First of all, fistula is a disease where there is an external opening, there is an internal opening, we all know, and there is a epithelialized tract in between. Now sometime the internal opening, because in all the primary fistulas, the internal opening is always at the dentate line or pectinate line, because that is the place where anal gland opens. It is very unlikely to find high internal opening, but sometimes we have secondary high internal openings which can make the situation more challenging. And sometimes internal opening is not found. It is there, but it is not demonstrated. We are not able to find. So when the source of infection is not found, again the situation is challenging. Then disease extensions. Basically the disease extends in three planes: intrasphincteric, extrasphincteric and extraperitoneal or suprasphincteric. Now intrasphincteric is the initial, because it starts in the intrasphincteric plane. So sometimes it remains in the intrasphincteric plane, may go cranially, may go in a horseshoe manner, but still within intrasphincteric plane. It can go to extrasphincteric areas, that is outside the external sphincter, making it a transsphincteric fistula, or it can go suprasphincteric, remaining extraperitoneal right up to abdominal wall, flanks, scrotum, all those areas may be involved. So these are three dimensions or three layers in which the disease may extend. Then as we said, 2 to 5% fistulas may have a maybe secondary. So you may have a primary disease like Crohn's or tuberculosis, so that also needs to be addressed. Then multi-system involvement also makes the disease challenging. So many classifications of fistula are being used. The most frequently and widely practiced classification is the Parkes classification, which classifies the fistulas into intrasphincteric, transsphincteric, suprasphincteric and extrasphincteric, like you see in these pictures. But actually this first picture you see, this is also intrasphincteric, this is also intrasphincteric, but this one is very complex. So type 1 or grade 1 fistula may be sometimes very simple and may be very complex. So the classification does not extrapolate into your clinical challenge or outcome. So you have to see the complexity of disease by mapping the disease and correlating its extensions and its relation with the sphincter complex. It is not always the classification ki grade 1 is simple, grade 1 may be also be complex. Similarly, this is type 2. So you can see this is type 2, but this type 2 is simple and this is more complex. So the classification is all the classification, they have their shortcomings, but still this is the most widely, this is suprasphincteric and this is extrasphincteric. Extrasphincteric is mostly secondary fistulas. So now in this picture you see this red line which is drawn. This is just a diagram, this is the anatomy picture and this is a imaging. So you see this line, the fistula which remains below this line, they are considered to be simple fistula, because this part of a sphincter, this is subcutaneous, this is superficial part of external sphincter, you can divide without causing incontinence. So these are simple fistulas. This is deep part of external sphincter and this is puborectalis. So if any fistula which is violating this muscle would be a complex one, because if you divide this part of muscle, it can lead to some degree of incontinence. So again you see in this picture also. Now how do we assess? The planning starts right from the OPD, where you see the patient. The OPD examination is the first step, followed by imaging and followed by examination under anesthesia. So in OPD examination, you see the external opening, you see the internal opening, you try to find the tract. Sometimes fistula is so simple that you can feel the whole disease between your two fingers. So in these patients, imaging is not required. You know it's a very simple fistula, straight away you can post him for surgery. Now sometimes the disease appears to be complex, then you need imaging, where you have three options. The X-ray fistulography is obsolete because it's very low accuracy, low sensitivity and specificity. Then you have two modalities. One is perineal ultrasound along with endoanal or endorectal probe, 360 degree, and the other is MRI. MRI is gold standard as of now because it is most sensitive and most specific, more than 90%. Still you can miss internal opening and complete extent of disease in up to 10% of cases, but still out of all the modalities, MRI is gold standard as of now for diagnosis and assessment of anal fistula. So this is X-ray fistulography, not done. Now in MRI we have three views, basically three sections: axial, coronal and sagittal. Axial view tells you about the transverse extent of disease, whether it is intrasphincteric or it is extrasphincteric or it is horseshoe. Now you can see in the first, this is the axial view, it is showing you horseshoe disease in the intersphincteric plane. This is the internal sphincter, this is the external sphincter, this is the intersphincteric space. This is the axial view and you can see horseshoe disease. This is a coronal view which tells you about the vertical extent of disease. This is puborectalis or pelvic floor. This is the lower part of the sphincter. So this is the height of a sphincter complex. Now you can see this is the 50% as we saw in the previous picture, and the disease is going above lower half, that is above 50%. So it's a complex disease. This is a sagittal view which is showing you the postanal space. This is intersphincteric space. This is postanal space, where if you draw a line from tip of coccyx up to here, it is anococcygeal raphe. So this would be superficial postanal space, deep postanal space, supralevator space, precoccygeal space. So you have to see all the three dimensions in order to map the disease, to have a three-dimensional picture in your mind when you are planning treatment. Additional workup is not required in all the patients, it is selective. When you are suspecting some other secondary cause like tuberculosis, like Crohn's disease, you can go for CT angiography. If there is likely involvement of urethra, we can go for MCU-RGU. If abdominal wall involvement is there, a CT abdomen may be there. Anal manometry, cystoscopy, TruNAT or RT-PCR, full colonoscopy, fecal calprotectin. These are all when we are suspecting Crohn's or IBD. So identification of internal opening, as we said, once we have done all the workup, we have done imaging, then the challenge is to map the disease, and for identification of internal opening, digital examination where dimpling, puckering, imaging as we said up to 90%, and then finally examination under anesthesia. Probing should never be done in the OPD, it should be done in under anesthesia. If at all it is done, we do probing, we inject some contrast from the external opening and see where it is going, injection of hydrogen peroxide, and then we have modern gadgets like a fistuloscope, like a video, which we can introduce from the external opening. You can see this is a modern gadget, that is a fistuloscope. We see inside the tract, and it can also help us not only mapping the tract but also finding the internal opening. You can see the light of fistuloscope reaching up to internal opening. And sometimes fistula has multiple secondary tracts, not a single tract. So fistuloscope can also help us in assessment of disease in order to find any secondary, like in this patient you see a secondary tract. Sometimes there is a high internal opening, like you see in this patient, there is a high internal opening. This patient was actually a surgeon, and you can see in the imaging also this is going up. So this is the pelvic floor area, and here you can see this intersphincteric dissection was done already in this patient. Now after doing examination, anesthesia, mapping, finding internal opening, come the management part. Management planning should be done on table after examination and anesthesia, and with all the backup you have, imaging, clinical examination has already been done. Now you have to decide what treatment you are going to offer. Now see, basically there are two types of treatment. One is a sphincter cutting, one is a sphincter preserving. Sphincter cutting means you remove the fistula from inside out. Everything is removed by cutting the sphincters, and then you leave the wound open. This is called as fistulotomy or fistulectomy. This is the ideal treatment for a simple fistula, because cutting the sphincter, you can remove all the disease. The chances of cure are almost 100% because everything has been removed. No disease is left behind. The only issue is a wound which will heal in due course of time. But because there is no disease left, so hardly any chance of recurrence. But this treatment is suitable for simple anal fistula, and all the practice guidelines across the world, they recommend should be the ideal treatment for simple fistula. For simple fistula, no fancy treatment. People are very fond. Every patient comes to us and tells, I want a laser treatment, such as laser spells some magic. It doesn't do anything. Laser has got very limited role in fistula. We use laser in all our surgeries, laser is there, but it is not a magic stick. People come, I want robotic treatment for fistula. So these fancy names are now everywhere on the internet, and people read these names and they think that this will do some magic on me. Nothing like that. You have to do scientific treatment, you have to educate the patient, you have to tell the patient and the right thing. So fistulotomy or fistulectomy still gold standard for simple anal fistula, all practice parameters, including Indian practice parameters. I was part of developing Indian practice parameters for anal fistula 3 years back as part of ACRSI, and we went through all the literature and we found that treatment for simple anal fistula. Then comes the issue of complex anal fistula. Now in complex anal fistula means it is involving, with the permission of chair, I will take 5 more minutes. I will not show videos, but I will just, at least the concept should be clear. So for complex anal fistula, again you have 2 options. One is doing a fistulectomy, and the other is treating the fistula without cutting the sphincter. Now if you are doing a fistulectomy for a complex fistula, it means you are cutting more than 50% of the sphincter. Now if you are cutting more than 50% of the sphincter, then patient will have, and you leave the wound, allow the wound to heal by itself by secondary intention, then patient may have, wound will heal undoubtedly over a period of time, but patient will have some issues with continence. If not gross incontinence, that may be stress incontinence, maybe incontinence to flatus or liquid stool. So to prevent that, you have to repair the sphincter back, which is called as fistulectomy and primary sphincter reconstruction. That should be done at the same time. You do fistulectomy and you repair the sphincters. That's what we do as one modality. The other is treating the fistula without cutting the sphincters. That is called as a sphincter preserving surgery. And you see here for complex anal fistula upstream, this is FPSR, that is fistulectomy and primary sphincter reconstruction, and this is sphincter preserving procedure. Now sphincter preserving procedures are many. There is no single procedure which is suitable for all the cases, which gives optimal result. Many procedures like waft, lift, laser, and so many. Every now and then new procedure is coming up, plaques and glues and mucosal flap and whatnot. Everybody comes with a new procedure, but most of them or many of them have failed. Some of them have stood the test of time. We are mentioning only those which have stood the test of time, and there is enough literature, class 1 literature, to support that they can be used as a modality, as a standard of care. So which includes lift, video assisted treatment, laser, not very good, but we use it, advancement flap. So they all have varied success rate. For secondary fistula, you have the option of medical treatment along with surgical treatment. So now various sphincter preserving procedures, fibrin glue and collagen plug, where you occlude the fistula tract with these materials, but these procedures could not give optimal or expected success. They failed actually. So now they have been abandoned. We don't use them anymore, but the procedures which we are still using, and you can also see the grade of recommendation of level of evidence. So mucosal advancement flap, lift and waft, these are the 3 procedures which are now we use them as a frontline procedures for sphincter preserving techniques. Filac or use of laser, still there is no evidence that it has got any benefit, but people use it. We also use it as a part of our treatment, sphincter preserving treatment. Now what is the principle of, just one more slide, just what is the principle of a sphincter preserving technique? See, in a sphincter technique, we are removing the fistula from outside in, that the whole disease is excised, removed. Either we leave it open in simple fistula, or in complex fistula we reconstruct, that is we do sphincter reconstruction. When we do sphincter preserving treatment, means without cutting the sphincter we are trying to treat the fistula. Techniques are many, but concept you should understand. Concept is central disease elimination. As we said, the fistula has intersphincteric disease and extrasphincteric or suprasphincteric disease. Now the source of infection is intersphincteric because the disease process starts from there. So if we are not cutting the sphincters, then intersphincteric disease has to be eliminated. It has to be removed. We have to get access to intersphincteric plane without cutting the sphincters by so many procedures, by lift or by waft, remove the source of infection. And the extrasphincteric disease, which may be on one side, both sides, going up to thigh, going up to legs, going up to back, going up to abdominal wall, all that disease can be treated with other modalities like waft or like curettage. So extrasphincteric disease you can treat by whatever tools you have, but most part is to cure the intersphincteric central disease which is the source of infection when we are trying to treat the fistula without cutting the sphincters. This is the concept of a sphincter preserving surgery. Just by putting a laser and ablating from inside out, it will not treat the fistula, it will not cure the fistula. So it's a disease which is known for its high recurrence, and the reason of recurrence is when the disease is not addressed in a scientific manner. And the scientific manner is either you remove the whole disease or you remove the central disease, that is the source of infection, if you are doing sphincter preserving surgery. I will not show the videos, there are many videos, but as a students you should know the concept, not the technique. You have your entire life and career ahead of you to see those techniques. There's so many videos are there. Abdominal wall, I'll just skip all these slides because if you have any questions, I would like. For these videos, you have plenty of time ahead of you to see these videos. So I will stop here, and once again I thank all of you for your patient hearing. So this is the video assisted treatment for a fistula which is reaching up to thigh. So I will not go in details. Another abdominal wall. This is central disease elimination from the intersphincteric plane. Just show you that this is how we remove the center, and the rest of the disease we treat with a fistuloscope, or this is a laser fiber. So this was the concept basically which we wanted to, because this is a disease where there's so many treatment options, and when so many options are there, it means none of them is perfect. Because when you have a perfect option, it becomes a gold standard. Like in gallstone disease, lap chole is gold standard, because this is one treatment option. Every one of you will say, I will do lap chole. But for a complex fistula, somebody will say, I will do waft, he will say, I will do lift, he will say, I will do self-lap, he will say, I will put a seton, somebody say, I will put a char sutra. If you go to 5 surgeons, they will have different, they will give you different options, and at the end of the day, it's confused that what to do, what not to do. So it is not that what to do, it is the scientific treatment that we should do, that will give optimal results. Because none of these procedures, as at the end of the day, said will give optimal results. What to do, what not, unless you address the. It is not that what I do of disease. That concept you have to understand. The scientific treatment that we treatment in a scientific, that will logical manner, then your outcome. None of these procedures, as we said, will give optimal results unless you address the source of disease. That concept you have to understand, and if you do treatment in a scientific, in a logical manner, then your outcome is going to be better. Thank you so much. If you have any questions, we can address them now.
Thank you, sir, for your informative talk on fistula and nano. So now I would like to invite Amin for felicitating Ashok, sir. So now I Professor J.D. Rawat, sir, for his lecture on hypospadias. So now Professor J.D. Rawat, sir, for his lecture on hypospadias. So Professor J.D. Rawat, sir, is head of Department of Pediatric Surgery in KGMU. And he has Professor J.D. publications in various departments of pediatric surgery in AGMU. Is an excellent teacher and he has published numerous publications in various international journals. And he's an excellent teacher and an excellent surgeon.
इसमें 2 हो गया ऊपर से ऊपर वाला हाँ इसमें अप डाउन का बता दिया अच्छा नहीं इसमें अप डाउन का बता दिया so pointer will be on this or there अच्छा अच्छा ठीक है fine so pointer will be on this or there okay So, good morning everyone. At the outset, I would like to thank the organizing team. At the outset, I would like to thank the organizing team, Dr. Arun Paljat and Sonkar, entire team of the secretary for giving this opportunity, entire team of the present my talk, this opportunity, the management of hypospadias, present my talk, and the management of the most common and the complex and this is one of the most common is and the complex problem. Look, the incidence, the most common is very high. That if it is the around 50 to is very high. It is around 250 live to 300 per the complex live male birth, and that more than 100 operation has more than 100 operation has been described for the management of hypospadias. But none of the single operation is sufficient to manage all type of hypospadias. So you can look the gravity and the complexity of this problem. So over 10-15 minutes, I would like to cover this topic. By these heading, that is the introduction, surgical anatomy of the hypospadias, brief about the embryology, etiology, classification, and surgical procedure, and what are the common complications which we face after repair of the hypospadias. So, as I told you, this is the common and complex problem, and and this is basically developmental anomalies where there is a embryological development of the penis, that is the urethra, corpora as well as the prepuce, and incidence I have already told you. So, brief about the surgical anatomy, there is a triad of the things which are present in hypospadias. As by definition you all know, the hypospadias is nothing but abnormal urethral opening on the ventral aspect of the penis, right from the glans up to the perineum. This is the one which is invariably by definition. And second thing is that abnormal ventral curvature of the penis, which is known as cardi, and it is present around almost 50% of the patient. And the third one is abnormal distribution of the foreskin with the dorsal hood. This is known as a hooded prepuce or caved prepuce. Beside that, there is another things which are present, and you have to know this. This is basically the, you can see the spongiosum where urethra is lying, and there is a bifurcation of the spongiosum here, and there is a usually pseudo-urethra in between from the external urethral meatus up to this part, and there is a good urethral group. So these are the things you must remember when you are planning for surgical intervention of these patients. The second one is the surgical anatomy is the blood supply, which is most important because we are basically taking a different type of flaps either from the prepuce, inner preputial skin, or sometimes outer preputial skin. So you should know the blood supply. The majority blood supply of the penis shaft is basically supplied by the branches from the internal pudendal, and the prepuce as well as the penile skin is basically supplied by the branches of the external pudendal, which is a branch of the femoral artery. Brief about the embryology, there are two stages in the development of the penis. The one stage is known as hormonal independent stage, that is the initial 8 to 12 week, where you can get a formation of urethral plate in the midline and along with the genital tubercle. Up to this stage there is no difference in the genitalia of the male and the female, but the second stage is known as hormonal dependent stage between 12 to 16 week, where there is a secretion of testosterone that converted into dihydrotestosterone in the presence of alpha reductase enzyme. So in this situation there is a elongation of the genital tubercle and the fusion of urethral plate in the midline, and that finally form the urethra. And the glandular part of the urethra is basically there are two theories for the development. One is either ectodermal ingrowth that form the urethral this glandular urethra, or there is a tubularization of the urethral plate which is coming from proximally and going down up. So there are two theories for the development of this. This is the diagram which you can see that up to 8 to 12 week there is no difference of the genitalia, but presence of testosterone that converted into dihydrotestosterone is finally go to the male side, and if there is no testosterone, ultimately that grow into the female side. Now coming to what are the etiology of the hypospadias. 80 to 90% cases there is no etiology found, meaning by it is unknown, but around 10 to 15% cases there various hypotheses has been given. One is the genetic cause, and it has been seen that around 4 to 10% there is a history of familial incidence, and it has been seen if the one family member is affected, the incidence is around 14%, and if members is affected, then incidence is around 21%, and 10 to 15% there is a other anomalies in these cases like renal anomalies, gene mutation, not much detail. Hormonal causes mean that the any androgen metabolism disturbance that can lead to the development of hypospadias as well as the micropenis, and that is the things like less formation of androgen, you can say, or there is a less receptor for action of the androgen, or there is a alpha 1 reductase deficiency documented in cases of hypospadias. Environment factor, especially pesticide and industrial chemical, where there is a lot of estrogens are there, and that exposure lead to the hampering the development of the testosterone. That group of the patient may develop higher incidence of testosterone. Maternal age more than 35, diabetes, and anti-epileptic initiative for the more exposure of the development of hypospadias. And more than 200 syndrome has been described in relation to the hypospadias, and I am not going to detail for that, but coming classification of the hypospadias. The hypospadias basically there are many classification has been mentioned. The most commonly accepted classification is that the presence of external urethral meatus on the ventral aspect, you can enumerate the name like glandular hypospadias, subcoronal, distal, mid-sap, so go up to the perineum. This is the best accepted classification. And if you look the incidence of these hypospadias, around interior hypospadias, you can say distal hypospadias is 70% incidence, and the middle is 10%, and the posterior is the 20%. So making the diagnosis of hypospadias, as I told you, three most important: ventral urethral opening, hooded prepuce, and presence of the cardi. Beside that, you have to also look for the size of the penis, and you have to look for the downward tilt of the glans. Glans group is most important. Penile rotation, bifid scrotum, pinoscrotal transposition, and associated anomalies like undescended testis, inguinal hernia, and the renal anomalies. These are the things which is important. The special things is that is the glans group. You can see in the photographs that if groove is good, then you can plan the procedure accordingly, and if glans groove is shallow, then you have to plan another technique. It is not suited for all single technique in all cases. So these are the different type of hypospadias which we are looking in day-to-day practice in OPD. So from distal penile to mid penile to proximal penile hypospadias. Now what are the investigation which require before surgical intervention? Not much require. We go routinely for blood and urine examination. Urine is the most important to rule out the presence of infection, because that is the things which are related to your surgical procedure. Hormonal assessment, electrolyte and chromosomals are very much restricted only when you are suspecting DSD, disorder of sexual differentiation, where severe hypospadias with or bilateral undescended testis, especially proximal penile hypospadias, then you think for these investigation. And even ultrasound and cystoscopy is also restricted in cases where you are suspecting Mullerian remnant, which is a remnant of prostatic ventricle, which is mostly seen in the pinoscrotal and perineal hypospadias, and ultrasound just to rule out associated renal anomalies. Now what is the goal of hypospadias repair? Why we want to go for repair of hypospadias? There are 2-3 reasons. One reason is that patient is micturate as man is micturate in standing position, number one. Second thing is presence of the cardi, there is a painful erection and bending of the penis on the downward. And third one is, I suppose the urethral opening present on the mid penile, proximal penile are more than that, then it is not able to ejaculate the semen at the right place. So these are the issue you have to address. And what are the ideal time is 6 to 18 month, and because of the quick healing, fever scar, less stress to the surgery. And there are three most important components of the hypospadias. One is that if cardi is there, then you have to correct the cardi, which is known as a arthroplasty. Second is that you make the urethra up to the tip of the glans, and that is known as urethroplasty. And third component is meato. The other thing you can submit like skin coverage, as well as the have a that transposition of the scrotum or bifid scrotum, then you can go for the scrotoplasty and other things. Now, what are the cardi? Cardi is basically a ventral curvature of the penis, and this is present because of the these four type of the cardi is there. The most common is the skin cardi, that is the tethering of the skin. It is present around 32% of the cases. Then fibrotic fascia, fibrosis of that Dartas fascia or Buck's fascia, that can lead to the formation of fibrous tissue and leading to the bending, 33% cases. Then corporal disproportion and congenital short urethra. These are the things where cardi will be there. And normal cardi which are accepted in hypospadias less than 20%, and if it is more than that, then you go for the surgical correction. And this is the way we you can measure the degree of. Now, how to correct the cardi in hypospadias is that this test, which is known as artificial erection test or McLaughlin and Gitty test, it was described in 1974, that under general anesthesia you deglove the penis, put a tunicate at the root of the penis and inject a saline, and then you can see the degree of cardi curvature, and then you measure the degree of cardi, and accordingly you can plan the treatment. Most of the skin cardi is get corrected simply by degloving of the penis, but if it is fibrotic like second stage, then you have to release the fibrous band which are present on the ventral aspect, and if it is more than that, there is a many option for correction of this cardi, dorsal plication like Nesbit and Buskin. All procedure has been described. These are the various procedures which have been described for the cardi correction, but second and third, the most commonly we use for the cardi correction. Now, how you will do the urethroplasty after correction of the cardi? Second stage is the management of the urethroplasty. The urethroplasty is basically done in the three settings. First setting is that you have to preserve the urethral plate as much as possible. If it is possible, then you go for the tubularization or other method of urethroplasty. Second is, if the urethral plate is not well developed or cardi is developed, you have divided the urethral plate, then option is that you can use a local tissue, that is the prepucial flap, inner or outer prepucial flap, and you can use that. In the last one is that if no local skin or prepucial flap is available, then you can go for the graft, and most commonly graft which we are using is the buccal mucosal graft. We can show further. So, in cases of distal penile hypospadias, there are various technique has been described, because I told you that there is no single technique by which you can repair all type of hypospadias. So, you have to look the surgical anatomy and plan the procedure according to the hypospadias. So, if the glans group is very good, or you can say there is a mega meatus, then you can go for the gap urethroplasty. We will show the some diagram also. Then you can go for the magpie metal advancement granuloplasty, then Thier's duplet urethroplasty, Matthews flip flap urethroplasty, and the last one is total or partial urethral mobilization. These are the procedure which is described for the distal penile hypospadias. For the mid penile hypospadias, you can use the only island flap or tube depending upon the urethral plate, and then tip urethroplasty, which is most commonly used, will take another 5 minutes to finish it. Approximate the glans after deglubbing the penis, and then this procedure is known as a gap urethroplasty. The second one is the MACPI, metal advancement galloplasty, vertical incision, then transfer stitching, then glans mobilization and closure. That is the MACPI procedures. And this is the one of the operative photographs. You can see there is a incision and then there is a complete procedure of this MACPI. Then Matthews is basically flip flap procedure. You can take a flap from just below the external urethral meatus, and the prerequisite for this is that the proximal skin and urethra should be normal, so that you can raise the flap. If the skin is narrow and the urethra is pseudo urethra, you cannot make the flap. So this procedure is applicable in selected cases. Then we coming to the prepucial onlay island flap. When you are preserving the plate, you can make a flap from the inner prepucial skin, rotate downward, and then you complete the urethroplasty. The another is that if patient have a severe cardi, you have removed the urethral plate, divided the fibrous tissue, corrected the cardi, then you can make a tube from the inner prepucial skin, rotate downward and complete the urethroplasty. And this is basically two procedure which has been described. One is the ducket procedure, another is the ASOPA. So in ASOPA, the first right, this picture is basically ASOPA technique, and that one is the ducket procedure. So you must know difference between ducket and ASOPA procedures. Then tip urethroplasty is tubularized inside plate urethroplasty. This is most commonly done when there is a good urethral plate is there and there is no cardi. In that situation, you make the incision like this, and then you do the urethroplasty and then spongioplasty followed by Dartas flap, or sometimes you can use the process vaginalis flap to cover the urethroplasty, and the incision which urethral plate is starting 3 mm just below the tip of the glans, so that there should be no narrowing in the glans. So this is about the tip urethroplasty. In proximal penile hypospadias, the management is usually depend upon the surgical anatomy of the proximal penile hypospadias. If it is a good urethral plate, then you can go for the single stage repair, either tip urethroplasty or you can use a flap urethroplasty. But if it is a cardi associated, then you can go for the first stage cardi correction, and second stage you can go for the urethroplasty. So after correction of the cardi, you can go for the Barr's flap, buccal mucosa or bladder mucosal or dermal patch. These are the various technique has been described for the proximal penile hypospadias. This is the buccal mucosal graft. You can take the buccal mucosa from the lower part of the cheeks or inside the cheek, and then you do the after correction of the cardi, you put this flap over, this graft over that, and after 6 months onward you can go for the urethroplasty. So after doing the urethroplasty, you have to reinforce your urethroplasty by applying the another flap which is known as corporal spongiosum flap. You can use it. You can use a Dartas flap, or you can use a tunica vaginalis flap. By using this flap, you can reduce the incidence of fistula formation. So this is the uncommon type of hypospadias. One is known as a concealed hypospadias, where you can see that the prepuce is totally intact and there is no cardi, but once you retract the prepuce down, you can see there is a megalourethra like things. So it is also known as a MIP, means megameatus intact prepuce. This is the one terminology that again require a sort of urethroplasty, and that right side in that you can see is known as a cripple hypospadias, where multiple surgery has been done and patient is still have a problem of incomplete cardi correction meatal stenosis, loss of skin and erectile problem. So these group of the patient basically require a stage procedure, and this is a short note usually get you in your examination also. So post operative, after doing surgery, lot of dressing has been described for the management of hypospadias, and the purpose of this dressing is to reduce the edema as well as the hematoma formation that ultimately lead to the infection formation. So you can use the tule grass or silicone foam, or you can use elastic bandage. So either you can cover whole of the dressing, or you can do the partial dressing, and then catheter is out after 7 days, and antibiotic basically we are giving for 7 days, and then oxybutynine and laxatives will be given to reduce the bladder spasm and the bowel motility to be continue. Complication, we all know, these all depend upon the severity of hypospadias, surgeon experience, and the various material which we are using in the repair of the hypospadias, and these are the complications as you are is common in other hypospadias or other surgical procedures like bleeding, infection, hematoma, common things which we are getting is that is the fistula formations, or sometimes the glands dehiscence, and that require later on repair after 6 months onward. So thank you very much for patience hearing, and I am happy if anybody ask any query, although we have exceeded the time. I am sorry for that.
Thank you, sir. Now I request from the state, sir. Now I request Professor S.N. Kuril, sir, to have a lecture on anorectal malformation. He is professor in the Department of Pediatric Surgery, KGMU, neonatal surgery, pediatric surgery. The government of India awarded him with the fourth highest civil honor of Padam Shri in 2016 for his contribution to medicine. Welcome you, sir.
Yes, sir. So, without further delay, I will straight away go on to the presentation, that is decision making in male anorectal malformation and its management by posterior sagittal anorectoplasty. Anorectal malformation is one of the common birth defects in India. It is occurring almost 1 in 1500 2000 birth, and when let it be a pediatrician or let it be a general surgeon, let it be a pediatric surgeon, the most important thing in presentation is what is the correct management of this baby. So, with the help of forthcoming slide, I will take you through the virtual experience of malformation. Come to you for management. This one, yeah, has come to you for management, so that of course for relief of obstruction and anorectal reconstruction, of course with correction of associated anomaly, and anorectal malformation should be corrected in such a manner so that not only the appearance is normal, but
function is also normal in terms of control of defecation, right. So, they are just saying that journey of 1000 miles must begin with first step in and management of anatomical malformation depends upon the correct. So, what is the correct decision? And for that, let us have look at these two kinds of internal anatomy of anatomical malformation. See, from outside, see here also the anal orifice is absent, and from outside here also the anal orifice is absent, but on this side the sphincter development is variable and the rectum above the levator ani muscle has taken anterior course to open anywhere in the bladder, neck or in the prostatic urethra or in the bulbar urethra. While in this case the rectum has formed, anal canal also has formed. It has traversed the well developed sphincters, but it has not opened here, right. So, decision in entire process of decision making, you will have to distinguish this kind of anomaly from this one, right. So, because this one needs a simple perineal anoplasty and the prognosis is very good, then this one needs 3-stage procedure, and that is the first stage colostomy, that is the diversion and relief obstruction, and of course, at the age of 4 to 6 weeks definitive repair, and then followed by colostomy closure later on. So, how do we reach such correct decision? So, it is the very most important thing is that by careful perineal inspection, if we find that anal orifice is absent, then there are 3 possibilities. 1, there is some external evidence to tell you the internal anatomy, and second, there is no external evidence to tell you the internal anatomy, and rarely there is normal looking ARM also that also have anatomical malformation like rectal atresia and imperforate anal membrane. So, see the evidence of external, what kind of external evidence? So, if you place the baby in good light and examine the perineum from the tip of coccyx and follow along the midline anteriorly, and somewhere you will find the opening in midline either in the scrotal median raphe or somewhere anterior at the anterior side of anogenital triangle here. And if this is the sign, then we know that the internal anatomy is like that, the rectum has and canal has formed and has opened here, and this is that is the low anatomical malformation and management is a simple perineal anoplasty. If you can see the fly speck of meconium, these are the epithelial pearl, right. So, even if you do not see this fly speck of meconium and see only epithelial pearl, then also the internal anatomy the rectum is formed, anal canal is formed, and this is manageable by simple perineal anoplasty. Then here blue line and median raphe here, or if you see only epithelial pearl, both these cases can be managed by the perineal anoplasty without the need for diverging colostomy. And here hidden in between the fold here, you can see the punctate anal orifice, and internal anatomy is like this, and this anomaly is known as covered anus, and this also can be managed by simple perineal anoplasty. There is no need for colostomy. And this is bucket handle deformity. Here a tag of the skin is attached anteriorly and tag of the skin attached posteriorly, and in between you can pass a dilator. So, it becomes a bucket handle deformity, and so this bucket handle deformity is also indicative of low malformation, that is rectum has formed, anal canal has formed, it has traversed the sphincter, and therefore, it is manageable by simple perineal anoplasty. Then this also can be managed with simple perineal anoplasty. Here it is different. Here see there is no sign here, no sign here, all along median raphe, no sign here, all along the median raphe of penis, no sign here. If you open the prepuce here and massage the bulbar urethra, you can see the meconium here coming out of the tip of urethral meatus. and this sign is known as black eye urethra. And if this is the sign, it is indicative of the fact that the rectum has formed, it has partially traversed the sphincters, but then it has taken anterior diversion to open in the bulbar urethra. So, it is recto-bulbar urethral fistula, and it is best managed with 3-stage procedure, that is the colostomy, posterior sagittal anarthroplasty, and then colostomy closure. Then this, look at this picture here. Here you can see the cleft scrotum and atypical hyposporia. You have passed the feeding tube here, it has external urethral meatus, is one is here, another is here, and you can recover the feeding tube here. Then is atypical hyposporia, and if this is the external anatomy with absence of anal orifice, then we know that the internal anatomy is recto-bulbar urethral fistula, and this needs 3-stage procedure: colostomy, definitive procedure, and colostomy closure. Then if you do not find any of these signs, then you go for urine examination, and after 16 hours of birth, if the patient has come to you, because at 16 hours of is time taken, the baby swallows air to reach rectum. So we take the help of invertogram. See, if you look at the pelvis here, this is ossified, this is ossified, this is P line and this is C line, and this is known as pubococcygeal line. So pubococcygeal line passes above the levator ani muscle here, above the levator ani muscle here, and it passes through the level of internal os in female. So before you do invertogram, rule out the vertebral anomaly, anal atresia, cardiac anomaly, tracheocecal fistula, radial and renal and limb anomalies. Then before invertogram, you must rule out TF by passage of red rubber catheter, and it will be arrested. You won't be able to pass it in the stomach, and the diagnosis of tracheal fistula is made bedside. There is no need to wait for sign of drooling of saliva. Even X-ray is not necessary. So that is there. And once you do the invertogram, and if you see the gas shadow has passed well beyond the eye point. This is the eye point here, and here see this is the eye point here. Shadow has passed well beyond the eye point. Then this is low malformation, and it is manageable with simple perineal anoplasty. And the gas shadow has not crossed this procedure. This is here. The gas shadow has passed the eye point. Again, needs 3-stage procedure, right? And here, this sign is typically seen in ARM patients in North India, a sign of pouch colon, a single large gas shadow, half of the strength of abdomen, and here you can see the gas in the bladder also. These two X-ray indicate that the patient needs 3-stage surgery. So for high ARM, you will have to do the diverting colostomy, and that is the sigmoid colostomy is preferred, but whenever indicated, sometimes the transverse colostomy is indicated, and in pouch colon, window colostomy is indicated. Repair is performed after 1 to 3 months, and before performing definitive repair, we do the distal colostogram. Pressure augmented distal colostogram here will show the anatomy of rectal pouch here. See the level of rectal pouch, the opening is here in the prostatic urethra, here the opening is there in the prostatic urethra, and this is the example of distal pressure augmented distal colostogram, and then you go ahead and do the surgery of posterior sagittal anarthroplasty. The anatomical basis of this posterior sagittal anarthroplasty is that the sphincter muscles from the central part of levator ani muscle, they descend down up to the anal dimple like a single functional sheet. That is one. Second, both half have independent blood supply. 2. Third is that if you go precisely in midline, then without compromising the, you can open the intersphincteric space precisely in midline, access the fistula, disconnect it, mobilize the rectum and place it here, and then the functional contribution of all the muscles are exploited. So here this is the rectum is mobilized and placed in the sphincter, and that is how the rectum will be mobilized and it will be placed in the sphincter, right. So after seeing this animation, you see the video. This is the position, jackknife position with, you will have to make sure the space is there, and this is the position from here, and this is the video. Yeah, and after the video my talk is over. So, here incision is precisely in midline, and the silk sutures are at the site of anal dimple, and it is the cutaneous termination of muscle complex. So, this is the contraction of muscle complex here, and these fibers are parasagittal fiber, this one, and this is coccyx here. Now, midline plane is absolutely avascular. This is the anterior limit of muscle complex contraction, and this is the posterior limit. This one is the anterior limit, this is the posterior limit, and this is the anterior limit. This is the posterior limit, and this is the anterior limit. Anterior limit is marked with silk sutures here. So, then the deep to coccyx, we incise the Walde's fascia here, precisely in midline, and once you incise the Walde's fascia, then put your right angle and divide the levator precisely in midline. Once you divide the levator precisely in midline, you expose the rectal pouch, and this rectal pouch you take the control with the help of sutures. So, now the rectal pouch is in your hand with the help of sutures, and in the lowermost dependent part of rectal pouch you open it, and if you peep inside the rectal cavity, see there is a fistula, it is opening in the urethra. You can directly visualize the fistula, and then circumscribe the fistula with the help of cautery here. So, fistula is disconnected from the rectal lumen, and this fistula is closed with fine 5-0 or 6-0 Weichel sutures. So, here I am closing the fistula after disconnecting its rectal lumen. That is it. So, that is how. And then the task is mobilization of rectum. So, rectum is mobilized off the prostate, which is anterior, in such a manner that the prostate remains intact, denonvular fascia remains intact, seminal vesicles and vas remain intact. So, and that is why in precise plane, that is the plane just next to longitudinal muscle coat of rectum and perirectal fascia, that is the plane of dissection. So, here my cautery is moving in the plane of longitudinal muscle coat of rectum and perirectal fascia, leaving the prostate caps behind intact, so that the urethral injury is avoided altogether. Right. See, this is prostate. Once the rectum is mobilized, right, then this is the levator muscle, there is the levator muscle, and this is muscle complex, and we mobilize the rectum by dividing the bands of perirectal fascia. Keep on dividing the bands of perirectal fascia, and then the 2 minutes only, and the rectum is lengthened. See, then you pre-place the sutures, and then pre-place the sutures across the sphincter muscle. This is the junction of levator and muscle complex here. And then all the sutures are pre-placed. When the sutures are pre-placed, then you pull the rectum down and place the rectum precisely in between the bisected sphincters and do the anoplasty. So, that is how anoplasty is completed. Anoplasty is complete, then we pull the rectum backward so that there is no mucosal prolapse, and then the sutures are tied off, the levator is approximated, and skin is closed like this. So, now you are having normal looking anal orifice. In next slide you will have the normal function also. See, here the boy is weeping, crying, and you can see the contraction of anal sphincters, you can see, and this is known as guarding reflex. So, that is how. So, finally, we conclude that there is no second chance in plane crash and surgery of anatomical malformation. The patient will become permanently incontinent if sphincter muscles are destroyed due to improper technique. In absence of sacral agenesis and hyperplastic sphincter muscles, results are gratifying with proper selection of procedure and meticulous technique, and in low malformations appropriately have a good prognosis with gratifying results in terms of continence, provided sphincters are not damaged, urethra is spared, and the stenosis is not created. So, but again I repeat, whenever in doubt, it is better to do a colostomy. And this slide of Chinese rope walk, emphasizing the importance of staying in midline. Yeah, because if you deviate from midline, you will damage the sphincters, and down below the tigers are waiting for you. Thank you. Yellow.
Thank you, sir.
Okay.
Now I request Professor Avnish Kumar, sir, to kindly felicitate, sir. Avnish Kumar, sir, to kindly felicitate, sir. Next in line, I request Professor Anand Pandey, sir, for his lecture on management of undescended testes. Sir is professor in pediatric surgery, and sir specializes in general pediatric surgery and pediatric urology. We welcome you, sir. Next in line, I request Professor Anand Pandey, sir, for his lecture on management of undescended testes. Sir is professor in pediatric surgery, and sir specializes in general pediatric surgery and pediatric urology. We welcome you, sir.
Okay. So, good afternoon, everyone. This is the third topic from pediatric surgery. So, undescended testis. As the name implies, failure of testis to reach into the scrotum. This is undescended testis. Okay. Few words about. So, good afternoon, everyone. Not very much. This is the third topic from pediatric surgery. So, in India, undescended testis, as the name implies, attachment called as cranial failure of testis to reach into the scrotum. And lower down, you must have heard of it, gubernaculum. So, fetal testis secretes testosterone, and due to its effect, there is regression of cranial suspensory ligament. Besides, insulin-like growth factor 3 by the Leydig cells, and it causes enlargement of gubernaculum. Besides, there is release of Mullerian inhibiting substance, which inhibits the Mullerian duct. Mullerian duct forms the female genital tract. You must be knowing this. Is it not working? the descent is divided into two parts: abdominal descent, which was described before, and followed by inguinal migration. In this phase, there is testosterone which acts on the genitofemoral nerve, and genitofemoral nerve releases CGRP, calcitonin gene related peptide. This causes gubernacular migration and along with it testicular migration, so that testis finally comes to the base of the scrotum and testicular descent is complete. Why does undescended testis results? These are some factors which have been found in studies. Failure of action of genitofemoral nerve. For any deficiency of testosterone due to any reason, we will be discussing it later on, CGRP may not be there and hence testis may not descend at its appropriate place. Abnormal location of genitofemoral nerve. Some syndromes such as microcephaly, in which there may be disturbances in the pituitary function because this is a line, overall pituitary hypothalamic axis tract. Anywhere deficiency in this tract may lead to abnormality in the testosterone production and ultimately resulting in undescended testis. Conditions such as arthrogryposis multiplex congenita, where there is unnecessary compression over the, it may hamper the descent of the testis. Abdominal wall defect, you see, a normal abdominal wall is needed for proper descent. So conditions such as, you must have heard of gastroschisis or omphalocele. In these conditions, the overall abdominal pressure is not adequate and hence these conditions are associated in about 33% with undescended testis. And lastly, neurological conditions, cerebral palsy or neural tube defect, where there is flaccid lower abdominal wall or improper coordination, it may lead to undescended testis. So these have been incriminated in its etiology. This is the classification of undescended testis. It can either be in the line of descent through the inguinoscrotal tract, or if the descent is not in the line of proper line, then it is an ectopic testis. In the line of descent, it can be intra-abdominal, canalicular, also known as emergent of peeping testis, in which testis is present at the deep ring, and lastly superficial inguinal pouch, which is also called Dennis. Ectopic locations, perineum, femoral, pubopenile, crossed ectopia. Crossed ectopia means both testes present in single side. These are the clinical pictures. This is 1 and 2 testes which were present on right side. This is the penile, and this one, you see there is a traction over the gubernaculum and indentation lateral to the malformed scrotum. So this one is perineal testis. Incidence at birth, it is about 4%, which decreases to 1% by 1 year of age, and undescended testis is more common in premature neonates, because I had described previously that the descent is completed by 9 months of fetal life. So if there is a premature infant, baby, possibility of undescended testis is very likely. If you ever encounter a patient with this complaint, sir मेरे बच्चे के गोली नहीं है या testis नहीं है, what you need to do? The complaint is most of the time straightforward, what I had just mentioned, absence of testis in the scrotum. What you need to examine? There are certain features. In examination, because testis is not present inside the scrotum, that side of affected scrotum will be poorly developed. In case of a gentle palpation from the deep ring to the superficial ring, you may be able to palpate the testis. If it is in the inguinal canal, it will glide under your fingers. You need to block the deep ring for better assessment of these things. Also, if you are not able to palpate it in the line of descent, look for the ectopic sites mentioned previously. These patients have coexisting hypospadias. So you always need to make comment upon penis is normal or not, and lastly a coexisting hernia, because it may be present in these patients. You need to remember one thing, a differential retractile testis, because this can easily be confused if a patient like this is given on examinations. Retractile testis can be easily differentiated based on some clinical features. when you inquire about the presence of testis, attendants will always mention that testis is present inside the scrotum at some point of part in the 24 hours. Scrotum of the affected side is well developed, testis is normal sized, and if you gently manipulate the testis, you can brought it to the base of the scrotum easily, and if you keep it there for 2 minutes to initiate cremasteric fatigue, testis will remain in the scrotum. This is different from undescended testis, where even if you are able to manipulate the testis, whenever you release it, it will spring back to its normal position or the position where it was present. So, by this clinical examination, you can differentiate between an undescended testis and a retractile testis. Now, why do we there where it should be? Complications may happen. The temperature inside the scrotum is 34 degrees, in inguinal canal it is 35, and in abdominal cavity we all know 37 degrees. So, it is a 4-degree temperature difference. So, if testis is not present in the scrotum, temperature differences may lead to affect the endocrine function. Sertoli cells have been seen to be disturbed in these patients. Germ cell progression, germ cells are not there or they develop degenerative changes as early as 6 months after birth via electron microscope. So, if it is not broke where it should be, complications are bound to happen. Because of these hormones and germ cells, fertility is going to be affected. Malignancy, I hope you must be knowing by this time that the chance of malignancy is very high in undescended testis. If it is unilateral, it is about 15%, and in bilateral 33%, most commonly seminoma. You must be knowing this, not a very important thing. Testicular torsion and has also been described. Psychological impact cannot be ruled out, and hernia is also present. So, you need to look for all these things, and because of these risks, you need to fix the testis in its appropriate location. We do not need any investigation for a palpable undescended testis, because we can easily see. Apart from anesthetic fitness, you do not need anything, and MRI as of now is not needed, because it is better to go for diagnostic laparoscope if you have a non-palpable testis. Hormonal therapy is controversial. In the European world, they routinely give hormones. In American part, they usually go straight forward for the surgery. However, there have been studies which mention that semen content and testicular size may be improved if these drugs before surgery. So, the 2 drugs HCG has been given as 100 IU per kg twice a week for 3-4 weeks, or LHRH spray in each nostrils 6 times a day for 3 to 4 weeks. I am not sure whether you know or not, but I have seen many patients 4 years, 5 years, 6 years, even 10 years. In fact, today in OPD we encounter a patient 5 years. देर क्यों लगाई? डॉक्टर साहब, डॉक्टर ने कहा था थोड़ा बड़ा हो जाए. तो this very बड़ा is very confusing, but technically this surgery should be done between 9 to 18 months of life. Why not in first 6 months? Because there is a neonatal testicular surge, and we believe that it may cause the testis to descend. So, at least 6 months is given for testis to descend. After that, you may perform depending upon the expertise. But if there is a coexisting inguinal hernia, you need to operate the patient beforehand. So, it is not like a rule that you need to do for before 6 months, only when there is hernia. Before going for surgery, you need to understand the arterial supply of the testis, because out of these 3, 2 need to be preserved for a successful testicular surgery or orchiopexy, which we call as. The first one is testicular artery, you all know this, a direct branch from aorta. The second is the artery to vas, usually is a branch of superior vesical artery, sometimes inferior vesical artery, and lastly cremasteric artery, which is a branch of inferior epigastric artery. So, testis is supplied by 3 arteries, you need to remember this. Now, types of surgeries, some surgery is straightforward, some can be 2-stage. If you have open palpable and descended testis, you need to go for open inguinal approach orchiopexy. And remember this word Prentice maneuver, we will discussing about it later on. Jones orchopexy is just for naming. In a peeping or emergent testis, which I mentioned before, testis present deep ring. And lastly, just to name, Bianchi's orchopexy, it is a transscrotal surgery for those testes present at the root of the scrotum, where you make an incision in the scrotum, mobilize the testis from there and place it in the subdartos pouch. I will be discussing for subdartos pouch in the slides later on. And in laparoscopy. Laparoscopic surgery can be performed for non-palpable testis. It can either be a single stage surgery without testicular ligation or a two-stage surgery in which ligation of testicular artery may be needed. These are the names of those laparoscopy procedures. If you are ligating the testicular artery close to its origin, it is a Fowler-Stephen surgery. If you are ligating it distally, it is a Kopp's procedure. One more thing, there is one procedure in which testicular artery is not ligated and we check for the mobility. We fix the testis near opposite abdominal wall close to anterior superior iliac spine, and the procedure is known as Shehata's procedure. So, either do the testicular artery or not ligate the testicular artery. If you are ligating, high ligation, Fowler-Stephens, low ligation, Kopp's procedure. These are the three names which you may remember, better to remember. These are the operative steps of a palpable undescended testis. Marking is there, testis is present in near the superficial inguinal ring. Lower inguinal crease incision. You need to remember this. The incision is different from what a general surgical incision for inguinal herniaotomy is made or hernioplasty. For transverse incision in lower inguinal crease. External oblique aponeurosis exposed. Testis along with sac lifted, and here you see this is testis in my hand and the distal it is the gubernaculum. We are teasing it, not dividing it blindly. Why? I will tell you later on. It is very important. Never ever divide it straightforward. Teasing slowly. You see this is the sac going to separate the cord structures. Sac separated and mobilized. Now, here this lever is placed in the retroperitoneum to gain length for the testicular artery. Always remember, the limiting factor for testicular mobilization is testicular artery and never the vas. Here, a finger is passed to superficial inguinal ring in the scrotum. Subdartos pouch is made. You see, normally we make the pouch, if we see from below, that it is inside the skin. We call it subdartos because it is the anatomical description. In a standing position, there will be outside, so subdartos. Testis is held by gubernaculum, carefully brought through the incision made. Placed in the subdartos pouch, fixed there, closure performed, skin closure and testis in the subdartos pouch. I mentioned that gubernaculum should not be divided immediately. Why? You see, this is the vas, it should be going there, but this is making a long loop. So, this is the long loop vas. Long loop may be encountered if you are going to dissect the gubernaculum. You need to be careful, otherwise you may be dividing the vas in this patient. That is why never ever divide the gubernaculum straightforward. Complications not very important, but if we have a poor mobilization or did not evaluate the patient properly before surgery, we may not be able to put the testis in the scrotum. Injury to vas may be happen. Hemorrhage if artery is injured. Infection we all know. If testis was brought or vessel was compromised, a gradual atrophy may happen. Besides, retraction. If testis were not mobilized properly or not placed properly, testis may retract back, leading to secondary undescended testis. This is the management algorithm for these patients. You see, it can either be palpable or non-palpable. If palpable, straightforward, go for open orchopexy. If it is non-palpable, go for diagnostic laparoscopy. It can either be an abdominal testis, in which case I mentioned low type. How do we know low? After mobilization of testis, you hold it by a Maryland and try to place it to the opposite deep ring. If it is going easily, you can fix it in single stage. If not, better to go for 2 stages. High type 2 stage orthopexy, single stage orthopexy, atrophic testis. If testis is atrophied due to any reason or was atrophied before also, it remains as a remnant called as testicular nubbin. You need not to preserve it because chances of malignancy may be there. Excise it with fixation of contralateral side. If it is a vanishing testis happens in intrauterine life, fetal life. Testis because of any reason may disappear, and what you will notice, only vas or cord structure going upward with no evidence of testis. In these patients also, you need to fix the contralateral testis. And why do a general surgeon needs it? You see, you need to be exposed with pediatric surgical conditions. Besides, you may encounter a delayed patient having undescended testis. And lastly, you may have complication. Just to share with all of you, when I was giving my general surgery examination here, the case allotted to me in my final MS passing examination was a huge abdominal mass due to undescended testis with developed malignancy and a para-aortic lymph node mass. This was my final examination case in MS. So you need to know this. And lastly, this patient, when I was in SAFI, he was a 40-year-old male patient and he came for testicular fixation at the age of 40. So if you are expert or exposed to it, you may be able to offer treatment in these patients. Thank you.
Thank you, sir. I request Professor Pava, sir, to kindly felicitate, sir. Now I request Professor Sanjeev, sir, for his next lecture on hemorrhoids. Now I request Professor Sanjeev, sir, for his next lecture on hemorrhoids.
इससे आगे जाता है ना. So नींद आ रही है सबको? इससे आगे जाता है ना. So wasting time. So I would like to. नींद आ रही है सबको? So start my topic. Before wasting time, I would like hemorrhoids, current management guidelines, and various symptomatology. I will cover my topic, my talk under that is following headings: introduction, relevant anatomy क्या है, etiologies क्या है various, क्या classification system है, how to evaluate a case of hemorrhoid and management guidelines. So hemorrhoidal venous cushions are normal structure that is present in the anorectal area, and it is suspended by suspended in submucosal layer of the anal canal by longitudinal connective tissue, and it is one of the most commonly encountered proctological condition in industrialized society or nowadays. Peak incidence elderly age group में होता है, though younger age group में it is also common. 50 years की एज के बाद more than 50% of patient once or two or multiple times they encounter symptoms related to these hemorrhoidal disorders. So if we talk about anatomy, there are submucosal hemorrhoidal plexus that is situated in this particular area. This is the channel of आर्टेरियोवेनस एनास्टमोसिस, जो इंटरनल हेमरॉयड होता है दैट इज बेसिकली सप्लाइड बाय सुपीरियर एंड मिडिल रेक्टल आर्टरी एंड venous drainage is also in the corresponding veins, that is superior hemorrhoidal vein or superior hemorrhoidal artery, and middle rectal vein का जो corresponding venous drainage होता है that is in middle rectal vein और middle hemorrhoidal vein. अगर external hemorrhoid की बात करें नीचे वाले पोर्शन के, तो in that area the arterial supply is by inferior rectal artery and drainage is via inferior rectal vein, that is particularly supply or drain into the pudendal veins. So based on the origin, the hemorrhoids can be categorized into internal or external hemorrhoids. Internal hemorrhoids are those hemorrhoidal cushions or those hemorrhoids which originate above dentate line. Dentate line के ऊपर है, whether it is prolapsing up to the anal verge or beyond that, उसको internal hemorrhoid ही कहेंगे. If origin is below dentate line, then it is known as external hemorrhoid. Understand? Then what are various etiologies? जो hypothesis दी गई है, various etiologies are basically related to irregular bowel habits, dietary pattern, constipation, straining by any means, prolonged sitting, pregnancy. With advancement of age there is possibility of development of constipation and hemorrhoid as well. Hereditary कुछ component भी hypothesis में है, nutritional है, as well as patients on anticoagulant therapy might have symptomatology of hemorrhoidal disorders. Pathogenesis के लिए there are 4 theories which are defined in various textbook. इसमें कहा गया है कि there may be abnormal dilatation of the hemorrhoidal venous plexus, that is one possibility that may leads to development of hemorrhoids. और जो arteriovenous anastomosis होती है at anal cushions की, at that area there is dilatation and ultimately lead to the formation of hemorrhoidal tissue. इसके अलावा hemorrhoidal cushions का जो prolapse होता है और downward displacement होता है, that might be a cause of development of hemorrhoid. That is basically due to, that might be basically due to जो anchoring tissue है वहाँ का, है ना, that connective tissue which support the hemorrhoidal venous cushions और this AV anastomosis वो destroy हो जाए, उसका destruction हो जाए या weak हो जाए anchoring tissue का, तो that leads to development of this descent and prolapse of hemorrhoidal tissue. Clinical features की बात करें तो the first and foremost symptom of hemorrhoid might be painless bleeding, that is usually fresh bleeding, bright red in color, or prolapse of the hemorrhoidal tissue or something from the anal canal. ये सबसे ज़्यादा common और important features होते हैं, clinical features होते हैं hemorrhoids के, जो symptomatology patient आपको बताता है. Besides that, pain in occasional situations, heaviness, sensation of fullness. Patient ये भी complain करता है sometimes कि he is not able to wash his bottom after. This might be due to external hemorrhoid or prolapsed grade 4 hemorrhoids. Constant mucosal discharge हो सकता है, painful palpable lump हो सकता है, and patient might be presented with anemia if persistent bleeding is there. Examination की finding क्या होगी? You have to do a perianal examination and ask the patient to take strain as he or she might do while defecating. So you may find whether there is hemorrhoidal mass that is coming out from the anal canal. इसके अलावा आप एनोस्कोपी कर सकते हैं एंड पेरिनेल एरिया में टेंडरनेस देख सकते हैं ना. इन एनोस्कोपी इंटरनल हेमोरॉइड्स ग्रेड 1-2 का है तो यू कैन फाइंड इट आउट. ब्लीडिंग हो रही है एट दैट एरिया से तो यू मै फाइंड इट आउट. प्रोलैप्स्ड हेमराइड है तो नेकेड आई से यू कैन सी ऑन स्ट्रेनिंग एज वेल एज ऑन एनोस्कोपी यू कैन आइडेंटिफाई इफ इट इज रिड्यूस्ड ग्रेड 3 हेमराइड्स. थ्रोम्बोज्ड एक्सटर्नल हेमराइड है तो यू कैन assess it via palpation, that is extremely tender and purplish or blackish in color अगर उसमें thrombosis and clots formation हो रखा है तब. Common position of hemorrhoids in general at R3. If you view in lithotomy position तो पिक्चर आपकी पहले फिगर जैसी दिखेगी, राइट एंटीरियर, राइट पोस्टीरियर एंड लेफ्ट लेटरल आर कॉमन पोजीशंस, एंड इफ यू सी प्रोन जैक नाइफ पोजीशन व्हाइल ऑपरेटिंग तो पिक्चर आपकी लेफ्ट लेटरल वाली इधर दिखेगी एंड राइट एंटीरियर पोस्टीरियर आपकी अपोजिट साइड दिखेगी. देन there are various classification system which are given for hemorrhoids since the beginning 18th century, but most commonly which we are adapting is Goliger classification, which are super added by our Association of Colon and Rectal Surgeons of India. तो इसमें क्लासिफिकेशन में गोलीगर क्लासिफिकेशन सिस्टम में हेमरॉइड्स आर ग्रेड्स इन 4 ग्रेड्स, दैट इज ग्रेड 1, 2, 3 एंड 4 बेस्ड ऑन हाउ मच प्रोलैप्स इज देयर. ग्रेड 1 इंट्राल्यूमिनल प्रोट्रूजन रहेगा, ग्रेड 2 में हेमरॉइडल स्पॉन्टेनियसली प्रोलैप्स होगा और चला जाएगा स्पॉन्टेनियसली. ग्रेड 3 में देयर शुड बी मैनुअल रिपोजिशन ऑफ द हेमरॉइड्स अगर प्रोलैप्स हो जाता है तो. एंड ग्रेड 4 इज परसिस्टेंट प्रोलैप्स ऑफ द इंटरनल हेमरॉइडल टिश्यू, उसको रिपोजिट करने पे या फिर स्पॉन्टेनियसली या फिर मैनुअली आपका रिपोजिशन नहीं हो सकता अनलेस वी आर प्रोवाइडिंग सम काइंड ऑफ एनेस्थीसिया टू द पेशेंट. प्रॉब्लम क्या है कि इसमें सिंगल हेमरॉइडल और इंटरनल हेमरॉइडल टिश्यू के क्लासिफिकेशन सिस्टम की बात करी गई, सो मैनेजमेंट में थोड़ा डिफ़िकल्टी आती है. कंसिडरिंग दिस एसोसिएशन ऑफ कोलोरेक्टल सर्जन्स ऑफ इंडिया ने एक सब क्लासिफिकेशन सिस्टम अडेप्ट किया which denotes whether there is single pile mass and how much circumference are involved internally inside the hemorrhoidal tissue, inside the anal canal. और इसको जो डिनोट करते हैं दैट इज ग्रेड के आगे सफिक्स लगा के डिनोट करते हैं. सपोज देयर इज ग्रेड 1 हेमरॉइड एंड सिंगल पाइल मास इज देयर तो इट हैज़ टू बी डिनोटेड एज ग्रेड 1 एंड ए. ऐसे ही अगर सब क्लासिफिकेशन की बात करें तो इफ़ देयर इज सिंगल पाइल मास देन इट इज ग्रेडेड एज सब क्लासिफाइड एज ए. बी इज 2 पाइल मास बट it should be less than 50% circumference of the anal canal. Circumferential pile mass अगर more than 50% है then it is known as or categorized in number C. And if there is thrombosis or gangrenous pile or complicated any kind of complicated pile mass then it is graded as subclassified as D. Evaluation, why it is required? ओपीडी में बैठो, किसी पेशेंट को बता दिया कि हेमोरॉयड है तो ऑल द सिम्टम्स ऑफ दैट पेशेंट इज रिलेटेड टू हेमोरॉयड ओनली, है ना. पेशेंट क्या कहेगा, इवन क्लिनिशियंस भी क्या कहेंगे, एक बार हेमोरॉयड देख लिया तो ऑल द सिम्टम्स रिलेटेड टू लोअर बॉटम और बैक इज रिलेटेड टू हेमोरॉयड, है ना. सर हमें पाइल्स की प्रॉब्लम है इसलिए मेरे कमर में दर्द हो रहा है, ठीक. सर पाइल्स है इसलिए खाना नहीं पच रहा है, ठीक है. बट समटाइम्स इट इज़ नॉट ट्रू, है ना. द प्रेसिपिटेटिंग कॉज इज समथिंग रिलेटेड टू जीआई डिस्टर्बेंसेज और पेशेंट उसको उल्टा को रिलेट करता है, हेमरॉयड है इसलिए हमको सिम्टोमेटोलॉजी है. तो डाइवर्स सिम्टोमेटोलॉजी है एंड यू हैव टू इवेलुएट इट प्रॉपरली फॉर प्रॉपर डायग्नोसिस एज वेल एज प्रॉपर मैनेजमेंट. तो हाउ we evaluate the patient of a hemorrhoidal disorder? First and foremost thing is clinical history, that is basically related to anal outlet symptoms. क्या है, severity क्या है, duration of symptoms क्या है, bleeding क्या है कि नहीं है, prolapse है कि नहीं, whatever the symptomatology related to anal bottom area that should be evaluated. As well as we have to inquire about dietary habits, and how much water she or he is taking in a day, constipation है कि नहीं पेशेंट को, सिटिंग हैबिट्स बहुत प्रोलॉन्ग्ड है कि नहीं, प्रीवियसली कोई ट्रीटमेंट लिया है कि नहीं, these all things should be considered of. And a disease specific history and examination should be performed in a case if you are suspecting hemorrhoidal disorder. इसकी grade 1 recommendation है कि that should be good enough for establishing a diagnosis of hemorrhoid. Sigmoidoscopy or colonoscopy is required in selected group of patient in certain situations. If after examination you are supposing that there might be some other pathologies like colorectal carcinomas, Crohn's disease, or patient have hereditary disorder of colorectal cancer on history, और जो सिम्टोमेटोलॉजी आपकी हेमोरॉयडल टिश्यू और हेमोरॉयडल डिसऑर्डर से एक्सप्लेन नहीं हो रही है, लाइक ग्रेड 1 का आपने हेमोरॉयड देखा एंड पेशेंट इज हैविंग इनकम्प्लीट इवैक्यूएशन की हिस्ट्री दे रहा है, बार बार पेशेंट को फीकल ऑकल्ट ब्लड पॉजिटिव आ रहा है, हिस्ट्री ऑफ वेट लॉस है पेशेंट को अलॉन्ग विथ हेमोरॉयड्स, पेशेंट के फर्स्ट डिग्री रिलेटिव में डायग्नोसिस है किसी को कोलोरेक्टल मैलिग्नेंसीज की, एंड फीकल immunohistochemical chemistry is positive for colorectal carcinomas, fecal DNA test positive आ रहा है, तो in these cases colonoscopy is required, but this is very less in number and has to be done in selected patient group. ढेर सारे ट्रायल्स हैं जिन्होंने बताया है कि there is incidental chance of diagnosis of this particular adenoma and carcinoma in these particular patients, but selected group है जिसमें आप हिस्ट्री और एग्जामिनेशन के बाद यू आर नॉट एबल टू एक्सप्लेन द सिम्टोमेटोलॉजी, है ना. देन मैनेजमेंट यही मेन स्लाइड है, उसके बाद आई विल शॉर्टली डिस्क्राइब ईच एंड एवरी प्रोसीजर, बहुत कम टाइम लगेगा. तो फर्स्ट एंड फॉरमोस्ट इज डाइटरी एंड लाइफस्टाइल मॉडिफिकेशन. जो रिकमेंडेशन है ग्रेड 1 ए की रिकमेंडेशन है, दैट शुड बी इनकॉर्पोरेटेड इन ईच एंड एवरी पेशेंट ऑफ हेमोरॉयडल डिसऑर्डर. टू स्टार्ट विथ, either you are adopting any kind of intervention or surgical procedures. Prior to procedure and post procedural, this has to be done mandatorily. तो डाइटरी एंड लाइफस्टाइल मॉडिफिकेशन की बात करें तो एडेक्वेट फाइबर एंड फ्लूइड ओरल इनटेक आप करना है, स्ट्रेनिंग अवॉइड करनी है, बल्किंग एजेंट एंड रेगुलर एक्सरसाइजेज आर डन इन फॉर्म ऑफ लाइफस्टाइल मॉडिफिकेशन. मेडिकल थेरेपी में अगर जाएं तो MPFF, कैल्शियम डोबेसिलेट, लोकल ऑइंटमेंट्स, a lot of things has been provided and described in literature. थोड़ा भी बताएंगे आगे. नॉन सर्जिकल ऑफिस प्रोसीजर्स में रबर बैंड लाइगेशन है, स्क्लेरोथेरेपी है, IRC है, फोम स्क्लेरोथेरेपी है. स्क्लेरोथेरेपी दो तरह से होती है, लिक्विड फॉर्म में रहती है और फोम फॉर्म में रहती है. यू कैन डू बोथ ऑफ देम. सर्जिकल प्रोसीजर्स, हेमोरॉयडेक्टमी अपने आप में इज ए वास्ट प्रोसीजर जिसके कई टाइप्स डिस्क्राइब्ड हैं. बियॉन्ड दैट नॉन एक्सिजनल प्रोसीजर्स हैं लाइक स्टेपेल्ड हेमोरॉयडेक्टमी, ट्रांस एनल हेमोरॉयडल आर्टरी लाइगेशन एंड चिवाटे प्रोसीजर. दैट इज न्यू इन लिटरेचर. सो बैलेंस डाइट मीन्स एडेक्वेट फाइबर, ओरल इनटेक, चेंज इन द डेफिकेशन हैबिट्स. एक निमोनिक है टोन जो लिटरेचर में डिस्क्राइब्ड है, दैट इज 3 minutes ड्यूरिंग बाउल मूवमेंट्स. वॉशरूम में जाके पेशेंट को ट्रेन करना है कि आपको वॉशरूम में कम टाइम बिताना है, नॉट इन लाइब्रेरी बैठ के पढ़ रहे हैं, किताब पढ़ रहे हैं, नॉट लाइक दैट, है ना. 1 बाउल मूवमेंट पर डे, एक बार अगर उसको डेफिकेशन होता दैट इज आइडियल, दो यू कैन कंपेल ऑन दैट. स्ट्रेनिंग नहीं करनी है, व्हेन डिजायर्ड तभी जाना है, नहीं जाके वॉशरूम में बैठे रहना है. और डाइटरी हैबिट्स में फाइबर इनटेक आपको बढ़ा देना है. तो दिस इज ग्रेड 1 रिकमेंडेशन है कि दिस हैज़ टू बी अडॉप्टेड इन ईच एंड एवरी पेशेंट ऑफ हेमोरॉयड. एंड सिम्टोमेटोलॉजी लाइक प्रोलैप्स, ब्लीडिंग एंड अदर थिंग्स, प्रोराइटस, itching are very much drastically changed or decreased while you take these conservative measures. उसके बाद आती है मेडिकल थेरेपी. मेडिकल थेरेपी इन फॉर्म ऑफ local therapy as well as systemic therapy. तो mostly which we prescribe or given in the literature is that is MPFF, है ना. MPFF क्या है? Micronized Purified Flavonoids, है ना. कैसे वर्क करता है? This work by increasing the tone of veins, है ना. veins को continuous यूज करने पे there is toning, so that toning हो जाती है तो टिश्यू स्ट्रेंथन हो जाता है. बाय दैट वी कैन यूज दिस. कितना थेरेप्यूटिक इफेक्ट है ना. इट इज ऑब्वियसली गिवन इन वेरियस लिटरेचर्स की सिम्टम्स इंप्रूव कर जाते हैं प्री प्रोसीजर, पोस्ट प्रोसीजर, एज वेल एज इन ग्रेड 1 एज वेल एज 2 हेमरॉइड्स like bleeding, pruritus, itching, but pain के लिए there is a little bit data which denotes कि MPFF के यूज से इस पेशेंट का पेन कम होता है. फ्लेबोटॉनिक्स का यूज जो भी करा गया है, जिस लिटरेचर से लिया गया है, दैट इज नॉट वेरी स्ट्रांगली रिकमेंडेड. These are various RCTs which denote there is persistent pain, bleeding, itching, pre-procedure as well as chances of recurrence after post-procedure is become lower in case if you use MPFF. है ना. Then surgical procedures are basically categorized into office procedures as well as surgical procedures, proper hemorrhoidectomy जिसको कहते हैं ना. तो in office procedures basically we perform 3 kinds of thing, that is रबर बैंड लाइगेशन, स्क्लेरोथेरेपी. तो रबर बैंड लाइगेशन की बात करें, दैट इज कंपेरेबल टू, इसमें करा क्या जाता है, वी हैव टू होल्ड द हेमरॉइडल टिश्यू, पुट अ रबर बैंड एट द ओरिजिन नेक ऑफ द दैट पर्टिकुलर हेमरॉइडल मास, और इट इज डिस्क्राइब्ड इन लिटरेचर दैट इज इक्विवेलेंट टू सर्जिकल हेमरॉइडेक्टमी इन सिलेक्टेड केसेस, नॉट इन ऑल केसेस. ग्रेड 1 and 2 में देयर इज equivalent results if we perform rubber band ligation, but in grade 3 very high recurrence rate is seen if we perform rubber band ligation. So routinely we can perform this procedure in grade 1 or 2 hemorrhoids, but overall recurrence rate is very high, up to 20-28% in overall. if we see ग्रेड 3 में ज़्यादा है, तो सर्जिकल ऑप्शंस बेटर होते हैं, चूज़ करने होते हैं इफ़ वी परफॉर्म और मैनेजिंग दिस हेमरॉइडल डिसऑर्डर्स. अगेन ढेर सारे लिटरेचर हैं, RCTs हैं. सर्जिकल हेमरॉइडेक्टमी को कंपेयर करा गया है रबर लाइगेशन से, एंड इनिशियल पोस्ट ऑप रिजल्ट्स आर इनिशियली सेम, बट वन थिंग इज़ दैट पेशेंट की लाइफ स्टाइल मॉडिफिकेशन नहीं करा गया, वट एवर जो भी नहीं करा गया, तो लेटर ऑन रिकरेंस की पॉसिबिलिटी बढ़ गई, रिकरेंस हो गए, है ना. तो up to 28% recurrence reported by rubber band ligation. Then sclerotherapy, how to perform it? Sclerosing agent is injected at the tip of the hemorrhoidal tissue, and that may leads sclerosis of that hemorrhoidal cushion or vein. Again, very much defined in literature, it is having very low success rate. वेरी लो सक्सेस रेट, एंड कुछ RCTs तो कह रही हैं कि ओनली 20% सक्सेस रेट इज डिफाइंड इन दिस हेमरॉइडल डिसऑर्डर्स. आपको बहुत इमरजेंसी है इन केसेस, देन ओनली यू हैव टू अडेप्ट इट, अदरवाइज नॉट. देन IRC अप्लाई थेरेपी, प्रोवाइड एनर्जी इन द फॉर्म ऑफ इंफ्रारेड कोआगुलेशन एट द टिप ऑफ हेमरॉइड्स. चारिंग हो जाती है एट दैट, but again it is having very much high recurrence rate. अब rarely performed procedure है this in IRC. Then procedure में जो describe है, that is of 2 types. In first we perform excision of hemorrhoidal tissue, and second is non excision of hemorrhoidal tissue. कहीं और हम मैनेजमेंट कर रहे हैं, एक्सीजन नहीं कर रहे हैं, हेमरॉइडल टिश्यू का एक्सीजन नहीं कर रहे हैं. इन दैट वन इज स्टेपेल्ड हेमरॉइडेक्टमी, स्टेपेल्ड हेमराइडोप्लास्टी. व्हाट वी डू इन दिस स्टेपेल्ड हेमराइडोप्लास्टी इज वी रिमूव अ सेगमेंट ऑफ म्यूकोसा अप्रॉक्सीमेटली 4 सेंटीमीटर एबव द डेंटेट लाइन, है ना. तो क्या होता है उससे, देयर इज अपवर्ड पुलिंग ऑफ म्यूकोसा, सो दैट आपका जो भी हेमरॉइडल टिश्यू है तो अपवर्ड शिफ्ट हो जाएगा, है ना. तो प्रोलैप्स है, इनिशियल प्रोलैप्स है या प्रोलैप्स है, तो आपका उसमें रिलीफ तुरंत मिल जाएगा, लगेगा कि हेमरॉइड्स आपके ख़त्म हो गए. स्ट्रेंथनिंग हो जाती है एबव द एनल कैनाल. जो रेक्टम में होती है स्ट्रेंथनिंग हो जाती है, पुल्ड अप हो जाता है. तो वी आर नॉट डूइंग एनी काइंड ऑफ एक्सिजनल प्रोसीजर इन स्टेपेल्ड हेमराइडोप्लास्टी. पुट ए स्टेपलर इनसाइड, है ना, टेक bursting suture as given in this picture and जो स्टेपलर है उसको आपने इंसर्ट करा, देन मेक ए नॉट ओवर ऑन द आउटसाइड और स्टेपलर को फायर कर दिया एंड यू सी देयर इज ए लाइन ऑफ. तो आपने हेमरॉइडल टिश्यू का कुछ एक्सीजन नहीं, कहाँ का एक्सीजन करा, एबव दैट पर्टिकुलर हेमरॉइडल टिश्यू, तो पुलिंग हो गई उसकी. लेस ऑपरेटिंग टाइम है बट टेक्निकली डिमांडिंग है ना. ऊंड हीलिंग जल्दी होती है, बाहर से कोई ऊंड दिखता नहीं है, इनसाइड एनल कैनाल होता है, तो इट इज़ समहाउ बेटर देन ट्रेडिशनल ओपन हेमरॉइडेक्टमी. लेकिन अगेन ब्लीडिंग है, अगर पेशेंट को परसिस्टेंट ब्लीडिंग है तो ऑब्वियसली इट इज़ नॉट ए बेटर ऑप्शन, है ना. प्रोलैप्स के लिए इट इज़ गुड ऑप्शन बट रिकमेंडेशन फॉर अगर परसिस्टेंट ब्लीडिंग है तो it is not going to work very good. Second option, non excisional procedure में transanal hemorrhoidal artery dearterialization by finger guided, under finger guidance और Doppler guidance, है ना. तो आप Doppler से कर सकते हैं और you can do it via a finger guidance. फिंगर से आर्टरी palpate करनी है and you have to ligate all the 3 sides or 4 sides whatever you feel. वहाँ पे आपको सूचर लेके क्या करना है, लाइगेट कर देना, डीआर्टरलाइजेशन हो जाता है, सप्लाई आपकी स्टॉप हो जाती है. एंड अगेन आइसोलेटेड हाल अगर कर रहे हैं, हेमरॉइडल आर्टरी लाइगेशन कर रहे हैं, तो इट इज़ हैविंग ए वेरी हाई रिकरेंस रेट. इफ इट इज़ कंबाइंड विथ सम काइंड ऑफ एक्सिजनल प्रोसीजर्स इन द फॉर्म ऑफ लिगाश्योर और ओपन हेमरॉइडेक्टमी, तो रिजल्ट्स आर वेरी गुड. इट इज़ ए Doppler probe in which we insert needle holder, वहाँ से आप आर्टरी की पल्सेशन फील करते हैं फॉर्म में, वॉइस के फॉर्म में, एंड लाइगेट दैट पर्टिकुलर एरिया. प्रोलैप्स भी है साथ में, तो वी कैन डू रेक्टोएनल म्यूकोपेक्सी, है ना. देन डॉपलर गाइडेड हेमरॉइडल आर्टरी लाइगेशन alone is having very high recurrence rate. वेरियस लिटरेचर में 3% to 60% तक रिकरेंस रेट दिया गया है. इफ़ वी कंबाइंड इट विथ अदर प्रोसीजर्स देन इट इज़ हैविंग हाई सक्सेस रेट, ए वेरी गुड सक्सेसफुल रेट, है ना. नाउ इट इज़ दैट इज चिवाटे ट्रांसएनल हेमराइडोपेक्सी करी जाती है. इन दिस इट इज़ ए वेरी गुड प्रोसीजर. देयर आर 2 rows ऑफ सूचर्स आर टेकन 2 to 4 सेंटीमीटर एबव डेंटेट लाइन. इसमें जो सूचरिंग करते हैं दैट इज़ टू बी डन डबल इंटरलॉकिंग फैशन टू रिड्यूस द चांस ऑफ क्या पस्टिंग बनने से रोकने के लिए, नहीं तो क्या होएगा, स्ट्रक्चर बन जाएगा ना. तो इट इज़ ए गुड प्रोसीजर, है ना. एंड ऑल्सो इट इज़ हैविंग वेरी हाई सक्सेस रेट. कोलेट्रल का फॉर्मेशन भी नहीं होता है डिस्पाइट यू आर डीआर्टराइलाइजिंग दिस. तो लेटर ऑन रिकरेंस और ब्लीडिंग के चांसेस बहुत कम रहते हैं. लेजर हेमराइडोप्लास्टी इमर्जिंग टेक्निक, अच्छी टेक्निक है. इन दिस वी what we do, patient under shadal anesthesia or local anesthesia, we put a laser fiber of frequency 1470 inside the hemorrhoidal tissue and जहाँ पे आपने आर्टरी पल्पेट करी है from that area we fire the laser fibers and give the laser energy in a fan shaped manner, है ना. fan shaped manner में आपको एनर्जी देनी है and we just withdraw the laser fiber. After that we compress it or we provide some normal saline, iced saline solution over that area so that extra energy that is given, that harmful effect उनका खत्म हो जाए. प्रॉब्लम क्या है, प्रॉब्लम क्या है इससे, एनर्जी कैलकुलेशन इज़ वेरी इंपॉर्टेंट. और अगर आप ज़्यादा दे देते हैं तो हार्मफुल इफेक्ट्स आर मच मोर एज कम्पेयर टू बेनिफिशियल इफेक्ट, है ना. एंड यू कैंट सी द इफेक्ट ऑन टेबल, है ना. नए लोग हैं अगर कर रहे हैं तो दे फाइंड कि इमीडिएटली लेजर एनर्जी आपने दी, सपोज आपने लागाश्योर से एक्सरसाइज करा तो आपको वहाँ दिख जाता है कि आपने एक्सरसाइज कर दिया, डिस्ट्रॉय कर दिया, ख़त्म हो गया टिश्यू. बट इफ़ वी आर गिविंग लेजर तो इट हैज़ टेक टाइम टू रिड्यूस. तो ऐसा नहीं कि ऑन साइट आपका हेमरॉयडल टिश्यू या हेमरॉयडल मास श्रिंक कर जाएगा, है ना. तो क्या करना है हमें, वी हैव टू जस्ट वेट एंड वॉच. जितनी एनर्जी देनी है एक हेमरॉयडल मास में आपको 120 जूल्स तक ही देना है, नॉट मोर देन दैट. अदरवाइज यू मे फेल कॉम्प्लिकेशन, म्यूकोसल ब्रीच हो जाएगी, फिशर हो जाएगा, है ना, स्पिक्टर इंजरी हो जाएगी और लेटर ऑन कॉम्प्लिकेशंस होंगे. तो इट इज़ ऑल्सो ए गुड प्रोसीजर. देन हेमरॉयडेक्टमी, है ना, हेमरॉयडेक्टमी प्रॉपर इट इज़ डिवाइडेड इनटू मल्टीपल टाइम्स. ढेर सारे टाइप्स हैं, जैसे कि ओपन हेमरॉयडेक्टमी है इनिशियली जो स्टार्ट करी गई थी, देन क्लोज्ड हेमरॉयडेक्टमी है, वाइट हेड हेमरॉयडेक्टमी है, सब म्यूकोसल हेमरॉयडेक्टमी है. along with that in hemorrhoidectomy with certain energy sources like ligasior, harmonic and bipolar hemorrhoidectomy. So one by one थोड़ा थोड़ा बता देते हैं, उसके बाद टॉक खत्म है. What we do in closed hemorrhoidectomy, we excise the hemorrhoidal tissue and close the mucosal flap, है ना. हेमोरॉयडल टिश्यू को आपने क्लैंप लगा करके एक्सरसाइज करा एंड जो मार्जिन्स है आपके पेशेंट के वुंड के मार्जिन्स है दैट हैज़ टू बी क्लोज्ड. प्रायर टू दैट वी लाइगेट द फीडर, जहाँ पे आपका बंच है उसको लाइगेट करना है एंड वी क्लोज द म्यूकोसा सो दैट हीलिंग इज फास्ट. इट हैज़ बीन सीन कि दिस टाइप ऑफ हेमोरॉयडेक्टमी इज बेटर देन ओपन, है ना. पेन कम होता है, हीलिंग फास्ट होती है इन मल्टीपल RCTs. ओपन वी हैव टू जस्ट लाइक इट एट द अपेक्स, जहाँ पे आपका फीडर है, फीडिंग वेसल है, एंड लीव द ऑल एरिया ओपन टू हील इट बाय सेकेंडरी इंटेंशन. तो इट इज़ ए टाइप ऑफ ओपन हेमोरॉयडेक्टमी इनिशियली डिस्क्राइब्ड बाय सर मिलिगन एंड मॉर्गन. तो उनके नाम पे अभी तक इसको डिस्क्राइब करा जाता है. देन बीच का रास्ता एक है पार्क और सबम्यूकोसल हेमोरॉयडेक्टमी. इन दिस वी form a submucosal flap in V-shaped up to dentate line. After that we split in two rays. उसके बाद क्या करना है, एक फ्लैप बना के we have to excise the hemorrhoidal tissue and partially close this mucosal flap, है ना. Again multiple RCTs हैं which denote कि there is less chance of bleeding and faster healing as compared to conventional open hemorrhoidectomy with this procedure, है ना. क्योंकि इसमें हम म्यूकोसा एक्सरसाइज नहीं कर रहे हैं तो पॉसिबिलिटी ऑफ स्टेनोसिस एंड स्ट्रक्चर आर ऑल्सो लेस विथ दिस पार्क हेमोरॉयडेक्टमी. इसके अलावा वाइट हेड हेमोरॉयडेक्टमी है. इन दैट हम हेमोरॉयड को कट करके जो टिश्यू है ऊपर से ले आ करके अप टू डेंटेट लाइन वहाँ पे फिक्स करते हैं. बट प्रॉब्लम क्या हुई, प्रॉब्लम ये हुई कि जो म्यूकोसा थे दैट इज सुचर्ड वाया स्किन ओवर द एनोडर्म. तो एट दैट एरिया स्लफिंग फाइब्रोसिस होने के बाद वाइट हेड डिफॉर्मिटी बन गई. बिकॉज सर वाइट हेड नेवर डिस्क्राइब दिस प्रोसीजर. उन्होंने कहा था कहाँ से हमें सूचरिंग करनी है, डेंटेट लाइन से ऊपर से, है ना. और बाद में लोगों ने क्या किया कि उसको सूचर किया नीचे स्किन से. तो वहाँ पे स्लफिंग, म्यूकोसल एक्ट्रोपियान एंड वाइट हेड डिफॉर्मिटी फॉर्म हुई, जिसकी वजह से उनका नाम इस खराब हो गया. कॉम्प्लिकेशंस, हाँ, वन मोर थिंग, लाइगाशोर और एनर्जी डिवाइस बेस्ड हेमरॉयडेक्टमी. ऊपर आपने क्या करा, आर्टरी को पल्पेट करा, उसको फिक्स करा एंड जो हेमरॉयडल टिश्यू है उसको लाइगाश्योर, बाइपोलर और एनी एनर्जी डिवाइस लाइक हार्मोनिक से एक्सरसाइज कर दिया, है ना. तो इसका रिजल्ट मल्टीपल RCTs में इज मच बेटर देन कन्वेंशनल हेमरॉयडेक्टमी इन फॉर्म ऑफ पोस्ट ऑपरेटिव पेन, रिकरेंस एज वेल एज डिस्कम्फर्ट में मिला. कॉम्प्लिकेशन एज यूजुअल हेमरॉयडेक्टमी के, पेन, urinary retention, UTIs, hemorrhage, incontinence, anal stenosis stricture if not performed well, mucosal ectropion, formation of fistula, किसी भी एनोरेक्टल सर्जरीज के बाद फॉर्मेशन ऑफ एनल फिशर इज कॉमन, है ना. तो दीज आर ऑल कॉम्प्लिकेशन ऑफ योर hemorrhoidectomies. Multiple RCTs are there which denote which is better, Milligan-Morgan versus Ferguson or Milligan-Morgan versus and various on. Again जो कॉमन सिचुएशन है हमारे पास आती है दैट इज external thrombosed hemorrhoid that has to be undertaken properly. साइन क्या है? पेनफुल टेंडर मास ओवर पेरियनल एरिया, यूजुअली एक्सटर्नल कंपोनेंट, ब्लूइश ह्यू के साथ रहेगा. करना क्या है इसमें? दिस कैन बी ऑप्ट, वी कैन ऑप्ट ए कंजर्वेटिव अप्रोच और वी कैन ऑप्ट ए सर्जिकल अप्रोच. इट इज़ ऑन यू. डेटा कोई ये सजेस्ट नहीं करता है कि कौन सा बेटर है, बट देयर आर सर्टेन बेनिफिट्स ऑफ डूइंग सर्जिकल प्रोसीजर्स, है ना. लोकल थेरेपी, सिड्स बाथ, वार्म सलाइन से और लोकल ऑइंटमेंट्स इन द फॉर्म ऑफ ग्लिसरील ट्राइनाइट्रेट और कैल्शियम चैनल ब्लॉकर्स इज ए फॉर्म ऑफ लोकल थेरेपी और नॉन ऑपरेटिव थेरेपी विच इज ऑप्टेड फॉर एक्सटर्नल थ्रोम्बोज्ड हेमरॉइड्स. बट इसका टाइम इतना लंबा है, मीन टाइम इतना लंबा होता है रिकवरी का कि we as a surgeon have to opt surgical excision part. Surgical excision is of two types. Some people are doing only thromboembolectomy at that particular area and some are doing hemorrhoidectomy along with thromboembolectomy. So which is better? Obviously in literature it was found कि hemorrhoidectomy is better in the form of recurrence and prevention of symptoms like pain and bleeding. It is a pictorial diagram. इसमें क्या करा गया है? We have to excise the external component of thrombosed hemorrhoids. Mean time of recovery if we opt for conservative therapy 28 दिन है ना, and we opt for surgical therapy it is 3 to 7 days है ना. So surgical therapy is a good option for grade 3 and 4 hemorrhoids, है ना, as we concerned about the cessation of symptoms and prevention of recurrence, है ना. ठीक. ओपन एंड क्लोज हेमरॉइडेक्टमी में obviously closed hemorrhoidectomy is better than open hemorrhoidectomy, and if we use energy devices in the form of Legasure or bipolar devices it is obviously better than open or closed hemorrhoidectomy. To summarize, initially lifestyle modification in each and every cases, tone जो अभी बताया हमने, along with that firstly try conservative approach for management of hemorrhoid. उसके लिए सही डायग्नोसिस बनना जरूरी है ना. ठीक है. पेशेंट ब्लीडिंग करके आ गया, आपने एग्जामिन भी नहीं करा और आपने क्या किया, ट्रीटमेंट ऑफ हेमरॉइड लिख दिया, तो दैट इज़ नॉट गुड. वी हैव टू एग्जामिन द पेशेंट, वी हैव टू परफॉर्म एडिस्टल रेक्टल एग्जामिनेशन. एटलीस्ट फिशर से भी ब्लीडिंग हो सकती है ना, क्रॉनिक फिशर से भी ब्लीडिंग हो सकती है, तो दैट हैज़ टू बी इंक्वायर्ड ऑफ. ग्रेड 4 में रिकमेंडेशन है कि आप सर्जिकल प्रोसीजर से ऑप्ट करें, कंजर्वेटिव अप्रोच आर यूजुअली नॉट बेटर. सो दिस इज ऑल अबाउट माई टॉक. थैंक यू वेरी मच.
Thank you, sir. Now I request Professor Avnish Kumar sir to kindly
हाँ जी,
felicitate sir.
हाँ जी बिल्कुल. Yeah. It is hypothesis, it is given, it is not proved. मतलब 4 हाइपोथेसिस हैं, उसमें से कुछ भी हो सकता है. इट इज़ डिस्क्राइब्ड इन लिटरेचर कि वेनस कुशन का डायलेटेशन है, उसके पीछे आर्टेरियो वेनस एनास्टमोसिस है, उसका डायलेटेशन हो सकता है. एंड कॉज में भी, कॉज ऑफ प्रोलैप्स माइट बी द डिस्ट्रक्शन ऑफ टिश्यू, सपोर्टिंग टिश्यू जो वहाँ पे है उसका डिस्ट्रक्शन हो सकता है ना. तो ये हाइपोथेसिस है, इट इज हाइपोथेसिस गिवन इन द लिटरेचर. दैट में भी है ना, दैट माइट बी फ्रैक्शन, कॉन्स्टिपेशन, प्रोलॉन्ग स्ट्रेनिंग है ना, ठीक है, और सम ट्रॉमा in any form.
Tone, might seem like an odd question, but tone suggests that there should be one bowel movement per day. But so wouldn't that be similar to constipation then? I mean, why one bowel movement per day?
Constipation is entirely different thing. It has been suggested. It is not absolutely indicated. है ना? If a patient or a person used to go for one time, there is least chance of development of hemorrhoid. है ना?
Sir, and another maybe an odd question, but there are thrombosed external hemorrhoids. External hemorrhoids are, I mean, so any painful hemorrhoid is per se external hemorrhoid itself because
no. It is external hemorrhoid is entirely different entity. Internal hemorrhoid is entirely different entity. है ना? दोनों की origin पे depend करता है whether it is external hemorrhoid or internal hemorrhoid. है ना? ठीक. तो thrombosis if external hemorrhoid में है ना, तो you have to opt for excision or conservative therapy as well. Thrombosis usually जब रहती है mixed component के साथ hemorrhoidal disorder रहता है तुम्हारा, which has internal as well as external component, and as literature says most of the cases में जो external component रहता है, internal के साथ external component रहता है, in that this thrombosis is common.
Yes, sir. So then thrombosed internal hemorrhoids, sir, will they be painful? Because they should not.
Usually not. No. Usually not. है ना?
If they are long stretch, they are painless. We start with they are painful.
Yes, sir. Sir, and
so what is the treatment is conservative. You can go for conservative.
yes.
But internal thrombosed hemorrhoids, most of the time it's
surgical excision.
So one last question, sir. You spoke about stapled hemorrhoidoplasty. Sir, you suggested that the stapler is fired and the rectal mucosa is drawn up so that the hemorrhoidal disease is drawn up into the anal canal, above the anal canal. Sir, but taking it versus hemorrhoidectomy, where we are excising the entire disease itself, be it closed or open or with ligature. Sir, why is I mean, because stable hemorrhoidoplasty is not getting rid of the disease, it's just pushing it upwards. So, sir, how is that?
Pulling it upwards.
Yes, sir, sorry, pulling it upwards. So, sir, how is it still better than hemorrhoidectomy?
It is not better than.
It's not.
In some forms, it is better than, है ना? ठीक? Because we excise hemorrhoidal tissue from the below, है ना? तो एक wound बनता है ना? उसका long post operative time है. Literature में जो described है various kind of symptomatology that is relieved by this stapled hemorrhoidectomy and various type of symptomatology that is relieved by this excisional hemorrhoidectomy, है ना? तो उनको कंपैरिजन किया गया है सम फॉर्म में, लाइक प्रोलैप्स रिड्यूस हो जाता है इमीडिएटली आफ्टर, है ना? hemorrhoidoplasty.
It is known as MIPH, minimally invasive procedure for prolapse hemorrhoid, PPH. Understand? That is, if it is a prolapse, then that is a suitable option. Otherwise, what is important is you have to know open hemorrhoidectomy is the gold standard. Every procedure is compared with that kind of movie. It is not it is a advanced technology or very good technology. The MIPH should be done. Understand? Stapler hemorrhoidectomy should be done. It is not like the case. Whenever you have prolapsed one, of course you should go for that MIPH. Otherwise, you can deal with all those modalities.
Yes, thank you, sir.
सर हमारा भी फोटो आ जाए सर आपके साथ. Thank you, sir.
Next, we are having lunch break for half an hour, and after that, we'll start with the session. Thank you.
ठीक है. अपना ही लैपटॉप ले आता फिर मैं.
Everyone, welcome back after the lunch session. So coming next is Dr. Imran Rizvi sir from the Department of Neurology, and this will be presenting a talk on understanding the statistics in journals. Welcome, sir.
Okay. Shall I start, or more people will be coming?
You can start.
Okay. Okay. So good afternoon, everybody. So this is the post-lunch session. So many people will be feeling drowsy, I think, and the topic is something which is apart from surgery, that is understanding statistics in medical journals. That is the most basic thing we want to know. So we will discuss statistics around that point only. So to understand this concept, we should know two things, that is the effect size and the confidence interval. So in this lecture we will discuss only two things, the effect size and the confidence interval. So you can see this table. This is a randomized control trial which was published in NEJM, and it shows patient of COVID-19. One arm of patient is treated with dexamethasone and other was given usual care. And you can see that they have compared the two intervention, but they have not shown you any p-value. Most of us are fixed with p-values only, but in most of the standard journal, they, for RCTs, they show only effect size. And here the effect size is risk ratio, which is presented along with the confidence interval. Then again another trial which compares liraglutide with placebo for obesity. And here you can see the mean, the effect size is mean difference. So what is effect size and which effect size we should use and how to interpret the effect size along with confidence interval, we will be discussing that. So basically effect size is comparison of outcome in two groups. For example, we have two groups. One group is receiving drug A, one group is receiving drug B, 100 patient in group A, 100 patient in group B, 100 patient died in group, 20 patient died in group A, 30 patient died in group B. So this comparison between 20 to 30 is the effect size. So effect size can be presented in the form of risk ratio, odds ratio, relative risk reduction, absolute risk reduction, number needed to treat, mean difference, standardized mean difference, hazard ratio. So which effect size is suitable for our study? How to decide that? So that will depend upon the type of outcome, which outcome you have selected. According to that, you will select the effect size. So first, let us consider what are the types of outcome in a study. So in a study broadly, you can encounter these four types of outcome: dichotomous outcome, ordinal outcome, continuous outcome, and time to event outcome. Dichotomous outcome means when the outcome of each patient can be categorized in one or two well-defined categories. There are two buckets. You can keep the outcome in one bucket or the other bucket. For example, patient living or dead, patient discharged from the hospital or not discharged from the hospital, fever improved or not improved, culture became negative or not became negative. So these types of outcome are example of dichotomous outcome or binary outcome. Then ordinal outcome is an outcome in which the outcome of each patient is in a category, but the category is following a natural order. For example, a pain scale, a Glasgow coma scale, severity of illness defined as mild, moderate and severe. These are the example of ordinal outcome. Then continuous outcome, when the outcome is in the form of a numeric quantity like blood pressure, blood sugar, WBC count, platelet count, C-reactive protein. These are example of continuous outcome. And then finally, time to event outcome, when we study the time that elapsed before the event has occurred. For example, time to death after the diagnosis of colon carcinoma. So these are the example of outcome. So depending upon these outcomes, if we have a dichotomous data, we can use risk ratio, odds ratio, relative risk reduction, absolute risk reduction, or number needed to treat. If we have continuous outcome, we can use mean difference or standardized mean difference.
If we have ordinal outcome, we can use a proportional odds ratio, and time to event outcome we analyze by hazard ratio. So as the time is short, I will discuss only the top 4 or 5 in this presentation. So coming to the first effect measure, that is the risk ratio. So risk ratio is most commonly used when we are dealing with dichotomous outcome, and it is most suitable outcome for cohort and randomized control trial. Study design, I think Hardeep sir will take. So when we are doing a RCT or cohort study, then risk ratio is the most useful effect measure, and it is defined as ratio of risk of event in the intervention arm and risk of event in the control arm. And risk terms सुन के कभी-कभी लगता है कि risk will be something bad, but it is not necessary that risk is something bad. It is just a probability. Risk can be bad or it can be good depending on the type of outcome. For example, if your outcome is death, risk can be bad. If your outcome is discharge from the hospital, risk can be good. So this is the formula. Risk ratio is defined as risk of event in the intervention arm divided by risk of event in the control arm. So if you want to calculate risk ratio or any of this type of effect measure, you have to make a 2 into 2 table. And whenever you are making a 2 into 2 table, follow a convention so that you don't get confused. The convention is write the outcome on the top and write your intervention on the side. So here in this example you can see that total A plus B patients are getting the intervention and C plus D patients are getting the control treatment. And A number of patients are developing the event in the intervention arm and C patients are developing the event in the control arm. So risk of event in the intervention arm will be A upon A plus B, and risk of event in the control arm will be C upon C plus D, and so your risk ratio will be A upon A plus B divided by C upon C plus D. So when you have calculated the risk ratio, how you will interpret it? So if risk ratio is 1, that means the risk of event is equal in intervention and in the control arm. And risk ratio is less than 1 means risk is less in the intervention arm as compared to the control arm. And if risk ratio is more than 1 means risk is more in the intervention arm as compared to the control arm. For example, if risk ratio is 0.5 means risk is half in the intervention arm as compared to the control arm. Risk ratio of 2 means risk is double in the intervention arm as compared to the control arm. But the risk ratio will be interpreted by, along with a 95% confidence interval, which will tell you whether this risk ratio is statistically significant or not. So I will deal with it in the coming slides. First let us understand another concept, that is concept of odds. For example, I have a dice, I rolled the dice 6 times and I got 6 only 1 time. So the risk of getting a 6 will be 1 upon 6. But the odd of getting a 6 will be events divided by non-event. एक बार 6 आया, 5 बार दूसरी चीजें आई, तो odds will be 1 upon 5. So odds ratio is defined, odds of event is defined as number of events divided by number of non-events, and odds ratio is the ratio of odds of event in the intervention arm to the odds of event in the control arm. And the important point is odds ratio is most useful for the case control study. So the study design, I think Hardeep sir will take. So odds ratio should be calculated. It is the most useful effect measure in the case control studies only. And again to calculate the odds ratio, we will again make a 2 into 2 table. So odds of event in the intervention arm will be events upon non-events, that is A upon B. Odds of event in the control arm will be C upon D, and odds ratio will be A upon B divided by C upon D, which will be equal to AD upon BC. So again the interpretation is same as the risk ratio. Odds ratio is equal to 1 means odds are equal in the intervention and the control arm, and the odd ratio less than 1 means odds are less in the intervention arm as compared to the control arm. And similarly we will interpret the odds ratio along with the 95% confidence interval. So the other quantity we can calculate is the relative risk reduction, that is how much the intervention is reducing the outcome as compared to the control group or the placebo. And to calculate it, we simply subtract 1 minus risk ratio and multiply it by 100. For example, if risk ratio is 0.4, that means 1 minus 0.4 into 100, that is 60% of the outcome is reduced by the intervention as compared to the control. Then the two most important effect measures are absolute risk reduction and number needed to treat. It is also known as risk difference, and it is basically the difference in the risk of outcome in the control arm and risk of outcome in the intervention arm. And if you want to explain the finding of the study or about the intervention to your patients, or even if you want to understand it yourself, then this is the most easily understandable measure. I will show you the example, then you will understand better. So to calculate it simply, calculate the risk of event in the control arm, risk of event in the intervention arm, and subtract the two, and you will get the risk difference or absolute risk reduction. Then number needed to treat is the average number of patients that need to be treated to prevent one bad outcome. Higher the number needed to treat, the less effective is the intervention. Lower the number needed to treat, the more effective is the intervention. And to calculate the number needed to treat, simply calculate the absolute risk reduction and do the reciprocal of it. 1 upon ARR will be the number needed to treat. So I will show you a simple example so that you can understand it better. For example, if a trial was conducted with 400 patients of TB meningitis, the patients were randomized in 2 arms in 1:1 ratio. 200 patients received the intervention in the form of steroid along with ATT, and 200 patients received the control treatment. And outcome was death at 6 months. If 20 patients died in the intervention arm and 40 patients died in the control arm. So how will you do the calculations? Simply make the 2 into 2 table, 200 patients in the intervention arm, 200 in the control arm. 20 deaths in the intervention arm and 40 deaths in the placebo arm. So risk of death in the dexamethasone arm will be 20 divided by 200, that is 0.1. Risk of death in the placebo arm will be 40 divided by 200, which will be 0.2, and risk ratio will be simply 0.1 divided by 0.2, that is 0.5. Odds ratio event upon non-event in the intervention arm will be 20 upon 180, in the placebo will be 40 upon 160, and odds ratio will be 0.11 upon 0.5, that is 0.44. So what does all this means? It means that risk of death is lower with dexamethasone as compared to the placebo. Odds of death is lower with the dexamethasone as compared to placebo. Risk ratio of 0.5 means relative risk of death is half when patients are treated with steroid as compared to the placebo. Then relative risk reduction is here is 50%. That is treatment with dexamethasone is leading to 50% reduction in death relative to placebo. But look at the this will be difficult to explain. अगर आप किसी से बोलो कि डेक्सामेथासोन देने से 50% रिडक्शन इन डेथ हो सकता है तो बोलेगा 50% किस चीज का? So it is not conveying the whole information. So you have to calculate the ARR. So risk in the control arm 0.2 minus intervention arm 0.1, that is 0.1, that is 10%. That means if you treat 100 patients of TB meningitis, you will be able to prevent 10 deaths. And number needed to treat will be 1 upon 0.1, that is 10. That means if 10 patients of TBM are treated with dexamethasone, then 1 death will be prevented. So these two are relatively simple to understand. That अगर हम 100 पेशेंट का इलाज करेंगे तो 10 को बचा सकते हैं, अगर 10 का इलाज करेंगे तो 1 को बचा सकते हैं, rather than mentioning a relative quantity like 50%, which will looks inflated also. So if you have continuous data like weight, height, blood pressure, then you have to calculate the mean difference. It is very simple to calculate the mean difference. For example, if you have 2 groups, TBM with hydrocephalus, without hydrocephalus, mean CSF protein is 212 in hydrocephalus group, 200 in without hydrocephalus group. So mean difference is simply 212 by minus 200, that is 12. So this I will skip, I think time is running out. So how to interpret mean difference? If mean difference is 0, that means no difference between the 2 groups. If positive mean difference, that means increase in the value of outcome in the intervention as compared to the control, and negative mean difference means decrease in the value of outcome as compared to the control. And mean difference will also be interpreted along with the 95% confidence interval to know whether it is significant or not. Then there is something known as SMD, standardized mean difference. This is useful in meta-analysis. In meta-analysis, what we do, we have results from different trials and we want to combine all these results together. So if 2 trials are reporting results in different manner, for example, one trial is reporting blood sugar in milligram per deciliter, other is reporting in form of millimole per liter. So how to combine these different quantities in a single summary? So then we use standardized mean difference. What we do, we calculate it by dividing mean difference by the standard deviation. For example, if we have 4 studies, 2 studies are reporting the outcome in the form of weight, in the form of mean plus minus standard deviation, and 2 are reporting in the form of BMI. So what we do, we calculate SMD, by dividing mean divided by standard deviation, that is 12 by 3, that is 4, 5 by 2.5, that is 2, and then we have all the quantities in the same unit in the form of SMD, we can pool them together. So what we have calculated till now, now we will interpret it along with confidence interval. So in research what we do, we draw a sample from the population, we conduct the experiment on the sample, and the results of the sample we infer to the population. For example, अगर हमसे बोला जाए कि लखनऊ के सारे adult males का हमको mean weight निकालना है, तो it will be practically impossible to sample all the population. So हम एक sample size calculate करेंगे, उनका weight निकालेंगे, और उस sample का weight हम population पे just 2 minutes infer करेंगे. So the effect estimate we measured till now are uncertain. That can be true, that can be less than truth, that can be more than truth. So there is an uncertainty. So this confidence interval basically is a range, and this range contains the true population value. So just coming to the most important point. So in the context of effect measure, the 95% confidence interval tells us whether what we have calculated is significant or not. So example, if we have 95% confidence interval of a ratio, like risk ratio and odds ratio, and the range is containing 1, then that quantity is not significant. For example, risk ratio of 0.78 and confidence interval of 0.5 to 1.5, and 1 is coming in the range, so this is not significant. But here, risk ratio of 0.66 and confidence interval of 0.3 to 0.75, and 1 is not coming in the range, so that is a significant. Finally, if we have a 95% confidence interval of a difference, like mean difference, so that range should not contain 0. If 0 is coming in the range, then that means that quantity is not significant. For example, here risk reduction of 1.71 and confidence interval minus 0.112 plus 3.53. So this is not significant. But here mean difference of 29 and confidence interval of 9 to 49, that means this is a significant difference. So that is all from my side today, because the time is running, and I will end here. Thank you.
Thank you, sir, for the insightful talk. Now I would request Dr. Jiten Kushwaha, sir, to kindly come on the stage and felicitate Dr. Imran, sir. Next up, I'm delighted to call Dr. Hardeep Singh Malhotra, sir, professor from the Department of Neurology, and sir will be giving a talk on the study designs. Welcome, sir.
Good afternoon, everyone. So I'll keep the talk crisp, and I've tried to incorporate a lot of examples so that you get a hang of how to assess and what should be the most appropriate study design required for analysis, as well as how it should be incorporated in your own study. So I do not have any significant disclosures, and my key objective is so that you get enabled in terms of defining and how you can go ahead with a study design when you read a original article or a study. So I'll walk you through the need to the conclusion. So what actually is a study design? So a study design is a structured methodology used to investigate a research question so that whatever you are doing is scientifically valid, ethical, and feasible. So at the end of the day, the most important reason why you want to define or have a study design is that it impacts the validity of your study, the reliability of your study, and how one's interpret your study. Whenever you are defining a research question, the most important impact is that it helps you in establishing a clear research objective. So if you are going ahead with a cohort study, the most important thing is that they are assessing the risk factors and causality. If you are going ahead with a cross-sectional study, it determines the prevalence, and if you are going ahead with a RCT, it evaluates the treatment efficacy. So these are the three most broad distinctions that you will come across when you are planning a study in terms of a study design. Without a clear study design, a study may fail to answer the intended question, and we'll see in the subsequent slides how the things get impacted. With a defined study design, the scientific vigor and validity is substantiated. It is ensured, it has to be there. Why? Because the amount of bias that is involved in a study, that gets minimized, which is very true with the randomized control designs. And it also helps us to produce valid, reliable, and generalized results. So what do we mean by a valid design or a valid result? You get something what you intended. It is a valid design. A reliable design is, it can be reproduced by someone else who's conducting the study. Last but not the least, what is generalizable, what you do in your study can be generalized to the population in general. So this is the basic meaning of three different words that we have used. And as I said earlier, that within RCT, the most important thing is the randomization, which helps you control most biases. So if you are ever asked a question, if you are conducting a study, what is the single most important parameter that you want to have in your study, is randomization. So across the board, right from the case reports up to the systematic reviews, the most important factor that is looked at is whether or not randomization was done. You cannot determine the statistical methods until and unless you have defined your study design. Your sample size calculation depends on that. More often than not, you find the prevalence formula, being put into a RCT or into a cohort design. So the sample size calculation is based on what is the type of study that you are intending to do. Going ahead, we have a different type of statistical analysis which is meant for a different study design and a different parameter. If you are looking at descriptive stats, they are about mean, median, proportions. If you are looking on comparisons, like more of inferential statistics, they are about t-tests, chi-square, and the regression models. Regressions can use in case controls and the other designs, and the survival analysis, as Dr. Imran said, the Kaplan-Meier projections, which are very important when you are going ahead with the cohort designs. This I have touched. Now, when you have a study design, whenever you are submitting your proposal for ethical approval or for regulatory approval, if you are not giving a clear-cut study designing protocol, that leads to a delay in approval. Then it also ensures that the participants are not exposed to unnecessary risks. So something which may look as simple as a study design has a lot of meaning to it, and if someone is not adhering to this thing, may have a lot of problem. Now let us see what are the types of study design. So in terms of the descriptive studies, I'll show you the algorithm which will help you in defining the study design, and more than 95% of the studies that you want to undertake or that you come across will fall in the algorithm. So after a brief description, I'll move on to the type of studies. So we have case reports. If you have a single patient that needs to be published or sent, case series, a collection, usually 3 to 6, that is required, that is the requirement. Cross-sectional, that is study conducted at one point of time. The strengths are that it is quick, inexpensive. You can go ahead and directly conduct this study, thesis, whatever you want to do. The biggest weakness that is addressed by a prospective cohort is the issue of causality or temporality. वो चीज़ उसकी वजह से ही हुई थी या नहीं हुई थी, this can be established only by a prospective cohort. No other study establishes this thing beyond doubt. So this is something which you need to remember. For the case control studies, I'll wait here for a minute, because when you are saying a case and a control, remember that these are two independent entities. You have a different inclusion criteria for cases and a different inclusion criteria for the controls. with the cohorts, when you're taking or following a single cohort and then you define a control within that cohort, that is a nested cohort or a control that was taken from within the cohort. So they have a common inclusion criteria, but a case control study has a different inclusion criteria. Almost nothing differentiates this thing best besides that you have a different inclusion criteria in a case control study. Always remember this thing. As Dr. Imran said, that when you are going ahead with the analysis, the odds would be the most applicable parameter in a case control study. For a cohort, you would like to go ahead with a relative risk measure. So with a cohort, you can have a prospective cohort, and as I said that the prospective cohorts, they are the best one to establish the temporal relationships, measure incidence and reduce the recall bias. पहले क्या हुआ था? If you are trying to look back, retrospection में देखना चाहते हो तो वो सब recall bias, it can be handled with a prospective cohort. आपको patient से कुछ नहीं पूछना, patient को कुछ याद नहीं करना. So all those anomalies that are associated with the recalls are taken care of. Then we have one of the best designs, that is an experimental design, where the participants are randomly assigned to different interventions, and this is considered as the gold standard for assessing treatment efficacy. तो एक कंडीशन को अगर हम देख रहे हैं तो केस कंट्रोल कर रहे हैं, क्रॉस सेक्शनल अगर एक प्रिवलेंस या किसी चीज़ का एस्टिमेशन कर रहे हैं, दैट इज़ अ क्रॉस सेक्शनल असेसमेंट. कोहॉर्ट को फॉलो करके कोई एनालिसिस कर रहे हैं, दिस इज़ अ कोहॉर्ट डिज़ाइन. The strength, of course, is minimizes confounding and bias and allows for causal inference. So you have different types of RCT. This is a very important thing. We commonly come across that this is a prospective study. This is a retrospective study. So prospective, retrospective and ambidextrous, they are not study designs. Remember these things, this thing. This is a mere movement of how outcome occurred. आउटकम हो चुका है तब आप केस कंट्रोल स्टडी करते हो. एक्सपोजर हुआ, आउटकम नहीं हुआ तो कोहॉर्ट स्टडी है. हो चुका है उसी पॉइंट पे देख रहे हो, दिस इज अ क्रॉस सेक्शनल स्टडी. सो दिस इज अ मेथड ऑफ डेटा कैप्चर और अकरेंस. दिस इज नॉट अ स्टडी डिजाइन बाय इटसेल्फ. इट इज एक्सट्रीमली कॉमन टू राइट ए प्रोस्पेक्टिव स्टडी है, रिट्रोस्पेक्टिव. दिस इज अ मियर प्रोजेक्शन ऑफ द डेटा कैप्चर. वो या आउटकम कब हुआ था या आप डेटा कैसे कैप्चर कर रहे हो. ठीक है सर, दिस इज नॉट अ स्टडी डिजाइन. सो द मोस्ट इंपॉर्टेंट स्लाइड is you have study designs which are based on the population and outcome, and the second part is population, intervention, the comparison and outcome, or the PICO or a PECO, where you have the exposure. So E and I is intervention, E is exposure. When you are dealing with interventions, these are the experimental designs. When you are dealing with exposures, these are the observational designs. So if you have the population and the outcome, यानी population और outcome जो आप देखना चाहते हो, that has already occurred, that is in front of you. So we will move forward. This will be a survey. In a descriptive part, in the analytical part, the same functionality occurs, but उसमें exposure है. जैसे smoker को follow कर रहे हो और देख रहे हो कि उसके अंदर हुआ या नहीं, या जिनको कैंसर हो चुका था कितने लोग स्मोकर्स थे. So you find cross-null at two levels, in the descriptive section and बाकी बीच में कुछ और repeat. Analytic में you have intervention, you have the exposures. So where you have the exposures are the observation. आप कहीं पर भी intervene, the moment you intervene, surgical technique, एक drug करें, एक procedure करें, किसी चीज़ के लिए, even एक behavioral therapy दे, that is also an intervention. So if you have an intervention, then you are doing a experimental study. If this is an exposure, this is an observational study. Here lies the importance of the direction of outcome that I was saying. So जो direction of outcome is not a study design, is a method to define the study design. Okay. So when you have the experimental group, you can either randomize them, you may not randomize them. If you look at the randomized control designs, the most important designs are parallel designs. I'll give you the example. And the second one is the crossover design. Looking at the direction of outcome, when the things are moving from exposure to outcome, smokers को follow कर रहे हो, देख रहे हो 10 साल के बाद कितनों को कैंसर हुआ. कैंसर हो चुका है, they were smokers. This is cross sectional. Cross sectional is appearing at 2 levels. इसमें क्या था, exposure नहीं था, इसमें exposure है. Then you have the case control. आप जो आउटकम है उससे एक्सपोजर पे जा रहे हो. आउटकम क्या है, कैंसर. तो सारे कैंसर के पेशेंट ले लिया, फिर उनसे पूछा कि कितने लोग स्मोकर्स थे. ओके, सो आउटकम्स को जब गैदर करो एंड यू मूविंग बैक, दिस इज व्हाट इज अ केस कंट्रोल एनालिसिस. आई विल फॉलो अ कॉमन एग्जांपल अप्रोच. यू मस्ट बी अवेयर ऑफ दिस थिंग, पेरोनाइकिया. सो वी विल मूव अहेड विद द पेरोनाइकिया एज एन एग्जांपल, and that is how I will finish my presentation. You find a rare infection in a patient presenting with peronaikia and want to document the findings. So I want you to get involved. तो ये क्या होगा? Case report, very good. You find a rare infection in 6 patients presenting with peronaikia and want to document the findings. You wish to study the spectrum of infective etiology, the spectrum of infective etiologies in patients presenting with peronaikia. This would be which kind of a study? स्पेक्ट्रम लेंगे, लैब पैरामीटर्स एक टाइम पे जब कभी भी असेस करेंगे तो सिंगल पॉइंट है, फॉलो नहीं कर रहे और पीछे भी नहीं. यस, सो दिस इज अ क्रॉस सेक्शनल डिजाइन. यू विश टू स्टडी अ 4, 5 और 6. ट्रिकी है, so just try and understand. If you understand this by a common example, you learn most of the things. You wish to study the change in high sensitivity CRP levels. इसकी जगह ग्लूकोज डाल दो, कुछ भी डाल दो, in diabetics and non-diabetics presenting with peronaikia. This would be which design? हाँ, very good. Why? 2 groups हुए, but these groups they formed a part of peronaikia group. इसमें controls हमने अलग से define नहीं किए. Got it? तो एक peronaikia के group में diabetics और non-diabetics आए, so this will not be a case control study. This will be a cohort study. You wish to study the prevalence of peronaikia in well controlled versus poorly controlled diabetics. Again a cohort. Diabetics हैं, उनमें से जिनमें जो inclusion criteria था चेंज नहीं हुआ. Inclusion criteria larger group is diabetes, जिनका poor control था, जिनका good control था, उनके बीच में हमने देखा. This again will be a cohort study. So this is the most trickiest example. If you wish to study the change in high sensitivity CRP levels in patients presenting with peronaikia. अब ये क्या डिज़ाइन हो सकता है? So this is one problem when you find with the title of the study. If your title of the study is not very clear and you come across this thing, then you have to look back, look at the protocol and try to find out कि उनका objective क्या था. So this can be anything, either a cross sectional study कि एक cross section पे आपने just a minute, हाँ, आपने एक क्रॉस सेक्शन पे सारे पेशेंट्स जो पेरानाइकिया के थे उनके अंदर हाई सेंसिटिविटी सीआरपी किया और हिस्टोरिकल कंट्रोल जो लैब कंट्रोल होते हैं उससे कंपेयर कर लिया, बिकेम अ क्रॉस सेक्शनल स्टडी. सो दिस कैन बी अ क्रॉस सेक्शनल स्टडी. आपने क्या किया कि इनको लिया और जो आपके पास दूसरे पेशेंट्स ओपीडी के अंदर आ रहे थे उनका HSCRP कैलकुलेट किया, यू कॉल्ड देम द कंट्रोल्स और ये आपके केसेस थे. तो दिस बिकेम द केस कंट्रोल स्टडी. और ऊपर हमने क्या लिखा है, चेंज इन HSCRP. चेंज क्या हुआ कि ये हो सकता है कि आपने एक पॉइंट पे देखा और देखा 6 महीने के बाद कितना है, 1 महीने के बाद कितना है, देन दिस बिकम्स अ कोहॉर्ट स्टडी. सो दिस इज द इम्पोर्टेंस इन डिफाइनिंग द study design. RCT is clear. You want to look at the efficacy of antibiotic A versus antibiotic B in 2 different groups. Is a parallel group study. When it is in the सेम कोहॉर्ट, एक में पहले दवाई दी, वॉश आउट पीरियड दिया, फिर दूसरी दवाई दी उसी ग्रुप के अंदर क्रॉस करके, दिस इज अ क्रॉस ओवर डिजाइन. सो टू समराइज, यू कैन एक्चुअली क्लिक द पिक्चर ऑफ दिस थिंग बिकॉज दिस विल हेल्प यू अ लॉट. When you are looking at the intervention, the best design is a RCT. you can use to some extent the cohort or a case control design, but the best design that is held till date is the RCT. For a diagnostic accuracy, it has to be a cross-sectional design. So lab studies अगर आप कर रहे हो और isolated lab है without clinical outcome, it should be a cross-sectional design. For the etiology, cohorts, prognosis cohorts, यहाँ कोई confusion नहीं है. For the descriptive, you may have cohort cross-sectional study or the cohort study. So, thank you. So, I'll be
thank you
happy
so much,
to
sir, for the insightful
answer
talk.
if there is a question. I do not.
If there are any questions anyone wants to ask. Yeah. Thank you, sir. Now I would like to call Dr. Surendra sir on the dais. Kindly come on the stage and felicitate all of us. Next up, we are welcome to have Dr. D. Himanshu sir from the Department of Medicine. Next up, we are welcome to have Dr. D. Himanshu use of artificial intelligence, and sir will be presenting a talk on the use of artificial intelligence in thesis and paper writing.
Thank you. And before we start, I just want to know. Thank you. And before we start, I just want to know two things. All of you. यहीं KGMC के students. So कितने लोग KGMC से यहाँ पे please raise your hands. So कितने लोग KGMC से यहाँ पे please raise your hands. और you're all from outside. So आप सब लोग thesis जमा कर चुके हैं या अभी thesis जमा करने वाले हैं? कौन से year है? Second year. कौन से year है? Second year. कितने लोगों ने अरुण फोटोस्टैट में अपनी बुकिंग करा लिए? झूठ नहीं, सच बताना. हाँ, जितने आराम से हाथ उठाओ. सब AI stand for artificial intelligence. हमारे ज़माने में A stand for artificial for अरुण फोटोस्टैट. हमारे ज़माने में सब लोग जाते थे और आखिरी दिन जाके फोटोस्टैट के बाहर बैठ के अपना थीसिस कराते थे. I still remember one of the most important things that happened. One of my batchmates वो गया फोटोस्टैट करा के सब कुछ थीसिस जमा कर दिया. यार मेरा सारा खत्म हो गया, एक दिन पहले ही जमा कर दिया. 2 दिन बाद उसको डीन ऑफिस से फोन आया, यार तेरा टाइटल तो दूसरा था, तुम्हारा टाइटल तो पिछले साल वाला डला हुआ है. सो ही फॉरगॉट टू चेंज द इवन टाइटल. देन ही हैड टू अगेन अनबाइंड द होल थिंग, रीडू इट एंड रीसबमिट इट. सो व्हाट आई एम ट्राइंग टू टेल यू इज, नकल के लिए भी अकल की बहुत जरूरत होती है. So just don't jump the gun and start thinking. And I also know this thing the fact of life is that I am not the one who is going to teach, because you are all well-versed gurus of artificial intelligence. मेरा जो पिछला one of the residents था, मतलब उससे मैं वार्ड में पूछता I used to talk to him and वो उससे इंग्लिश बुलवाता था तो मतलब 4 शब्द नहीं निकलते थे ढंग से उससे. उसको प्रेजेंटेशन करता था केस में तो उसको मतलब ऐसे आवाज़ निकलती थी जैसे लगता था यार कि इसको इंग्लिश नहीं आती थी. बट नेचुरल, मेनी पीपल कम फ्रॉम यूपी बोर्ड एंड ये कॉमन है. बट एक दिन वो लिख के लाया एक पेपर एंड आई वाज स्टन्ड. ही लुक्ड एज इफ सडनली आई गॉट अ शेक्सपियर इन माय वार्ड. मतलब उसकी अंग्रेजी मैंने पढ़ के मैं तो हिल गया यार, ये क्या लिखा है यार, इतना शुद्ध, इतना भयंकर अंग्रेजी. तब अचानक से मेरे भी ज्ञान चक्षु खुले कि भाई ये आई नहीं, ये AI है. सो यू ऑल मस्ट हैव यूज्ड चैट GPT, करेक्ट? और पीछे जितने व्हाट्सएप पे बैठे हैं, व्हाट्सएप कभी आजकल खुल गया, उसमें भी चलता है. या आई नो, आई वाज सीइंग 2-3 लोग यूज कर रहे थे, व्हाट्सएप पे लगे हुए थे उसमें. सो आई एम नॉट द टीचर, यू आर द टीचर्स. अब मुझे बताना इससे और क्या क्या मैं जोड़ सकता हूँ. सो हैविंग सेड दैट, सो फर्स्ट ऑफ ऑल यू हैव टू अंडरस्टैंड सर्टेन थिंग्स. आई होप दिस मूव्स फॉरवर्ड. Yeah. So these are the things that we are going to cover about. One of the things that I want to explain out here is first this basic slide. we have been discussing AIs, deep learnings and everything, machine learning. There is a huge difference between what we are talking. हर आदमी को लगता है कि AI में हमने लेटर लिख लिया तो अब मैं चैंपियन हो गया हूँ, but that's not the AI. ये काम तो बहुत सालों से हो रहा था. आप गूगल पे डालते थे पहले भी कुछ आता था. गूगल बाबा भी बहुत अच्छे थे. आपने आज सर्च मारा तो दूसरे दिन आपके वही सर्च की एडवर्टाइजमेंट्स पूरे अगले हफ्ते भर दिखाता था. वो तो पहले से कर रहा था. That's all AI. That's all part of artificial intelligence. So what we are doing here is just simply the tip of the iceberg. That is the software which has been created. We are using it for a basic requirements. What the AI, the world over is talking about is something much beyond that. That is the machine learning, deep learning and all. So we are not doing that. We are just doing जो काम अरुण फोटोस्टैट करता है वो हम एक कंप्यूटर से करेंगे अब, right? Correct? So we go to that part. So in writing, you have to first of all, what does AI do? There are algorithms. The algorithms किसी ने डाला कि आपके इस डेटा सीरीज के लिए अगर हमने डाला तो उसके हिसाब से हमारे ये चीज सर्च या ये चीज आउटपुट निकलेगा. So the softwares that we have, that's what they are doing. That means if you have a thesis topic, suppose what's your thesis topic? Just sort of blue. What's your thesis topic? इतना अच्छा तो है यार. हाँ. So all you do is you have to ensure when you write in your AI, the AI should be able to understand the topic which it can actually try to mimic with its algorithms. अब जाके तुम यही लिखोगे तो it may not be able to get to everything. But if you put in a proper तरीके से कि you can do two ways. If you make a small abstract, if you put a small abstract and put it into the software then will expand it. सिंपल सी बात है, आपको रिव्यू ऑफ लिटरेचर लिखने हैं 30 पन्ने. आप गिनती करके जाते हो ना, थीसिस मेरे 60 पन्ने की होनी चाहिए. 60 पन्ने होगा तो मेरे एचओडी सर के थ्रू से पास करके मैं जमा कर लूंगा. करेक्ट? मतलब सर सब लोग सर हिला रहे कि यही होता है. दैट्स व्हाट इवन दे रियलाइज कि 60 पेजेस हो गए तो मेरा थीसिस फिनिश हो जाएगा. सो व्हाट यू डू इज यू स्टार्ट राइटिंग रिव्यू ऑफ लिटरेचर. तो हमारे जो स्टूडेंट्स के हम अपने टाइम में भी देखते हैं रिव्यू ऑफ लिटरेचर में आप लोग ऐसे स्टार्ट करते हो. सपोज स्कार इन थायराइड पोस्ट थायराइड है तो पहले आप थायराइड की बात करते हो. व्हाट इज थायराइड, राइट? उसके बाद लिखते हो थायराइड का डायग्राम ये है, राइट? उसके बाद तुमने डालते हो कि थायराइड हम 4 जगह से काट सकते हैं, राइट? उसके बाद इसमें स्कार बनते हैं. बट दैट्स नॉट रिव्यू ऑफ लिटरेचर. ये कहानी लिख रहे हो तुम बस 20 पन्ने बनाने के लिए. अ रिव्यू ऑफ लिटरेचर रिक्वायर्स दैट यू टॉक अबाउट योर टॉपिक. The topic is I have a thyroid which has these types of surgeries. इस surgeries के इसमें से इतने आए हैं. इसमें कितने टाइप में हमें स्कार्स का देखा गया एंड उस स्कार की क्वांटिफिकेशन किस सिस्टम से हुआ है, उस सिस्टम में से कितने जगह एप्लीकेशंस यूज किए गए. दैट इज रिव्यू ऑफ लिटरेचर. बट 90% ऑफ रिव्यू ऑफ लिटरेचर इज सो इफ यू पुट थायराइड सर्जरी सो इट विल गिव यू 20 पेजेस ऑफ all thing about thyroid from anatomy से लेके basics के लेके सब कुछ देगा. But if you go about doing it in a basic form, you put an abstract, then it will create the whole paragraph. If you put the whole review of literature, then it can do the next part. It can do a grammar check, completely correct it, put it into a system so that what you get is a final output. So ऐसा नहीं है कि हमने बस AI कल सुबह जाके डॉक्टर हिमांशु ने पढ़ाया तो जाके हमने चैट जीपीटी खोला. चैट जीपीटी के तो वो आजकल 5000 समथिंग उसका वो है प्लस 758 रुपीज उसका टैक्स है. आई सर्च yesterday only. So and you put it and you can get everything. But no, you won't get everything because you will get all trash, because trash in AI का second part is trash in is trash out. You can also do a content generation as we suggested, and you can have a style enhancements, how to make it more beautiful. Now, if you look at this, you can also do a data analysis. I'm not going much into this, but I'll go into this software thing. So, popularly what we use, popularly there is a software called Grammarly. Kabhi use kiya? So, one of the things is it's a free software also, and it's also a paid software. This is used by us sometimes, many times, when you want to correct your paper. Suppose you have written your paper, you have written your thesis. कल कोई कहता है इसमें बहुत spelling mistake है. तुमने introduction लिखा और बहुत स्पेलिंग मिस्टेक है, तो 99% चांस है कि तुम्हारा जो एक्सटर्नल इवैल्यूएटर है तुम्हारा थीसिस वापस भेजेगा। जब मैं स्टूडेंट था, सो वन ऑफ माय प्रोफेसर महेश चंद्र ने यही कहा था हमसे, आई थिंक मेनी ऑफ द सीनियर्स नो, कि बेटा देखो जब एग्जामिनर के पास आता है थीसिस, वेरी प्रैक्टिकल थिंग, वो उसके पास 10-15 थीसिस आती हैं, तो सबसे पहला पन्ना खोलता है इंट्रोडक्शन का, और इंट्रोडक्शन अगर ढंग से नहीं लिखा है तो सबसे पहले वहीं बंद हो जाता है किताब। उसके बाद वो खोलता है सबसे पीछे, अब मेथोडोलॉजी खोलता है कि तुमने क्या क्या कर रहे हो, और उसके बाद तीसरा खुलता है तुम्हारा रिजल्ट्स का पूरा टेबल्स बने होंगे, और देखेगा कि इसमें से रेलेवेंट जो एम है उसका टेबल है कि नहीं। 70% of your examiners very practically are going to do this, and 80% of students never write this thing properly. उसका इंट्रोडक्शन खोल लो, अगर वो कहते थे कि अगर मेरे पास आएगा, ही वॉज मेनली नॉन इन्वेजिव कार्डियोलॉजिस्ट, वो कहते थे मेरे पास अगर कल कैंसर पे कोई आएगा विच आई डोंट नो अबाउट द टॉपिक, द फर्स्ट थिंग आई एम टू सी इज हाउ उसके स्पेलिंग मिस्टेक्स क्या है। So first and foremost is you should ensure your thesis, your paper, that the grammar and the spelling mistakes are properly corrected. For that we use a software called Grammarly. You can just put it in. You can take a whole complete costings uska, it's approximately it costs around 10,000, where it does everything. It does the whole editing. You take your जितना भी तुमने लिखा उसको अंदर एंटर करोगे तो automatically plagiarism detections, checking सब कुछ करता है. It evaluates, puts in and does every part, and what you get is a final outcome. Outcome is totally cleaned. Then you got the Jasper is another software which is used very commonly by mainly more of the basic scientists ज़्यादा use करते हैं, where it actually does the whole development of tables, काफ़ी सारे चीज़ करता है. And third, of course, I have not used Quillbolt. I do not have much idea about it, but it also does paraphrasing, research writing, and all. Now, if you go beyond this, in the last 3 to 6 months, there has been a lot of changes. There are many other softwares which have come in, which you can do better also, or do equally well. Now, if you people use MS Word, right? PowerPoint use करते हो, correct? So the MS Word itself has now what is, अगर आपका latest version है तो उसमें एक आता है Copilot करके. If you press the Copilot will do everything for you, and you will actually get a complete version. But कभी Copilot use किया? नहीं? So the Copilot asks you certain statements. First thing that will ask you is, what is your question? What is your basic norm? या आपका कोई previous कोई आपका कोई already आप written कोई document है. Then it will take that for an MS Word and it will create the whole thing. Similarly, if you use ChatGPT or Gemini is from Google. The Gemini you can put it, it will give you a complete list of headings and everything, and you will get a complete outcome. So you have other softwares, these are certain softwares, you have MS Word, Copilot and all, which you can use it even in your basic जो आप कर रहे हो उसी के साथ कर सकते हो, if you have the original version of your Microsoft. I personally, why do you use it? Well, it is user friendly without doubt. Then you are compatible to it and you want to use the relevant features. So I have personally used Grammarly, I have used Copilot, I have used to a certain extent ChatGPT. I have not used Gemini that much, and जैसे बाकी दो softwares जो बताया, Quillbolt I have never used. Why? Most of my documents when I create, they are in Word. So once I am in Word, why would I go to another place? I will try to kick the Copilot. तो अगर आपने अपना basic introduction भी लिखा है और उस पे अगर आपने Copilot यूज किया, the trick of the thing is it can create a complete review of literature for you. आपका ROL वो तैयार कर देगा, ठीक? So that is how easy it becomes. But then you have to also integrate it with the present systems. One of the important thing that I will show you is it is efficient, it can access all academic sources, and I'll go straight to some other thing. The AI tools helps you to organize everything. This PowerPoint itself, is made on AI. I kept on thinking what to do. I just went and clicked on Copilot. The Copilot created the whole AI. This is all AI. So आपको दिख रहा है सारा? So this is all AI. I didn't put a single slide into it because personally I am not a big fan of AI in paper writing and thesis writing. But you can do everything with this with the Copilot. But where does it lack? So I'll show you the last slides where it will lack. आपको ये जो दिख रहा है, I'll show you the last slide, then you'll understand why you should be very careful about using AIs. I don't want to waste too much. Yes. So जो AI का पूरा तुम आप देखोगे, what was the thing that निष्कर्ष आया? हमने क्वेश्चन डाला, पूरा बहुत सुंदर सा इसने एक पीपीटी बनाई. The PPT itself, with all its beautification, technically it was not creating anything extra जब तक मैं अपना अकल ना लगाऊं. सॉफ्टवेयर का नाम, सॉफ्टवेयर में क्या प्रॉब्लम्स आएंगे वो नहीं, पहला चीज. सेकंड, look at the difference between these characters. So इसमें and this. In a hall, usually you say you have 24, 28 and all those presentations. So if you just create with AI, you will end up with trash just like the presentation which you are seeing. Why I did not change this is just to prove that even if you think you are smart and you put this AI, a AI generated document does not give you total clarity जब तक आप अपना अकल नहीं लगाते हैं. जैसे आप ना अरुण फोटो स्टार्ट पे जाते हो, I've got 35 seconds, I'll just tell you this thing. जस्ट जब अरुण फोटो स्टार्ट पे जाते हो और आप जाके अपना टाइटल देते हो और बोलते हो कि मेरा थीसिस बना दो, वो थीसिस के 50 टेबल्स बनाता है, वो सारे टेबल 95% कूड़ा होता है, बिकॉज यू डू नॉट नो योरसेल्फ कि व्हाट वाज योर रिसर्च क्वेश्चन. एंड 95% ऑफ टाइम्स मेरा जो स्टूडेंट आता है ना लेके, उसको मैं वापस भेजता हूँ, बेटा इसमें से जाओ फिर से वो 20 टेबल्स बना के लाओ, क्योंकि जो तुमको दिया है वो मेल वर्सेस फीमेल, फीमेल वर्सेस एज वर्सेस एज, एज वर्सेस रूरल, रूरल वर्सेस दिस एंड दिस वर्सेस दिस सब देता और यू पीपल सबमिट दैट. So my final thing is, do not rely on AI, get your eye, and your question would be still the staging of scar mark, and the Arun photo stack will give you कितने इसमें फीमेल थे, कितने मेल थे, कितना टेबल्स था, और ऐसे ही कूड़ा निकल के आएगा जो इसमें दिख रहा है. It will be all very glossy, but will not have any substance. So this is AI for you. Thank you.
Thank you, sir, for that talk.
Final एक सेकंड दिखाते हैं. I just sorry. Final एक सेकंड दिखाते हैं. I just did this. If you can see, these are the documents which we generated, and we tried to connect it with the AI software. This is generated, and this I did using Copilot AI software. This I did using Copilot. And such another thing. Sir, मुझे बोल रहे हैं कि ये क्या करा रहा है. And so you see, this is all totally I created. This is just all for your sake. I created fever just for your sake. How can you create the whole history diagram? How can you create the whole history diagram? All I had to put is AUFI. All I had to put is terminologies of AUFI and the terminologies of simple. And these graphs हमने अपने हिसाब से डाला था, और 2-3 क्वेश्चंस डाला, fever in tropical infection fever उसमें डाला, and you got all those things which you could actually create. And further जब हमने इसको और किया, because some of them were much more, उसका दूसरा वाला पार्ट का है, then I went and I said I want grammar corrections, I want total properly aligned document. So that's the document that they displayed. So the same document in a very formatted way which it created. So now this article within 1 hour is ready for submission into any journal. मतलब एक review article है जा सकता है. But what was the flip here? The flip is I had to put my brain, get my tropical infections of fever, किस fever, कितने दिन का fever, और उसमें क्या क्या हमें approximate diseases कुछ जैसा उसमें पता चला, सब कुछ निकाल लिया कहीं का. It went on to even take out TB, ये वो. So if you are talking about acute fever, it has to be 7 days. So we had to do a little bit of screening out, and then you have a full document ready for your paper presentation.
Thank you, sir. Thank you, sir. Next up, I would like to call upon Dr. Soumya Singh ma'am from the Department of KGMU, ma'am from the Department of KGMU. And ma'am would be giving a talk on how to write an ethical proposal for proposed research.
Almost the last lecture, we are at the end. Although it's the last, but not the least important. So how to write an ethical proposal for research? Before that, what actually is ethics in research, especially in surgical research, or why it is important or overemphasized? So in surgical side, most of the time, subjects are the patients, human lives. And second important thing is, most of the time interventions are in form of surgery. It may be major surgery, minor surgery, general anesthesia, local anesthesia. Whatever intervention we perform, it always has its effects, side effects, morbidity and mortality. So we have to be very ethical. Second thing is regarding ethical dilemmas in biomedical research. It always have been and it will always be. There are lots of debates and dilemmas in whole of the biomedical research. One of the most common one is like a lot of studies have been done on HIV patients in African subcontinent. So what was done? So the dilemma or the conflict was on the issue of placebo. एक ग्रुप है जो HIV पॉजिटिव पेशेंट्स का है, उनको दो में डिवाइड किया उन्होंने, एक को प्लेसिबो दिया और एक को एक्चुअली रेट्रोवायरल थेरेपी दी. सो ऑब्वियसली जिसको प्लेसिबो मिला है, ऐसे ग्रुप में क्या होगा, HIV विल कीप ऑन प्रोग्रेसिंग और क्या होगा, ट्रांसमिशन रेट भी बढ़ेगा. तो ऑल्दो इट्स रिसर्च बट इट्स अनइथिकल. तो ऐसे इनफाइनाइट एग्जांपल्स हैं. देयर आर लॉट ऑफ डायलेमास विच हैज़ टू बी सॉल्व. दैट्स वाई एक कॉमन स्ट्रक्चर, एक कॉमन प्लेटफॉर्म होना चाहिए जिसमें एथिक्स के बेस पे जो भी हमारी रिसर्च है उसका जो फाउंडेशन है, उसका जो स्ट्रक्चर है. देयर वाज एन एरा ऑफ ओपन सर्जरी और वेरी इन्वेजिव टाइम. अब हम कहाँ पे आ गए हैं, लेपारोस्कोपिक और मिनिमली इन्वेजिव. लेकिन ये जो ट्रांसफॉर्मेशन है ये हम बहुत आसानी से एक स्लाइड में देख पा रहे हैं. अगर हम उसके पीछे की चीज़ें देखें तो इट मस्ट हैव बीन, दिस ट्रांसफॉर्मेशन हैज़ gone through infinite number of tests, trials, research. और उन सब का बेस क्या था, ethics. That's why ethics is important. And even from minimally invasive laparoscopy to robotics. तो first laparoscopic surgery was done between 90 to 92. और robotic surgery कब आया, 2000 to 2002. तो कितने साल का अंतर था, 20 years. लेकिन हम अगर ओपन से लेपारोस्कोपी की बात करें तो कितना टाइम लगा था, 100 years. तो 100 years वर्सेस 20 years. तो ये जो टाइम था, ये वाला ट्रांजिशन टाइम था, अब क्या है, उससे ज़्यादा है कि उससे कम है, उससे कम है, ऑलमोस्ट 1/5 है. तो ऐसा क्यों पॉसिबल हुआ, क्योंकि हमारे पास ऑलरेडी वेल डिफाइंड रिसर्च डिज़ाइन थे, हमारे इथिकल प्रिंसिपल्स ज़्यादा क्लियर थे, हमारा जो स्ट्रक्चर था वो वेल डिफाइंड था. तो दिस इज़ ऑल्सो वन ऑफ द इम्पॉर्टेंट पार्ट ऑफ ethics in research and applying the principle, all these principle in actually performing the research. There is another very interesting thing. बहुत सारी एनालिसिस, सिस्टमैटिक एनालिसिस, मेटा एनालिसिस हुई है और ये देखा गया कि दुनिया भर में जितनी भी मेडिकल रिसर्च है उसमें जो ड्रग से रिलेटेड है या फार्मास्यूटिकल्स है या परफॉर्म बाय फिजिशियंस, परफॉर्म बाय मेडिकल पर्सनल वर्सेस वो सारी रिसर्च जो सर्जन्स करते हैं, जो सर्जिकल रिसर्च है, उनकी जो क्वालिटी देखी गई या उनका जो एक यील्ड और स्टैंडर्ड देखा गया, उसमें जो सर्जिकल रिसर्चेस थे वो क्या थे, इंफीरियर क्वालिटी थे एज़ कम्पेयर टू मेडिकल। उसकी फिर रूट कॉज एनालिसिस करी गई, ऑक्सफोर्ड में सारे सर्जिकल साइंटिस्ट की मीटिंग हुई, तो उसमें ये पाया गया कि जितनी भी मेडिकल रिसर्चेज होती हैं उनका जो जजमेंट जो क्राइटेरिया है, उनके जो जिस बेसिस पे हम उनको ग्रेड करते हैं वर्सेस सर्जिकल, इट शुड नॉट बी सेम। क्यों? बिकॉज सर्जरी में जो भी इंटरवेंशन होता है वो सर्जन डिपेंडेंट होता है, स्किल डिपेंडेंट होता है, सर्जन के एक्सपीरियंस से वैरी करता है। तो इसलिए क्या किया गया, जो सर्जिकल रिसर्च है उसको ग्रेड करने के लिए एक उन्होंने फ्रेमवर्क बनाया, दैट इज़ आइडियल फ्रेमवर्क। इसमें क्या होता है, आइडिया, डेवलपमेंट, असेसमेंट, एक्सप्लोरेशन एंड लॉन्ग टर्म मॉनिटरिंग, इस हेडिंग में सर्जिकल रिसर्च को ग्रेड करना चाहिए। ओके लेकिन जो भी फ्रेमवर्क हो, जो भी स्पेशलिटी हो, जो भी इंटरवेंशन हो, जिस भी तरीके से रिसर्च की जाए, what should never be miss is ethics. So that's why most important thing is ethics. So ethics, Akanksha, can you please read?
Ethics, the moral principle and guidelines that govern the conduct of research involving humans, animals and biological materials.
Okay, perfect. So ethics is what? Ethics actually जो ये word है इसकी origin कहाँ से? Ancient Greek word ethikos. Ethikos means character. Character which has to be moral. तो जो भी moral principles हम research में follow करते हैं वो सारी ethics is a very broad term. लेकिन हम यहाँ पे किसकी बात कर रहे हैं? सिर्फ medical ethics in medicine जो हम actually apply करते हैं, और आइडियली ये डे टू डे हमारी केयर में होता है, बट फॉर रिसर्च इट हैज़ टू बी डॉक्यूमेंटेड एंड इट हैज़ टू बी इन स्ट्रक्चर्ड वे। सो देर आर 4 different pillars of ethics. Jyoti, what's the first one? First one, autonomy. What does that mean? What's autonomy? Autonomy is actually free will of a person. Free will, हर व्यक्ति को उसका अधिकार है कि वो अपना गलत सही खुद डिसाइड करे। तो ये हम रिसर्च में कहाँ पे प्ले करता है? कंसेंट, इन्फॉर्म कंसेंट। जो पेशेंट विल हैव टू डिसाइड कि उसे उस स्टडी में जाना है या नहीं। अगर वो पेशेंट इंक्लूडेड भी है तो एट एनी पॉइंट ऑफ टाइम पेशेंट को राइट है कि उसे विड्रॉ कर सकता है। दिस इज व्हाट ऑटोनॉमी। नेक्स्ट, बेनिफिशियंस। वर्ड इटसेल्फ इज वेरी क्लियर। एक ये कैरेक्टर या ट्रेट होता है किसका? जनरॉसिटी का एंड डूइंग गुड। तो हमारा हर आखिरी उद्देश्य हर रिसर्च का होना चाहिए, ऑलवेज डू गुड फॉर द पेशेंट। नेक्स्ट, नॉन मेलिफिशेंस। इसका क्या मतलब है? डू नो हार्म, नो डेथ, सिर्फ डेथ ही नहीं और क्या, एनी लॉस, एनी इनकैपेसिटेशन, एनी डिप्राइवेशन। इवन अगर किसी का फंक्शनल लेवल ये है उससे हम नीचे भी ला रहे हैं, इवन फंक्शनैलिटी दैट शुड ऑल्सो बी अवॉइडेड एंड इन एनी फॉर्म, फिजिकल, financial and mental. Last one is justice, fairness. यानी अगर हम कोई रिसर्च कर रहे हैं और हमारे जो पार्टिसिपेंट्स हैं, जो सब्जेक्ट्स हैं, उनमें किसी भी तरह का अनफेयर ट्रीटमेंट नहीं होना चाहिए ऑन द बेसिस ऑफ कास्ट, क्रीड, जेंडर, नेशनैलिटी। देयर शुड नॉट बी एनी बायस। सो व्हाई एथिकल प्रपोजल मैटर? तो अगर एक क्वेश्चन ये एमसीक्यूज में बहुत बार आता है कि जो इथिक्स होता है रिसर्च में वो किसके लिए है? वो डॉक्टर्स, रिसर्चर्स, सर्जन्स के लिए है या पेशेंट के लिए या दोनों के लिए? पार्टिसिपेंट्स इज ऑलवेज पेशेंट सेंट्रिक। जितने भी नियम बनाए गए हैं पेशेंट की सेफ्टी के लिए बनाए गए हैं, ठीक है? सो पार्टिसिपेंट राइट्स एंड वेलफेयर, पेशेंट सेफ्टी, साइंटिफिक इंटीग्रिटी मीन्स ऑनेस्टी, एक्यूरेसी और ऑनेस्टी होनी चाहिए। बिल्ड पब्लिक ट्रस्ट, कंप्लायंस, IRBs, इंस्टीट्यूशनल रेगुलेटरी बॉडीज़, जैसे हमारे यहाँ इथिकल कमिटी अलग अलग देशों में उसको IRBs भी कहते हैं, US में, इंग्लैंड में इथिक्स कमिटी जो हमारे यहाँ पे है। इन्हांस रिसर्च क्रेडिबिलिटी, लोगों का हम जो भी रिसर्च कर रहे हैं उनका ट्रस्ट होना चाहिए एंड वी शुड नॉट ब्रेक दैट ट्रस्ट। Avoid legal and ethical consequences, fair participant selection, it should be non-biased, and contribution to evidence based practice. हम लोग रिसर्च करते क्यों है? हमेशा क्या होता है, हमें कंट्रीब्यूट करना होता है। वी हैव टू ऐड टू एग्जिस्टिंग नॉलेज। या जो भी गैप है उसे हमें क्या करना है, फुलफिल करना है। ये भी हमारा स्टडी का या जो भी रिसर्च है उसका एक उद्देश्य होता है। तो इथिक्स की बात करें तो नोइंगली या अननोइंगली हम लोग ये ऑलरेडी प्रैक्टिस कर रहे हैं। कब से? 500 साल पूर्व, बिफोर क्राइस्ट, ठीक है। तो जो हिपोक्रेटिक ओथ है, अगर उसके हम बेस में जाएंगे तो उसका भी जो आखिरी हिस्सा है दैट इज डू नो हार्म, दैट इज प्रिंसिपल ऑफ नॉन मैलफिशेंस। लेकिन इसके बाद जो बहुत सारे कोड्स बने, बहुत सारे स्ट्रक्चर्ड गाइडलाइंस बनी, उनका बेसिस क्या था, उनका रेशनल क्या था कि मेडिकल रिसर्च की हिस्ट्री देखेंगे तो बहुत सारी चीज़ें हुई, इंसिडेंसेस हुए दैट वाज वेरी वेरी शेमफुल, वेरी डार्क फॉर द होल ऑफ द ह्यूमन रेस। उसमें से सबसे बहुत सारे एग्जाम्पल्स हैं, लेकिन हर क्लास, हर ट्रेनिंग, हर इथिक्स की जो टीचिंग है उसमें इसको ज़रूर कोट किया जाता है। व्हाट वाज दैट? इट वाज द डॉक्टर्स ट्रायल। जब वर्ल्ड वॉर सेकेंड ख़त्म हुआ उसके बाद, नॉर्मली जब भी वॉर होता है तो उसके बाद एक एनालिसिस होती है जिसमें मिलिट्री और नॉन मिलिट्री सारी चीज़ों का इवैल्यूएशन होता है। तो उसमें यूएस मिलिट्री ने एक ट्रायल स्टार्ट किया। ये उन लोगों के लिए था जिन्होंने जानबूझकर जो प्रिजनर्स ऑफ वॉर थे उनके साथ इनजस्टिस किया, इनह्यूमन एक्सपेरिमेंट्स और एक्टिविटीज़ करी। तो उसमें बहुत सारे लोग थे, जितने भी थे जिन पे ट्रायल चल रहा था, उनमें सरप्राइजिंगली 23 वर डॉक्टर्स, फिजिशियन। उसमें खुद एडोल्फ हिटलर का पर्सनल जो फिजिशियन था वो भी शामिल था। तो जब ये उसकी एनालिसिस हुई और ये ट्रायल 1946 से 47 तक चला, तो उसका जो रिज़ल्ट आया उसमें ये पाया गया कि एक्चुअली जितने लोग थे ट्राइड थे उसमें 7 को छोड़ के सारे गिल्टी थे। वाई देवर गिल्टी? जो भी ह्यूमन हिस्ट्री की सबसे शेमफुल एक्सपेरिमेंट्स और एक्टिविटीज़ करी थी उन्होंने। उसमें क्या किया था? मोस्ट कॉमन जो लिविंग ह्यूमन बॉडी पे हाइपोथर्मिया के स्टडी को देखने के लिए उनको क्या करते थे, माइनस टेम्परेचर्स पे प्रोलॉन्ग ड्यूरेशन के लिए प्रिजनर्स को एक्सपोज करते थे, जिसमें मोस्ट ऑफ द प्रिजनर्स यूज टू बी ज्यूज। मलेरिया एक्सपेरिमेंट्स, हेल्दी पेशेंट्स में क्या करते, हेल्दी लोगों में क्या करते थे, मलेरिया पैरासाइट इनोकुलेट करते थे ताकि मलेरिया का नेचुरल कोज देखने के लिए उन पर अलग अलग जो ड्रग्स था उसका ट्रायल देखने के लिए, विदाउट देयर कंसेंट एंड विदाउट देयर नॉलेज। मस्टर्ड गैस एक्सपेरिमेंट, इट वाज अ वेरी पॉइजनस गैस, बर्न होता था, अलग अलग सिस्मिक मैनिफेस्टेशन होते थे। उसकी स्टडी के लिए इन्हीं प्रिजनर्स को वो एक्सपोज करते थे मस्टर्ड गैस के लिए। देन बोन मसल एंड नर्व ट्रांसप्लांटेशन, एनेस्थीसिया, विदाउट एनेस्थीसिया, विदाउट पेन किलर्स, विदाउट एंटीबायोटिक्स। उसका इन रिजल्ट क्या हुआ? Sepsis, infection, very painful condition, and at times death because of septic shock. Sterilization experiment, masses में जाके sterilize किया था, खाली नाजीज की यूजेनिक्स को बढ़ाने के लिए, Jews को ख़त्म करने के लिए। So it was hardcore, unethical practice, and it was अभी तक जितने भी researches हुए हैं हमारी human history में, it's one of the most shameful. फिर फाइनली जब वर्डिक्ट आया तो उसमें 7 लोगों को डेथ सेंटेंस मिला और सभी को लाइफ टाइम इम्प्रिजनमेंट। लेकिन इसके बाद एक चीज़ ये इस्टेब्लिश हुई कि देयर वाज इस्टेब्लिशमेंट ऑफ द न्यूरमबर्ग कोड, बिकॉज दिस ट्रायल वाज बीइंग हेल्ड इन न्यूरमबर्ग, जर्मनी। तो इसके बाद इथिक्स से रिलेटेड जितनी भी स्टडीज़ हुई, जितने भी एविडेंसेस मिले, जितने भी स्ट्रक्चर्स बने, जितने भी फ्रेमवर्क बना, दैट वाज बेस्ड ऑन न्यूरमबर्ग कोड। तो इस पर क्वेश्चन आ सकता है, वो अगर इथिक्स या रिसर्च, हार्डकोर रिसर्च में, तो फर्स्ट कोड वेयर इट वाज डन एंड व्हाट वाज द आउटकम। तो जो न्यूरमबर्ग कोड बना उसके 10 प्रिंसिपल्स थे, जिसमें मोस्ट इंपॉर्टेंट क्या था? वॉलंटरी कंसेंट एंड अवॉइडेंस ऑफ अननेसेसरी हार्म। लेकिन कोड बनने के बाद भी क्या थ्रू आउट द वर्ल्ड ये चीज़ें फॉलो नहीं हुई? फॉलो हुई, अनफॉर्चुनेटली नो। उसका जो सेकेंड बेस्ट एग्जाम्पल है, जो इसी की सीरीज़ में दूसरा मोस्ट ड्रेडफुल, डार्क एंड शेमफुल माना जाता है, दैट इज़ टस्केगी सिफिलिस स्टडी। ये कहाँ पे हुआ था? अलाबामा में, यूएस में। इसमें भी उन्होंने क्या किया था? अफ्रीकन अमेरिकन पॉपुलेशन को लिया था और सिफिलिस की स्टडी कर रही थी। लेकिन ज़्यादातर वो लोग पुअर पेशेंट्स थे और उनको डिस्क्लोज नहीं किया गया था कि उनको सिफिलिस है। उनको बस ये बोला गया कि देयर आर सम बैड ब्लड, जिसका वो ट्रीटमेंट करेंगे, उनको फ्री में खाना देंगे। लेकिन उन्होंने क्या किया? 2 ग्रुप में डिवाइड किया। एक में सिफिलिस, ये जितने भी पेशेंट थे, उस समय 1943 तक पेनिसिलिन आ गई थी एंड पेनिसिलिन वाज अ ड्रग ऑफ चॉइस फॉर सिफिलिस। तो एक ग्रुप को तो उन्होंने सिफिलिस दिया, वो कंट्रोल था, दूसरे ग्रुप को दे डिडंट ट्रीटेड, और उन्हें जानने भी नहीं दिया कि इसका कोई ट्रीटमेंट अवेलेबल है। तो उसका नतीजा ये हुआ कि एंड दिस स्टडी वाज वन ऑफ द लॉन्गेस्ट, 1932 से स्टार्ट हुआ था और 1972 तक चला था। तो जब तक ये स्टडी हुई 100-200 से ज़्यादा लोगों की डेथ हो चुकी थी, बहुत सारे मेल से फीमेल में ट्रांसमिट हो चुका था, और बहुत सारे लोगों को ब्लाइंडनेस, मेंटल इलनेस, ये सारी मॉर्बिडिटीज़ हो चुकी थी। तो ये दुनिया के सामने कैसे आया? जो यूएस पब्लिक हेल्थ का एक ऑफिसर था, उसने ये इन्फॉर्मेशन सारी की सारी लीक करी एसोसिएशन ऑफ प्रेस को, न्यूयॉर्क टाइम्स को, और जब 1972 में पब्लिक हुआ तभी तुरंत फिर इस ट्रायल पे रोक लगा दी। और उसके बाद फिर क्या हुआ, बहुत सारे यूएस में स्ट्रिक्ट एक्ट बने, और देयर इज़ एक और रिपोर्ट बनाई गई, ठीक है। उस रिपोर्ट की वजह से फिर यूनेस्को और वर्ल्ड मिलिट्री एसोसिएशन ने भी क्या किया, इसको अडॉप्ट किया। So this was Declaration of Helsinki came before that, and there was a Belmont report. So role of ethics in biomedical research is for promoting trust and integrity, for protecting participants, ensuring fairness. There should be justice, enhancing credibility, and legal and professional compliance. हमारे यहाँ अगर हम इंडियन कॉन्टेक्स्ट में बात करें तो हमारा पहला जो इथिक्स से रिलेटेड डॉक्यूमेंट था वो ICMR, दैट वाज लेड इन 1980, और हम लोग ज़्यादातर जो इंडिया में इंस्टीट्यूट्स में फॉलो होता है दैट इज़ बेस्ड ऑन ICMR। इसका जो लेटेस्ट वर्जन है दैट हैज़ बीन रिवाइज मल्टीपल टाइम्स, और अभी जो चल रहा है दैट हैज़ कम इन 2017। और हमारे यहाँ पे जो भी रिसर्च हो रहे हैं, जो भी गवर्नमेंट एंड नॉन गवर्नमेंट इंस्टीट्यूट में, दैट हैज़ टू बी अबाइडेड बाय द रूल्स ऑफ ICMR। So principles: do no harm, and again the same 4 principles: autonomy, beneficence, non-maleficence, and justice. That has to be followed. ये एक चीज़ इंटरेस्टिंग है, और जो पूरा इथिक्स का जो डॉक्यूमेंट है वो इसी स्ट्रक्चर पे बेस्ड है। दिस इज नोन एज प्रिंसिपल, 12 जनरल प्रिंसिपल्स और डजन जनरल प्रिंसिपल। तो ये एग्जैक्टली इसी फॉर्म में फॉलो किया जाना होता है। व्हाट इज़ दैट? नेसेसिटी, क्या ज़रूरत है, हम क्यों कर रहे हैं। तो कोई भी रिसर्च का जो बेस होता है, मूल होता है, देयर शुड बी सम गैप और सम नेसेसिटी। देन कंसेंट, नॉन एक्सप्लॉयटेशन, सोशल अकाउंटेबिलिटी, सेफगार्डिंग प्रिवेसी, मिनिमाइजिंग रिस्क, नॉन मैलिफिशेंस, प्रोफेशनल एक्सपर्टीज, बेनिफिट मैक्सिमाइजेशन, बेनिफिसेंस, ऑर्गेनाइजेशनल स्ट्रक्चर, ओपननेस एंड अकाउंटेबिलिटी। अगर पेशेंट को रिसर्च के दौरान कुछ हार्म हो रहा है तो उसकी रिस्पॉन्सिबिलिटी लेनी होती है। Principle of comprehensive responsibility and environmental stewardship. So it looks very comprehensive, लेकिन it's quite doable. जब हम step by step ये चीज़ें करते जाते हैं तो ये हो जाता है, ठीक है। So इसमें most of you have already gone through this process कि एक covering letter होता है, हम वो किसको भेजते हैं, IEC को। कवरिंग लेटर, उसके साथ क्या होते हैं, बहुत सारे डॉक्यूमेंट्स होते हैं, उनका एक सेट प्रोफार्मा होता है, वो फिल करना होता है। उसमें क्या होता है, टाइप ऑफ रिव्यू रिक्वेस्टेड, कुछ क्वेश्चनर बेस्ड होते हैं जिसमें पेशेंट को हार्म नहीं होता है, वो जल्दी हो जाता है, उसको कहते हैं एक्सपीडेटेड। कुछ को कई बार प्रॉपर कमिटी में जाने की ज़रूरत नहीं होती, वो एग्जेम्प्टेड होते हैं। और कुछ जो ट्रायल्स ज़्यादातर होते हैं या इंटरवेंशन वाले होते हैं उसमें प्रॉपर रिव्यू की ज़रूरत होती है। देन केस रिकॉर्ड फॉर्म अगर स्टडी में एप्लीकेबल है तो दैट हैज़ टू बी अटैच्ड। रिक्रूटमेंट प्रोसीजर्स, किस तरह से पेशेंट रिक्रूट करेंगे। इंस्ट्रक्शन कार्ड, अगर कोई प्रोसीजर है उसकी एक पेशेंट की लैंग्वेज में सिंप्लीफाइड उसका डिटेल पेशेंट को देना पड़ता है। इन्वेस्टिगेशन ब्रोशर, ये ज़्यादातर ड्रग ट्रायल्स के लिए होता है। डिटेल्स ऑफ फंडिंग एजेंसी, अगर कोई इंडस्ट्रियल सपोर्ट ले रहे हैं या किसी एक्सटर्नल एजेंसी से ले रहे हैं, दैट हैज़ टू बी डिस्क्लोज्ड। COI, कॉन्फ्लिक्ट ऑफ इंटरेस्ट, वो बताना होता है कि आपका कोई पर्सनल एडवांटेज, कोई मॉनेटरी बेनिफिट अगर उससे जुड़ा है तो यू हैव टू डिस्क्लोज। देन एनी अदर रिसर्च एथिक्स, अंडरटेकिंग विद सिग्नेचर ऑफ इन्वेस्टिगेटर, उसमें एक पेज होता है जिसमें सारे PI को PI की कॉन्टैक्ट एड्रेस होता है और साइन होता है, अप्रूवल होता है, ठीक है। इंश्योरेंस पॉलिसी, इंडेमनिटी पॉलिसी, अगर कुछ इंटरवेंशन कर रहे हैं, ड्रग ट्रायल कर रहे हैं जिसमें पेशेंट को पोटेंशियल हार्म हो सकता है तो उसमें हम कैसे कवर करेंगे, उसका भी डिस्क्लोजर हमें देना होता है। ये ज़्यादातर मल्टी सेंट्रिक ड्रग बेस्ड ट्रायल्स या फार्मास्यूटिकल जो कंपनीज होती हैं उनके जो ट्रायल्स होते हैं उसमें पॉलिसी और इंडेमिनिटी का होना ज़रूरी होता है। फिर इसमें जो फर्स्ट डॉक्यूमेंट था दिस वन, इसमें जो सीरियल नंबर 25 है उसमें प्रोटोकॉल है। अब प्रोटोकॉल भी अपने आप में बहुत एग्जॉस्टिव डॉक्यूमेंट है, ठीक है। तो प्रोटोकॉल के भी डिफरेंट कंपोनेंट्स हैं। तो ये जो 18 ये अलग से सिर्फ प्रोटोकॉल के हैं। इसमें क्या होना चाहिए, टाइटल, समरी, जो मोस्ट ऑफ थिंग्स यू ऑलरेडी डन, बैकग्राउंड विद रेशनल, इंक्लूजन एक्सक्लूजन क्राइटेरिया, रिसर्च ऑब्जेक्टिव्स, एलिजिबिलिटी क्राइटेरिया, फिर किस तरह की स्टडी है, उसका नेचर क्या, स्टडी डिज़ाइन क्या, जैसा अभी मेहरोत्रा सर ने डिस्कस किया था, ड्यूरेशन ऑफ द स्टडी, प्लेसिबो, बेनिफिट, रिस्क, पेशेंट को कितना फ़ायदा कितना नुकसान है ये क्लियरली मेंशन होना चाहिए। प्रोसीजर फॉर सीकिंग एंड ऑब्टेनिंग इन्फॉर्म कंसेंट कैसे करेंगे, रिटन, वर्बल, ऑडियो विजुअल। ज़्यादातर ऑडियो विजुअल कब करते हैं, जब हम पेशेंट का स्पेसिमेन लॉन्ग ड्यूरेशन के लिए प्रिजर्व करते हैं, रीयूज़ करते हैं, तो ऑडियो विजुअल होना चाहिए। या फिर ट्रायल्स, प्लान फॉर स्टैटिस्टिकल एनालिसिस, किस तरह की स्टडी में लगाएंगे, 1 more minute, एंड प्रपोज कंपनसेशन, ये ज़्यादातर ट्रायल्स में होता है। प्रोविजन ऑफ एंसिलरी केयर फॉर अनरिलेटेड इलनेस, आप कोई किसी और ड्रग का कोई और इफेक्ट देख रहे हो, उस दौरान पेशेंट को कोई और तरह की इलनेस होगी तो भी वो आपकी जिम्मेदारी है, यू हैव टू ट्रीट द पेशेंट और यू हैव टू टेक केयर ऑफ द पेशेंट। प्लान्स फॉर पब्लिकेशन ऑफ रिजल्ट, और हर रिसर्च का एंड रिजल्ट क्या होता है, आपको उसको साइंटिफिक कम्युनिटी में लाना है। कैसे, इन फॉर्म ऑफ पब्लिकेशन, चाहे वो पॉजिटिव हो चाहे नेगेटिव रिजल्ट हो, यू हैव टू पब्लिश। उसमें भी पेशेंट हैज़ टू बी वेल इन्फॉर्म, पेशेंट की कंसेंट होनी चाहिए। ethical consideration and safeguards for protection of participants। अच्छी बात है कि हमारे ethical committee they already issued some handy notes जिसमें उन्होंने सारे इंस्ट्रक्शन दिए। तो whosoever undergraduate nursing और resident जिनको भी even for faculty जिसको भी करनी है, अगर इन सारे step by step if you go through this, most of the things are very clear। ओनली थिंग इज जो बड़े इंस्टीट्यूट होते हैं, सेंट्रल इंस्टीट्यूट होते हैं, उसमें क्या होता है, जो इथिकल रिव्यू का टाइम होता है इट मे बी प्रोलॉन्ग। तो बेहतर होता है हमेशा 3-4 महीने पहले यू शुड हैव दैट डेल्टा बिटवीन एक्चुअली स्टार्टिंग द प्रोजेक्ट एंड सबमिटिंग इथिकल। तो 3-4 महीने का टाइम लेके बिफोर एंड इट शुड बी सबमिटेड। सो दिस इज अ सैंपल ऑफ कवर लेटर। इसका हमेशा क्या होना चाहिए, दैट हैज़ टू बी फॉरवर्डेड बाय हेड ऑफ द डिपार्टमेंट और चेयर ऑफ द डिपार्टमेंट। देन ये प्रोफार्मा होता है, ये प्री स्ट्रक्चर प्रोफार्मा है जो इंस्टीट्यूट वैरी कर सकता है, बट जो बेसिक कंपोनेंट्स हैं वो ज़्यादातर क्या होते हैं, सेम होते हैं। इसको भरना भी आसान है, जो चीज़ें एप्लीकेबल नहीं यू हैव टू स्ट्राइक ऑफ, जो एप्लीकेबल हैं उसमें टिक करना। ज़्यादातर जो क्वेश्चंस होते हैं वो पेशेंट सेफ्टी, पेशेंट की प्रिवेसी, पेशेंट का जो डेटा कॉन्फिडेंशियलिटी और वल्नरेबिलिटी उससे रिलेटेड होते हैं। अंडरटेकिंग बाय द प्रिंसिपल इन्वेस्टिगेटर, इसमें क्या होता है, इसमें जो अकाउंटेबिलिटी की बात करें, प्रिंसिपल इन्वेस्टिगेटर को रिस्पॉन्सिबिलिटी लेनी होगी कि ये अप्रूवल मिलने के बाद भी स्टडी पूरी तरह से क्या होगा, इथिकली कंडक्ट किया जाएगा। और इस दौरान पेशेंट को या कुछ भी जो भी कंप्लेंट्स होती हैं या जो भी कॉन्फ्लिक्ट्स होते हैं, अगर कुछ होता है तो प्रिंसिपल इन्वेस्टिगेटर की जिम्मेदारी है टू हैंडल दैट इशू एंड टू मैनेज। इन्फॉर्म कंसेंट, तो हमारे यहाँ जो इथिकल अप्रूवल के लिए भेजा जाता है उसमें जो मोस्ट कॉमन रिजेक्शन होता है कि दोबारा या मेजर चेंजेस, माइनर चेंजेस, पुअरली रिटन होता है। पुअरली रिटन में या तो ऑब्जेक्टिव्स क्लियर नहीं होते हैं या मेथड, सैम्पल साइज वेल कैलकुलेटेड नहीं होता है। और जो दूसरी मोस्ट कॉमन चीज़ होती है कंसेंट, तो कंसेंट में इंग्लिश में तो रहेगी, पेशेंट की जो लोकल वर्नाकुलर लैंग्वेज है या हिंदी है उसमें भी एक इन्फॉर्म कंसेंट का फॉर्मेट होना चाहिए। So this we have already discussed, but because of the scarcity of time we could not over-emphasize. Regarding decisions, approved या तो ethical committee approve कर देगा या फिर revision with minor modification, वो अगर हम resubmit करते हैं तो expedited होता है, जल्दी हो जाता है। दूसरा होता है revision with major modification, उसमें फिर क्या होता है, पूरी प्रक्रिया फिर से चलती है, again it may be time taking 1 to 3 months। नॉट अप्रूवल, उसमें कुछ मेजर लूप होल्स होंगे या इथिकली सही नहीं होगा या जो टाइप ऑफ स्टडी है वो फिजिबल नहीं होगी. So the bottom line is, because professionals sometimes do more harm than good when they intervene in the lives of other people, their policies and practices should be informed by rigorous, transparent and up-to-date evaluations. Thank you.
Thank you very much, ma'am, for the insightful talk. I would request Dr. Jiten Kushwaha sir to kindly come on the dais and felicitate ma'am. Thank you, sir. Thank you, ma'am. Thank you, sir. Next up, we have a live session. We have a live session by Dr. Shabi Ahmed, from Eminent Medical College, Allahabad. Medical College, Allahabad. Presenting on rectal prolapse. It would be a Zoom call. It would be a Zoom call.
Hello, am I audible?
Yes, sir. You are audible and you can start. Thank you, sir, for your presence.
Thank you so much. I'm really delighted to meet you again, you all people, and special thanks to Dr. Abhinav and the organizing team for remembering me. And let me share my screen and get off with this. Share. How do we do that? Just guide me how to share my screen. Just a minute. Give me a minute. Okay. This is the section.
Sir, on the bottom corner, you can see the share screen option.
Is it now?
Yes, sir. It's visible.
Are you
now.
getting it?
Yes, sir. Yes, sir.
Excellent. So, really delighted to talk to you, all the PGs and the faculty of the KGMU department. So let's straight away get to the topic. I'll be dealing with the rectal prolapse, especially the surgical aspect. As you all know, that full thickness rectal prolapse describes the entire rectum protruding to the anus, and mucosal prolapse is only the partial or the mucosa which comes out. And now there is another term which often confuses especially the PG. Let me get to the, can you see the pointer on the screen? Can you see pointer on the screen? Anyone, please? Chairpersons? There is a red pointer on the screen. Hello?
Yes, sir.
Acha, okay. I was saying that, is there a red pointer on the screen? I think yes. Okay. So basically internal intussusception, where the rectum doesn't exist the anus, but it remains inside and presents in various forms, defecation and problems in defecation like somewhat akin to an ODS syndrome, etc. So that's another thing. So basically the anatomical anomaly that I'll just revise that there is an abnormally deep pouch of Douglas and there is lax atonic muscles of the pelvic floor and anus. There is weakness of sphincters and often may be associated with pudendal neuropathy, or there may be lack of normal fixation of rectum with a mobile mesorectum or lax lateral ligaments. So what are the causes? In short, it can be associated with the following conditions. That is an advanced age, as I'll show you later on that the age group in which this occurs, long-term constipation, long-term straining during defecation, and this is especially very habitual you can say, in our population of straining and attempting to empty the rectum completely. And this is a very common complaint that they cannot empty the rectum or the motion is not clear. And herein comes this part. Anal sex, long-term diarrhea, etc. of childbirth, and previous surgery which may be weakening the pelvic floor. Now, a brief review, these muscles, all the PGs know, especially focus on the perineal body, to which the external, the perineum muscles are attached, and then the part of the levator ani, which is especially the puborectalis, which maintains the angle of the anorectum and gives continence about 70% of the total continence, and rest is contributed by the external sphincter. So there is weakening or lax of these muscles which often lead to a prolapse. So how common is rectal prolapse? Fairly uncommon, but not rare. We see it quite often in the OPDs. And incidence is unknown because of underreporting, especially in the elderly population. And age group, you see it in children and you see it older groups. And majority, about 80 to 90%, are females. And they may be associated 50% incontinence, which may be in the form of fecal soiling or mucus discharge, sometimes, or frank incontinence. And on the contrary, about half of them or less than half of it, 15 to 65, that's the reported reports in literature, that there may be constipation associated with rectal prolapse leading to straining and prolapse of the rectum. So this is often concurrent with pelvic floor descent and prolapse of other pelvic floor organs. And herein comes the concept of pelvic organ prolapse syndrome, or POPS as it is said, and it has divided into the anterior, middle and the posterior components, especially in females. The anterior can be the bladder and the vaginal prolapse, mid one consisting of the rectal prolapse, posterior one is the rectal prolapse, and mid one is the vaginal or the wall prolapse, especially in patients after hysterectomy. However, it has been seen that many patients can be nulliparous. So this graph, this bar diagram depicts the heterogeneity, heterogeneous population. You can see that young population, but majority is grouped in the elderly group from about 50 years to about 90 years of age. Now, if you talk about the demographics, as I said, that is mostly in females, and of course is present in Asians. This is an international kind of data. Age mostly elderly, however, not uncommon in young children, and they almost have ASA grade 2 or 3, and that means there are comorbidities present. So this was about the, we'll talk about the surgical part later on. So evaluation basically is important. See the patient in OPD and you have to take a good history. And remember, as I said, that herein you'll get a lot of patients which will be complaining of motion not being clear after teeny saaf hoti hai. And they are straining, they have a habit of finger evacuation, and how much time they are spending on the like in the toilet or on the commode, that you should ask, because then it will let you understand that what exactly is the problem with the patient. And of course, an examination is very essential. A DRE is very, very essential part of the evaluation. And during that DRE, you have to see, normally when the patient comes to the OPD, you'll see the patient and where there is no prolapse. But what we follow here, that I would definitely examine the patient myself, look for the perianal area, muscle tone. very important. When you do a DRE in a patient with prolapse, you all often find the anal sphincter patulous. And you note the squeeze pressure also. That gives a rough idea of the muscle tone. Ask the patient, put your finger in and ask the patient to squeeze. Then what I also ask is that if the patient has come, they should take a photograph while at home. Sometimes this prolapse is not evident in the OPDs. Ask the patient to get a photograph in their convenience or at the home, or even they can make a short video with their mobile phone. Everyone has got that. And that gives a very good idea, if you're not able to elicit this prolapse, that actually what is happening when the patient is at home. Now, investigations, colonic imaging, especially, as you know, that sometimes the left-sided colonic cancer can be associated with prolapse or polyps might be there. So, basic sigmoidoscopy is very important. If you can get a complete colonoscopy, fine, but an essential bare minimum is a sigmoidoscopy. Difficogram definitely is required. Anal manometry is not very mandatory. If the rectal prolapse is very evident and there is a procedentia, then you can assess it, but this test might not be available everywhere, so it doesn't mean that the patient will not get a treatment. Now, defecography can be done easily. If you have the facilities, then MR defecography is very good. It tells you about the muscles, pelvic floor, the intussusception or the intrarectal prolapse. Otherwise, you can have a fluoroscopic defecography, and there are certain recent tests which are being done nowadays, that is the dynamic transperineal ultrasound or 3D ultrasound. Of course, manometry has said that if you can get it, fine. If you don't get it, then it's not very mandatory. And the rest of the EMG studies, etc., if available, they can be done. So what is the aim of the treatment? One, you have to control the prolapse. Second, prevent recurrence. And to restore a normal bowel function wherein the patient can have confidence in passing motion without the fear of the prolapse. You should restore continence, especially in patients who have this fecal incontinence, or you should also prevent the constipation in those group of patients who complain constipation or impaired evacuation, and often they would give you a history of finger evacuation. So these are the other group of people. So this is very important in the assessment part also. Now, basically, the treatment aims at either resection or plication of the redundant bowel, and plus minus the fixation of the rectum to the sacrum, as we'll discuss later on. And this is achieved through two group of approaches, that is the perineal or the abdominal approach. Now, this is a situation where the prolapse is neglected. Patient comes with an incarcerated prolapse, congested mucosa, and you may even have gangrene. The patient comes with a blackened or dusky bowel. So what is to be done in emergency? That is another issue, because this is a patient wherein you cannot send back if the patient comes in the night. What you do? You try to reduce the mucosal edema. Salt or sugar, grounded sugar can be applied, or at least apply some glycerine gauze so that you reduce the edema and attempt a gentle reduction. Because this patient, if you are very aggressive, then you may even tear up the bowel. So this group of patient also will present you in emergency, and herein emergency is required if the prolapse cannot be reduced and the viability of the bowel is in question. And most of the time, the perineal approach is done in such cases. So there is always many ways to skin a cat. In 1959, Charles Well, by what we know as the Wells operation, said that I've traced the literature in between 30 and there are about 100 operations for prolapse of the rectum. And there is still some more. So over 100 procedures are described, and that only shows, when there are a lot of procedures, it only shows that there is still some need to improvise. So let's talk about the approach, perennial approach. Okay, so what are the advantages and disadvantages? That is, got low morbidity, high recurrence rate, avoids abdominal surgery and the pelvic dissection. So basically, it is like cutting off an upturned sock but not fixing it. So Delorme's operation was first described very early, 1900, wherein a circumferential incision is made through the mucosa of the prolapsed rectum near the dentate line, and using electrocautery, the mucosa is stripped off and cut from the apex. The denuded muscles is then plicated with a suture, and then you can say, imagine a clock, and you place these sutures at 12 o'clock, 1 o'clock, 2 o'clock, 3 o'clock, etc., depending on the distances. You place it serially, and then all these sutures are reefed up, and then it forms also a buttress of the muscle, and then the transected edges of the mucosa are sutured together, and they are placed back or inverted into the anal canal for it to stay there. This reefed up prolapsed muscle is supposed to give it a buttress and avoid any prolapse. So basically, this has been reserved for an aged group of population, and wherein the prolapse has been neglected also, or do it in emergency. So it has got a fairly low morbidity. It can be done under local and the spinal. And this is the results. There are various results on this, but as you can see that the recurrence is up to the tune of 38%, about 1/3 can recur. Low mortality, but several studies show consistently that the recurrence in best of hands has been from 6% to 30%, so a little bit more. And the improvement in constipation is there. Some amount of incontinence some of the patients can have. So next comes the Alt-Myers surgery. It was first used by Miles in 1933, and again Alt-Myers basically established and standardized it in 1971. So what is this and different from Delorme's is that there you did a mucosal resection, but here a full thickness circumferential incision is made in the prolapsed rectum, about 1 to 2 centimeters distal to the dentate line, and after this the rectum, or you can say the anorectal area, is cut, the hernial sac is entered, and the prolapse is delivered. The mesentery of the prolapsed bowel is serially ligated, and the redundant bowel, as much as the redundant bowel is pulled down, the bowel is transected, hands into the distal anal canal or staple using a circular stapler. And some of the patients, if they require a levator anaplasty, then the muscles, the levator ani muscles can also be buttressed anteriorly so as to improve the constipation. So herein you can see that this is the pictorial depiction, that here is this is the apex of the prolapse, and here in about distal to the dentate line, just incision is given. This is full thickness. That means this is full thickness, and this part which is, I am moving my pointer on that, is the prolapse part of the bowel, which is now coming or telescoping through the outer tube. And this is the prolapse part of the bowel, which is brought out as much as it can. And here you can see that the mesentery of the sigmoid or the bowel which is coming out is clamped and ligated. Then the prolapsed bowel is basically transected about 2 centimeter distal to this outer sleeve. And as you can see that these two ends, this cut end and this cut end, will now be sutured together to do a complete anastomosis, interrupted or continuous in a single layer manner. and then this is going to be inverted. So this is the resection process, complete resection of the prolapsing part of the bowel is done. In this part, since there is associated resection being done, the recurrence rate is less as compared to the Delorme's procedure. And often in many series, it has been from 0% to about average about 16%. One report says about 29, but about 16%, but majority 29 patients and 16%. So majority is less. Now there is another procedure which is sort of a modification of the Altmaier's. That is the perineal stapled prolapsed or known as the stapled Altmaier's procedure. Here again, the prolapse is pulled out completely, and basically at 3 o'clock and 9 o'clock, the prolapsed bowel is cut with a linear stapler. And the dissection is performed using a curved contour or the transistor stapler. And here is some of the reports, the results of the published reports, that this is fairly a quick surgery, and it can be done in patients who are 80 years and above. Operating time half an hour to 1 hour, and the stay is also around 5 days. And this is basically what has been done by open and through the cutting technique, and suturing is done with staplers. So functional outcome after PSP for the external rectal prolapse, that fairly good. And but some of the patients had complained of continuation of the symptom, that in some amount of prolapse had been there, but fairly good for patients who are requiring a fast surgery in emergency and in OPD. The incontinence score, definitely the Wexner score improves after the PSP surgery, as you can see. It's comparing the pre-PSP and the post-PSP. So now come to the abdominal procedures. Now abdominal procedures, we open the abdomen, anatomy, and the pelvic surgery and dissections or resections is being done. So it's a suture rectopexy, mesh rectopexy, resection rectopexy, and the latest addition is lap versus open versus robotic. So posterior suture rectopexy was first described by Catat in 1959, and basically there is mobilization, dissection of the peritoneal folds, and without doing any mesh, etc., the rectum is fixed to the sacrum, and the recurrence had been fairly low, around less than 10%. Even John Gallagher had suggested that mobilization alone may cause adequate fibrosis to treat prolapse. And there have been published records and reports that there is no significant difference in the recurrence rates. Now, there had been run RCT of the rectopexy versus the non-rectopexy, and the sigmoid resection was allowed in presence of constipation, and there was no significant difference in the complications rate. However, resected versus non-resected, the recurrence rate was significantly different. Now, posterior mesh rectopexy and Ripstein, Wells used the sponge, and there is mesh being used, posterior mesh, then the mesh was used anteriorly, then there was a difference that complete wrap of the rectum while fixing to the sacrum, but that led to which was covered, and 1/3 left anteriorly open, which can like accommodate the feces, accommodate the movement. So it was associated with the, I'm telling about the different variations of this posterior mesh rectopexy. And this was like several reports has been there. So using a complete encerclage of the mesh, that was done away, then incomplete anterior fixation as classical described by Ripstein or Wells classification. Then there has been replacement of the sponge. Again, the recurrence rate has been on the lower side. So but it has some other problems also, like pelvic sepsis, which has been around 2 to 10%. And of course, you have to be very careful when you are dealing with fixation on the sacral hollow, because you may damage the sacral plexus, and it bleeds a lot and difficult to control. Hematoma should be avoided, and we have to place a drain if there is considerable ooze. The incontinence improves, but constipation was the more side effect, and that's why the variation of using the size of the mesh, doing a 360 degrees wrap or 270 degrees or just about 180 degrees wrap of the rectum on the posterior side. So this is basically just a diagram to depict that this is basically the redundant sigmoid, and an anterior resection is performed, the anastomosis is completed, and the rectum is fixed to the sacrum. So it improves constipation, but the only risk is that we are putting in a suture line, and that is why we are not doing a mesh, we are not using a mesh, but just suture rectopexy. So the risk of anastomotic leakage increases. However, it is very good in those patients who are really constipated and having prolapse. So resection rectopexy is redundant rectosigmoid, and it places a straight course of the left colon and involves more fixation, and there is definite relief of the constipation. So now comes the new version, that is the laparoscopic. Laparoscopic advent, it simplified procedure in a way because you could get a good view of the pelvis with a good audio, the visual camera and the instruments. There was reduced pain, reduced stay, and all these studies show that there is no difference in the incontinence, constipation, or recurrence. So it has been fairly well accepted by the patients. And one disadvantage, as you can see, that the operating time slightly more, but the hospital stay very favorable and very low. So basically, it involves a full circumferential mobilization to the pelvic floor. The lateral ligaments are divided, and polypropylene mesh secured to the sacrum with a protract or with sutures or even with glue, and laterally it is sutured to the sides of the rectum. And there has been audit of these, that means how many patients have been included, what's the functional results, what is the definition of recurrence, etc. And the long-term results show that even at the 5 years, the recurrence rate is fairly low, less than 10%, around 4. And if there had been some mucosal prolapse, that had been dealt with banding, etc. The incontinence score improved. The constipation score was not much different. So these patients did not have much constipation as compared to the open earlier procedures. So if you summarize, recurrence with Delorme's highest, and the posterior suture rectopexy, around 9%, and the resection has got the least recurrence rate. So why is constipation associated with rectopexy? Briefly, after the full mobilization of the rectum, there might be autonomic nerve injury, and this often leads to dysmotility and impaired evacuation. Now, the laparoscopic ventral rectopexy, this is the latest and often has been claimed as being a gold standard, that finally we might have arrived at a gold standard of managing rectal prolapse. And basically, as you know, the purpose of surgery for rectal prolapse was to correct the prolapse, protect or restore continence, and avoid constipation. So we are correcting also the middle compartment prolapse, because in females, the correction, the opening of the anterior, the rectovaginal septum, also improves the vaginal prolapse. And when we are placing the mesh, we can not only fix it to the rectum, but we can also make a Y and fix the vaginal wall also to prevent a concomitant middle compartment prolapse. And since this is a brief description, that basically a J, a reverse J kind of incision, you can see my this red dot and the pointer, and this incision done from the right side and opening up the deep the a pouch of Douglas recto-vaginal pouch, and this peritoneum is incised, and then the plane is dissected. After dissecting it and remobilization, basically a polypropylene mesh, usually we use now a soft mesh, and we have completed quite a lot of these procedures in our department. And basically I'm using either a Vipro or a soft mesh while fixing it, and it's very effective rather than using the normal kind of the high density proline mesh. The soft mesh is much acceptable and need not fix it tightly. Here the Protac can be used as proline sutures to fix it to the sacrum, and basically the lower part of the mesh can be fixed to the anterior aspect of the rectum. Now this is what I was talking about. Sometimes when you have a concomitant middle compartment prolapse, vaginal uterine prolapse, then the same can be cut in a Y. One part goes to the rectum, the other part can be stitched to the posterior vaginal wall, or in case of wall prolapse to the vault of the vagina, and it corrects a lot of things, and patient really get a good benefit out of this. So after this, the peritoneum has to be closed over this mesh to prevent morbidity and complications post-operative. So there has been a lot of published reports now on the laparoscopic ventral mesh rectopexy. This is a real image from one of our patients. And low recurrence rate, 3.4% only. Continence improved, 45%. And constipation not affected. These were the best part. Because earlier procedures, they were affecting the constipation, especially the wrap around and those techniques of the posterior rectal pexy. And here in the ventral rectopexy, doesn't affect the constipation so much. Now, complications, of course. One complication I will talk about is the mesh erosion. Even though not very common, but this has been there with almost every procedure. Even it has been the problem of the gynecologist and the urogynecologist, wherein they have been using mesh to deal with vault prolapse or the middle compartment prolapse, wherein erosion of the mesh to the bladder can be to the vaginal wall or posteriorly to the rectum. And otherwise, these complications still, the major complications are less than around 1 to 2%. And we need further follow-up because this has come lately. And operating time is slightly more, about 2 hours. Hospital stay is less, and recurrence rate, continence, etc. is much better than the previous surgeries. So the bowel function scores, of course, as I said, that is better at the end of a year and a 2 year, median follow-up of 24 months. So is it really a cure? It has an excellent cure rate, an improvement in incontinence, constipation for the full thickness rectal prolapse, good long-term results, and no reports of mesh erosion in the colorectal literature. But is it not? Then again, the problem of mesh, as with others, it may continue to shrink with time. And there has been an increasing number of vaginal erosions. And I think that is why we started using the softer mesh or the hybrid kind of mesh, the Vipro mesh. And instead of the stiff, high density polypropylene mesh. We don't have a comparative study on this, but I find personally that this is using just changing the type of the mesh in this surgery has given better results and lesser risk of this part of vaginal erosion, because it can be often difficult to treat these erosions and you have to remove the I've yet to come across this kind of complications, but it has been there, and people usually then try to remove the mesh or cut the mesh, whatever part of it, and do a conservative management in this aspect unless it warrants a surgery. So what should be the procedure? Now we can conclude and try to conclude and revise the perineal procedures for the elderly unfit patients. It has got a low morbidity but a high recurrence rate. We should know and inform the patient well in advance when we are doing that. Role of rectopexy, preferably laparoscopic now with the advent of this. How about robotic? I especially did not touch robotic because it will be complicated issues. Robotic also gives the same result at a very, very enhanced cost, and people are doing robotic ventral mesh rectopexy, but the results are not much different from the good old the laparoscopic procedure in a fit patient who can tolerate a GA. So the posterior suture rectopexy as good as the posterior mesh. That's a personal preference, what you try to do. And a ventral rectopexy adds a mesh, but it's superior if the perineal descent and other organs prolapse and avoids new constipation. And of course, we have to vary of the mesh. So is perineal approach really safer? There has been results depending on this, but suffice to say that yes, for a patient who has got a high ASI score and mortality, morbidity risk, that approach can be adopted. So I conclude that tailor the procedure to the patient fitness and anesthetic risk. Tell the patient the risk versus recurrence rate. It is very, very important, especially when the young patients comes to you that you are trying to do rectopexy. And also talk about the damage or rectal, very rare complication of erectile dysfunction, etc. That also must be discussed. It's always good to discuss the problems and complications with the patient, that yes, we have several methods, but this is the best method, and all these carry certain problems, and none of these problems are proven to be 100% satisfactory effective all over in the literature. And the ventral mesh rectopexy in women with any evidence of middle compartment syndrome, we have to talk about the mesh, the long operating time, and potential mesh complications. And 90%, 80 to 90% are females, 10% are men. So what I just said, that has to be kept in mind. Thank you so much. Any questions I will take.
So any questions, please? Thank you, sir, for your interesting talk on rectal prolapse.
I have time. I'll give you a situation. I think I have 2 minutes.
Okay, sir. Okay, sir. You can continue.
I can see that. So let's ask the students. Now I'll give you a scenario. I could not get it on slide, but I'll tell you. Try to listen. There is a patient, 85-year-old, frail old lady, and patient had Delorme's surgery. Understand? Delorme's mucosectomy and surgery. After 2 years, patient again comes with recurrence, with the rectum protruding out. What should be the option and how to proceed? Anyone? We just had a talk on rectal prolapse, pros and cons. I give you a given.
Anyone among you can answer the question?
Just let's take an attempt. A perineal procedure, recurrence. Old lady, 85, of course not very fit. I mean, she can, let's say, ASA grade 2, and all that, not moribund, but what could be the options? Listening to all the various options, what do you think? Should we go in again for the perineal part, or should we resort to some other part? It should be an open surgery or a laparoscopic surgery. And among all, what would be the best option? Anyone? Part of the first question, that should we go for a perineal approach again? Patient had a Delorme's surgery. Should we go for Altamars? Altamar, resection or stapled? Yes or no? See, I'm sitting very far off in Allahabad. So you can always make blunders without any hesitation. Of course, we'll give the right answer. Yes, make an attempt. Anyone? So, okay, if none, I'll give the answer. So basically, remember that this patient had a recurrence. So perineal surgery would be difficult. Already she had surgery, there'll be a lot of adhesions. So if you attempt to resect it from here, as I said, in Altmaiers, there will be a complete circumferential resection of the outer tube and then mobilization of the inner tube and cutting it and joining these two tubes outside the anal canal. This is Altmaiers. So doing this would be problematic. There will be adhesions, lot of adhesions there. And it will be difficult to separate you and not be able to do anastomosis. This patient actually underwent an evaluation. So what was, now you have to say that, sir, first I will evaluate this patient. So you have to evaluate what? For the integrity of the sphincters. So you do a MR, you can do a CT. Of course, you reduce the prolapse. If the prolapse is not incarcerated, so that question should have asked, sir, it is incarcerated or not? So it is not incarcerated prolapse. Prolapse can be reduced, but there is recurrence. So it has to be reduced, and evaluation by MR defecography, structure of the muscles, MR will give, or you can also do a transperineal ultrasonography, or a truss can also tell you the integrity of the external and the internal sphincters. And after this, basically this patient underwent a ventral lap rectoplexy, and she did nicely after that, and that was the best option. Just a mobilization of the anterior, the rectovaginal pouch, and placement of the mesh and closure of it, and patient was symptom free for more than a year. Anything? Thank you so much. I just gave a clinical scenario so that it will be a revision for all the students.
Thank you, sir, for your precious time that you have given, and I'm sure that the students must have got their knowledge upgraded after your lecture regarding the rectal labs. So thank you once again.
Basically, I would suggest that usually these lectures, I mean, are slightly more concise, advanced. So maybe they should do some a little bit of basic revision, then it will become interesting. Because if we take to basic things, then it will take a lot of time, and then the recent advances would be left out. So
Yes,
that's
sir.
my suggestion to all
Sure,
the
sir.
PGs.
Sure, sir.
Best
We'll
of
follow
luck
it
and my
from-
best wishes from here in Allahabad.
Thank you, sir.
So I log off, Mr.
Okay,
Chairman.
sir. Yes, you can log off. Thank you once again.
Okay, you can disconnect my connection. Thank you.
रेजिडेंट 5 मिनट और बैठ जाओ, एक छोटा सा टॉपिक होना है कोलोस्टमी बैग पे, कोलोप्लास्ट वाले लोग थोड़ा सा शो करेंगे कुछ, ओनली फॉर 5 मिनट्स. उसके बाद जो है अपना एंडो ट्रेनिंग वर्कशॉप पे चले जाना. ठीक है, वो भी करवाने अभी 5 मिनट्स का. आप प्लीज 5 मिनट्स से करके ग्रुप फोटोग्राफ भी होना है इसके बाद. ठीक है, जो इम्पोर्टेंट आपका है वो आप बता दीजिए, उसके बाद फिर we'll have a group photograph with the audition.
All the residents and doctors who have joined us from outside other than KGMU, please remain seated as we'll be having a group photograph after this session. Okay, thank you.
Students who have given their e-poster presentation today, they will get their certificate on their mail. And बाकी और जितने हैं वो अपना यहाँ पे जो यहाँ वाले हैं.
So, very good afternoon, sir. I'm Saman. You might be familiar with Akbar. Akbar is my BSc nursing colleague. So, I hope I am audible for everyone. So you might be familiar with Akbar. Akbar is my nursing colleague. Sir, I am someone from Coloplast, and my team is, Akbar is the member of one of my team. Sir, you may be familiar with the colostomy bag. There are certainly, I will be making it very fast. Sir, Akbar तो permanently यहाँ based है, duty इनकी KGM में ही है. So there are certainly two types of colostomy bags. Once you had seen is a one piece where bag and flange are attached to each other. That we call one piece colostomy bag. सो यहाँ पर 17501 के नाम से आता है, आपने देखा होगा उसमें स्पाइरल एडेसिव है. सिंस अनदर काइंड ऑफ बैग इज वेयर द बैग एंड फ्लैंज आर डिटैच्ड टू अनदर वन, सो दैट इज कॉल्ड टू पीस. नॉर्मली जब पेशेंट यहाँ पर बेड रिडन कंडीशन में रहता है तब तो वन पीस है, बिकॉज वो रिपोजिशन नहीं हो सकता बैग. और जब आप पेशेंट को वापस से अपना नॉर्मल कंडीशन में नॉर्मलाइज करनी है लाइफ, देन द बैग कुड बी रिपोजिशन विद द टू पीस सिस्टम. So this is general categorization of bags, one piece and two piece. Now since the evolution, this is the bag you had seen in the hospital. This is a spiral adhesive. Two things are there. One is skin care layer and other is adhesive. So both are important, and there is in Coloplast there is a perfect blend of both. That's why after the stoma making and post to that, क्या हुआ? And after that stoma marking and before the anastomosis, you need a clean and clear skin for anastomosis. So this is what is required. Skin care layer is also an important one to make clearer skin available to you at the time of anastomosis. Now sir, there is not only the bag which is required. You may have seen, because the stoma has peristensial movement, or sometimes it is prolapsed or retracted. So there is a need of convex base plates or two-piece bag system, or there is the upgraded bag where there is not a single layer, there is an upgraded layer of triple layer hydrocolloid. So आपने थर्ड ईयर में या सीनियर सर्जन्स ने देखा होगा यहाँ पर कि जब पेशेंट का स्किन एस्कोरिएट हो जाता है तो वो हाइड्रोकोलाइड की एक ड्रेसिंग लगाते हैं अकबर उस पर. सो इन दिस बैग देयर इज ऑलरेडी टू लेयर ऑफ हाइड्रोकोलाइड्स, वी कॉल इट सेंसुरा मियो. इस बैग के होने की वजह से इनकेस अगर लीकेज होता भी है तो पेशेंट की जर्नी में वो अर्ली स्टेज में वो रिकॉग्नाइज नहीं कर सकता है कि उसका लीकेज हुआ है कि नहीं हुआ है. तो हाइड्रोकोलाइड लेयर उसको हेल्प करती है कि अगर इनकेस लीकेज होता भी है तो 2-4-6 घंटे तक वो मैनेज कर सकता है. बाय द टाइम ही कैन गेट रियलाइज कि बैग लीकेज हो रहा है. एंड द इम्पॉर्टेंट अदर थिंग्स आर लाइक पेस्ट, बिकॉज स्टोमा का जो वर्ल्ड ऑस्टोमी काउंसिल का रिकमेंडेशन है, स्टोमा के साइड से 1 mm एक्स्ट्रा कट करना है, ताकि पेरिस्टेशियल मूवमेंट की वजह से ना तो ट्रॉमा और उसमें और ना ढीले होने की वजह से लीकेज हो. तो पेस्ट एक सीलिंग इफेक्ट देता है. एडिशनली देयर आर सो पेस्ट आपने देखा ही होगा. एडिशनली देयर इज एन बैरियर स्प्रे. बैरियर स्प्रे इज नन बट इज अ प्योर 95% पेंटासिलॉक्सेन एंड डाइसिलॉक्सेन मिक्सचर which provides a layer of silicone over the peristomal skin area. सो इसकी वजह से इनकेस अगर लीकेज होता भी है तो सिलिकॉन का एक लेयर बन जाता है उस पर, एंड डायरेक्टली एफ्लुएंट जो है ना स्किन के कांटेक्ट में नहीं आता और उससे एस्कोरिएशन नहीं होता. सो देयर आर अदर प्रोडक्ट्स लाइक रिमूवर स्प्रे विच न्यूट्रलाइज 87% ऑफ एडिशन फोर्सेस. इसकी वजह से बैग आसानी से निकल जाता है. सी टेप्स आर देयर इन लाइन, वो बेस प्लेट को सिक्योर रखते हैं. सो दीज आर द थिंग्स Akbar इज गोइंग टू मैनेज. मेजर ऑफ द थिंग्स आर अवेलेबल इनसाइड द हॉस्पिटल. Whatever is not available, they are available in the Amrit. तो पेशेंट को कहीं बाहर नहीं भेजते हम लोग. अकबर का साथ अच्छी चीज़ ये है कि अकबर कोई चार्ज भी नहीं लेते हैं पेशेंट का. So this is a very short presentation from my side. Sir, anything I could be helpful तो आप, I am open for conversation, sir. Thank you so much, sir.
our 4-day academic program.
Okay.
Bolu, this concludes our YouTube में record हो रहा बेटा.
Good afternoon, sir.
Sir. Sir को बोल दो.
पीछे करिए पट्टे अरेंज करिए